Do we have Dr. Swati in the hall?
Hello, yes. Who's there?
Okay, hello, Dr. Swati. A very good morning. First of all, a very good morning to all of you, all the panelists that we have today, the speakers. So, Dr. Swati, would you... Hello?
Hello,
Yeah.
yes.
So, Dr. Swati, just quickly with the flow, would you want me to introduce or would you want to immediately
So
begin?
we will be introducing. Thank you.
Okay, thank you.
Yeah, it's Dr. Rohit and me on dais, so we'll be introducing.
Okay, sure.
Okay.
Thank you.
क्या बात आ गया यार कोई एक जना भी देगा होगा ना तो मेरी तरफ से उसको एक अवार्ड दिलवा देना यार Dr. Meenakshi, Dr. Tan, Dr. Sharon, Dr. Kumudni, Dr. Sachin, how are you everybody? We'll just be starting. And thank you very much for agreeing to be a part of this meeting today. It's our foundation day and it's being celebrated over 3 days. We have 3 days of scientific sessions. Tomorrow is live surgery. So thank you again for making this program an absolute success. नहीं आती लाइव शो बेस्ड Shraddha, will you tell us when we are live?
Yes, sure, sure.
Thanks.
Yes.
I'm sure you're aware of the order. Dr. Meenakshi goes first, followed by me. And I guess as people join, Dr. Madhura is supposed to go after that. Sachin, Dr. Sangeeta, Dr. Sharon, Clement, Dr. Kumudni, and Frank Martin. Of course, Dr. Frank Martin has the Dr. Prem Prakash oration, which will be the last, but probably the icing on the cake, the jewel on the crown. Hello, Dr. Sangeeta. Dr. Sachin and Dr. Sangeeta are, of course, alumni of RP Center.
Hello.
I have with me Dr. Swati and Dr. Rebecca, my colleagues here at Pediatric Ophthalmology and Strabismus and Neuro-Ophthalmology section.
Morning, everyone. Hello. Pastor, good evening at US.
Yeah.
Yeah.
Doctor, so sorry to interrupt you, but we are live now.
Good morning, everybody, and of course, good afternoon and good evening at various parts of the world. We are live all over the world on YouTube and Facebook. And welcome to the 55th RP Center Foundation Day Scientific Program. We are starting the Strabismus and Neuro-Ophthalmology update session. And it's an absolute proud moment with us to have such a wonderful panel of experts who are going to talk about some very interesting topics. We will start immediately, and Dr. Meenakshi would be the first one to talk on amblyopia management. I'll request Dr. Swati to please introduce Dr. Meenakshi for us.
Hello, good morning, everyone. So Dr. Meenakshi is a pediatric ophthalmology consultant at Shankar Nethralaya, Chennai. She has done her residency from PGI Chandigarh and University of Louisville, Kentucky. She is also the Director of Academics at Shankar Nethralaya and has multiple publications and vast experience in field of pediatric ophthalmology. She would be talking about the basic of pediatric ophthalmology, which is amblyopia management. Dr. Meenakshi, please. You may share your slides.
Good morning. I hope my slides are visible. I'm so
Yes,
honored. I'm so honored to be here. My dear friend Rohit, Professor Sitial. I didn't realize I'm part of a panel of such esteemed speakers. So I'm really very honored to be here. And thank you so much for the invitation. Now, Rohit, when he gave me this talk, he said, make the postgraduates learn amblyopia management. They're just not doing it properly. So that's going to be the focus of my talk. It's really geared towards the postgraduate. So it's going to really cover only the basics. So I also apologize for the lack of the background. I just couldn't locate it. So without any further ado, so I have no financial disclosure. And the learning objectives of my talk is going to be a quick look at amblyopia prevalence. Why are we even talking about it? A quick recap of terminology, how to use evidence to manage amblyopia, a few case examples, and what is not covered in this talk are adult amblyopia management and use of technology. For the sake of time, why should you know how to manage amblyopia? Because it is an important public health problem. First of all, it occurs in children. There's a lifelong reduction in vision, and amblyopia and its treatment affects the quality of life. And if you look at population-based studies, the prevalence seems to be in young kids, 0.7 to 1.9%, and school-going children a bit higher. And bilateral, of course, is less common. So a quick recap of terminology. And what are we looking at? So we're talking about strabismic, anisometropic, where there's anisometropia is the factor, ametropic, where there's bilateral refractive errors, and then, of course, visual deprivation when we're talking of ptosis or cataracts or, occlusion amblyopia. Okay, so we're going to jump right into management. So before we go into management, I just want to say, what's the crux? The crux is A, you find a visual acuity deficit, plus you find a likely cause, voila, then you have the amblyopia diagnosis. But to find out all these things, you need a list of tests, a battery of tests, clinical tests that you have to do to make that diagnosis. So you have the Bruckner, which is a good screening test for strabismus, binocularity stereoacuity testing, which again gives you a clue, really is there amblyopia or not, fixation testing, visual acuity testing, the most important step, ocular alignment testing to find out strabismic, of course, cycloplegic refraction, and subjective testing, if necessary, to uncover bilateral ametropic or anisometropic amblyopia, and anterior segment and fundus exam to look for causes of visual deprivation, and also to look for other causes that may be the cause for reduced vision. It may not be amblyopia at all. So if the visual acuity is down, but there is no squint, no anisometropia, no media opacity, no structural anomaly, search for another cause. Okay, so can amblyopia coexist with a structural lesion in the eye? Of course it can. Optic nerve hypoplasia, myelinated nerve fibers, retinopathy of prematurity, all these conditions also may have a component of amblyopia. And so that component needs to be treated. Okay, let's say 5-year-old male, OS esotropia, vision OD seems to be quite okay, left eye, count finger at 2 meters. Okay, that's what the kid looks like. Haha, you're getting excited. Could this be strabismic amblyopia? But before you decide that, make sure you look at the fundus because there may be some other explanation. Okay, whenever you talk of management, it's nice to know how to prevent amblyopia. So vision screening is the key. Identification early. Amblyopia treatment is very successful in young children, but it's also successful in older children and teenagers. So do screen and treat everybody. So this is something I took out of the AAO preferred practice pattern. And here it basically says which vision screening test is age appropriate. And this is a wonderful resource. And as you can see, as the kid gets older, you'll be able to do subjective testing. Now, okay, moving on to management, really, how do we know what we know? We know all this thanks to PDIG, Pediatric Eye Disease Investigator Group, which was established in 1997 to conduct clinical trials in pediatric ophthalmology. And so amblyopia treatment studies are really large and it can be quite daunting to look at them. There are 25 in number when I last counted. But after you go kind of through the test, but you come back to your patient, and this is what you want to know. Is the amblyopia unilateral or bilateral? Which eye is the amblyopic eye? What is the severity? What is the cause? These are the basic things that you need to know before you start any treatment. So this is the PD severity scale of amblyopia. What do we mean by severe, moderate, and mild? And so severe is like less than 6/30, moderate is 6/12 to 6/30, and mild is better than 6/12. So when I look at the PDIG, even at the table, it can be, oh my God, what's happening? So here I thought it's an easy way to look at the ATS. So you first see what exactly did they study? Randomized trial comparing occlusion versus pharmacological therapy for moderate amblyopia. And what is the age group they looked at? 3 to less than 7 years. And how long did they follow the patient? 6 months. What did they find? Vision improved in both groups. So this is how you make sense of the ATS. Okay, so what is the strategy? Correct the cause of visual deprivation, correct refractive error, if any, and promote the use of amblyopic eye by blurring, occluding the fellow eye. So before you start, you need to make sure you've noted a few things: age of the child, visual acuity, adherence to previous treatment, because compliance is a big deal. Physical, social, and psychological status of the child. What is the goal of treatment? Equal vision. So what do we have? We actually have many things that we can offer the patient. Number one, top up there is refractive correction. Then you have occlusion, pharmacological treatment, and a few others, which I'm not really going to talk about in great detail. So when we talk about anisometropic amblyopia, now what did PDIG say? Well, they said 3 to less than 7 or 7 to 17. They looked at both groups and they found that 18 weeks of spectacle wear, 2/3 children improved by 2 lines. And look at even the older group, 25% improved by 2 lines. And the same holds true for bilateral ametropic amblyopia and strabismic amblyopia. So what are we going to say? give glasses. If the glasses are indicated, spectacles are indicated, give spectacles. And this whole process of first giving spectacles and then calling the patient back is called refractive adaptation. Okay, we've given spectacles, patient has come back. What are we going to do for next? We're going to look at patching or occlusion. It really works by reducing the neural signals from the fellow eye. The adhesive patch that is applied directly to the skin surrounding the fellow eye is the best option. Spectacle mounted or frosted glasses, sometimes the child may peek and the whole point is lost. How much occlusion? Well, what did ATS find? In severe amblyopia, 6 hours was found to be as good as all waking hours. And that's what we used to do in Iowa. We used to do some crazy amount of patching. We used to do all waking hours patching. 6 hours is good enough. In moderate amblyopia, 6 and 2 hours gave the same improvement. What could be the problem? Of course, it's problem. Occlusion amblyopia, skin irritation from the patch, new onset strabismus. The child needs close monitoring to prevent accidents and can be pretty stressful for children and caregivers. So let's look at a case. 6-year-old boy, right eye exotropia, 660 vision OD, 66 OS, cycloplegic refraction, fundus are all really nothing much is going on. Affected eye is the right eye. It's strabismic, it's severe. So how will you manage? Aha, we have ATS to the rescue. And so occlude the left eye for 6 hours per day with 1 hour of new work. Case 2, 6-year-old with left eye inward deviation since 4 months, right eye 612, left eye 636. Cycloplegic refraction shows fair amount of anisometropia, hyperopia. The rest is normal. Again, left eye, strabismic and anisometropic. It's severe. What do? Refractive adaptation, as we talked about, give spectacles. Patient returns after 12 weeks and vision is improved. Right eye 6.6, left eye 6.18. Now we just come under the moderate amblyopia and you can do 2 hours of occlusion of the right eye. Case 3, 4-year-old girl, left eye squinting since birth, vision is 6.6, 6.24. Rest of the exam is normal, not compliant with patching. What are we going to do? Now, penalization to the rescue with atropine 1%, strabismic, anisometropic combined, moderate and mild more, but severe cases too responded to atropine, and children who are hypermetropic in the non-amblyopic eye. Now, daily dosing they found in ATS was as effective as patching, weekend dosing as effective as daily. So what are we going to do? Weekend dosing. And that is what ATS showed us, that weekend dosing can improve vision. And so a few things about penalization. It can be the first line of therapy after eyeglasses if there is no improvement. It's particularly good in latent nystagmus, occlusion failure, or as a maintenance treatment. How does it work? Cycloplegia optically defocus the fellow eye. And transient reduction of vision in the fellow eye could be a problem. They also found some new onset esotropia, photosensitivity, conjunctival irritation. Remember, with atropine, the systemic side effects: fever, tachycardia, dryness, delirium. What are we going to do? Also, areas with increased sun exposure in children less than 3 years of age, maybe avoid penalization or be very careful. Reduce systemic absorption by digital pressure over the punctum and the lacrimal sac. And that is how we reduce the systemic side effects. So coming back to our case, you remember, what are we going to do? Penalization of the right eye, because this child was not compliant with occlusion. So we have something to fall back on. When do we do surgery for amblyopia? Oh, only if there is visual deprivation because of cataract or corneal opacity, or the ptosis is significant, or you need to clear a non-clearing vitreous hemorrhage or debris. And of course, if there is a subluxated lens in the visual axis. Will you operate on strabismus before amblyopia treatment? No, no, no. I hope postgraduates, you've understood. Now, the last slide is more on deprivation amblyopia. It is least common type, but the most severe form, the most difficult to treat. Unilateral tends to be worse than bilateral. Use your judgment as to how much to do and how long to do, because ATS really didn't give us too many guidelines. Now, I am not going to talk much about them, but there are adjunct to treatment, that is adjuncts to the occlusion, penalization, only after you have tried them. What do we have? Binocs, we have REMED, which is virtual reality. We have Revital Vision, which is perceptual learning. And of course, our RP Center alumnus, Dr. Santan Gopal, has come up with OrthoPtech, which is a magnocellular pathway stimulator. So we have a lot of things there, but after traditional patching and penalization has been tried. Now, thank you, Team RPC. I am again very honored to be here, and thank you for giving me this opportunity.
Thank you, Dr. Meenakshi. That was an excellent talk. I hope our PTs have learned something out of it and they'll remember it. So I now invite Professor Rohit Saxena, who of course does not need any introduction. He is currently head of the strabismus and pediatric ophthalmology and neuro-ophthalmology services at the center. So he will be talking about the management of third nerve palsy. Over to you, sir.
Thank you, Dr. Swati, and thank you again for the esteemed speakers, panelists, and audience who are logged in here today as part of the RP Center Foundation Day celebrations. I'll be talking about management of third nerve palsy, and it's been our good fortune to, over many years, evolve a kind of understanding of the management of third nerve palsy by a lot of different kind of options that we were given the opportunity to try. So complete third nerve palsy particularly can be quite a challenge because 4 of the 6 muscles are affected, and you really have very little options as far as modifying or strengthening muscles are concerned. So essentially breaking down the options in front of managing third nerve palsy, you have a supramaximal resection procedure of the horizontal recti, which would be either of the same eye or of the other eye, as we would see the options. Now, you could do a lateral rectus periosteal fixation with a large medial rectus resection or plication. You could do a globe anchor to the medial orbital wall with a large lateral rectus recession, or you could, what has been recently being described as the medial transposition of the lateral rectus of the involved eye. So if it is an incomplete third nerve palsy, essentially a medial rectus underaction is there. However, the eye is moving past midline. You can see a certain amount of adduction. You could plan a recess resect procedure, a supramaximal recess resect procedure of the ipsilateral eye, and you can see you can get moderately good results. What benefit you get from this surgery is that you are able to preserve the ocular motility. So the adduction component still remains, adduction and abduction remains, and you can use that to get a better outcome in the horizontal gazes. The other eye can be used if there is an aberrant innervation. So in conditions where there is an aberrant innervation, a pseudo-von Graeff's sign, you can see that the lid gets lifted on attempted adduction. The medial rectus fibers are misdirected to the LPS, and on attempted adduction, the lid gets lifted. And this can be used by operating the other eye. So you can not only get the alignment, but you can also get improvement in ptosis. So this is a very useful procedure in aberrant innervations. Of course, one, the patient has to be willing for it. And the second important thing is that the FDT of the involved eye lateral rectus should be free. So if it's a tight muscle, the lateral rectus is tight, or because of a long-standing exotropia, you will have to operate the involved eye. But just in case the FDT is free and the patient is willing, you could think of operating the other eye. In cases where there is virtually no movement, you can actually remove the lateral rectus and do a large a lateral rectus periosteal anchoring, which is essentially an infinite recession of the lateral rectus. So you do you just eliminate the lateral rectus functioning on the globe and do a MR plication or resection, and you can get some fairly good alignment. So in this case, you can see there is a large exotropia. There is very little amount of movement you can see, but there is some movement, and you can see post-operatively, you can get some fairly good alignment. However, if there is no medial rectus function, in those conditions, it's not really beneficial, because even a large medial rectus resection or plication is not going to give you a strong adducting force that can bring the eye on alignment, even if the lateral rectus has been removed from the picture. So despite a lateral rectus periosteal fixation and a very large MR resection, we still do not get a good alignment in primary gaze. So what do we do in these cases where there is zero function of the medial rectus? So we had two major options in front of us. One is the globe fixation to the medial orbital wall, which has evolved over multiple years, and we have some very, very good results with this procedure. And the other is the transposition of the lateral rectus medially. So this was the medial wall periosteal anchor. We use the precurruncular approach, which we find to be very fast, to be virtually bloodless, and gives us a very good approach to the medial orbital wall. So this is the approach we use. We use a precaruncular opening. We enter the medial wall, reach the medial wall periosteum, pass the non-absorbable ethibond sutures, bring them out from adjacent to the medial rectus and tie them adjacently there. So these are some of the results that we showed of the medial periosteal wall anchor. And this is a very, very useful surgery. And we have now been doing it in multiple cases, which have been operated multiple number of times by various procedures. So these are cases you can see very large third nerve palsy, exotropia, and post-operative very good alignment. Of course, you lose the eye movement if there is any, even vertical movements, if there was some, get lost because the eye is kind of fixed in primary gaze. The lateral rectus transposition to the medial side was described long back, and Gokigit's paper actually in 2013 actually brought interest back into this. The main problem with the described technique was that it was shown to be less than effective, and a lot of residual exotropia was observed, and one would require to do a medial rectus resection along with that. The modification we did was that we added a posterior fixation suture to the transposed half slips of the superior and inferior slips of the lateral recti that were transposed medially. The important thing to remember is when you're splitting it, your split should go far back beyond the globe. Otherwise, it kind of causes pressure onto the posterior part of the globe, causing effusion in the post-op period. So this is again our results of this split LR to MR transposition. Again, we add a posterior tenectomy of the superior oblique, which help in the transposition of the superior split, along with eliminating the abducting force of the superior oblique, giving us better alignment in primary gaze and also in down gaze. So again, another patient in which we did LR to MR transposition with posterior tenectomy of the superior oblique. If there is associated vertical deviation, like in this case, there is third nerve palsy with hypertropia, we can do a complete muscle transposition. So the lateral rectus was transposed medially through the inferior root. So the whole muscle was transposed and was not split. So you get a very good vertical effect along with a moderate to good horizontal effect. In these cases, we found the adduction force of the lateral rectus transposed medially was not so much, and you would require a medial rectus resection or plication along with this. Another case, you can see that there was hypotropia along with the exotropia, and the lateral rectus was shifted medially from the superior root under the superior rectus superior oblique along with the posterior tenectomy of the superior oblique. You can again see good vertical correction. Because these were fixed procedures, we described an adjustable transposition where we brought these slips medially and crossed them underneath the medial rectus and tying them on an adjustable suture, making the process adjustable, because sometimes we found that there was a residual exo or vertical deviation which could be corrected by doing this. So again, you can see adjustable transposition. So small vertical deviations could be corrected by adjusting the different slips of the two vertical to the arm. So here you can see a small amount of hypotropia with exotropia, which was corrected by the differential tightening or adjustment of the crossed fibers. So just to summarize, there are many factors that affect surgical decision-making. Management of third nerve palsy, we now have increasing options. First, see whether it's complete or incomplete. How's the medial rectus functioning? See for any aberrant regeneration that can be used. If the patient is, of course, willing for other eye surgery, finally use appropriate surgery, because we get graded responses for each surgery. I use LR to MR, particularly when there are vertical deviations, and periosteal anchor if the force duction test of the lateral rectus is positive, or in cases of resurgery. Thank you very much for the opportunity and the attention.
Thank you, sir. Thank you. May I now, we will take the questions at the end of the session to maintain the time. And may I now request Dr. Rebecca to introduce Dr. Madhura Tamharkar.
Well, she is the Associate Professor in Ophthalmology in the She Eye Institute, Philadelphia, Pennsylvania. She's done her MD from the University Hospital in Bombay. And later she did a research fellow in glaucoma at the Wills Eye Hospital and a fellowship in neuro-ophthalmology from the She Eye Institute. Now she has several publications, including the book on prism therapy in strabismus and amblyopia. So now I would like to invite her for her talk in the advanced strabismus for the non-surgeon.
I'm sorry, I think she is having some connection issues and would be joining shortly. We'll go on to the next talk, which is by Dr. Sachin Kedar, who will be talking. So we now move on to the neuro-ophthalmology section. We'll be talking on lesion localization in neuro-ophthalmology. Dr. Rebecca, if you could please introduce our past alumnus, Dr. Sachin.
So Dr. Sachin Kedar, he's done his MBBS and MD from AIMS, New Delhi. And he's completed his residency at the University of Mississippi Medical Center in Jackson and fellowship at the Emory University School of Medicine in Atlanta. Now, currently, he's the professor of ophthalmology and neurology at Emory University School of Medicine. He also is the vice chair for education in the Department of Ophthalmology at Emory and also chairs the NANOS Curriculum Committee. So I would like to invite Dr. Sachin Kedar for his talk on lesion localization in neuro-ophthalmology.
Good morning to everybody in India. Can everybody hear me clearly?
Yes, Sachin, go ahead.
Well, thank you, Rohit, and thank you, Dr. Titial, for the kind invitation. This is a lovely program that you've set up for the Foundation Day. I remember the Foundation Day quite different from when I was there, but this is a nice twist to it. So the objectives of today's talk is to explain the neuroanatomic principles for localization of visual pathway lesions based on clinical examination. So you're all familiar with the visual system. To me, it is the best studied neurological system that is available. It starts with the visual apparatus comprising of the eyeball, and then you have different pathways and centers, the afferent pathways, the primary visual cortex, the association cortices, the efferent pathway, and the pupillary pathways. So neuroanatomic localization is where we can localize a lesion to somewhere along these routes. So when I look at a patient with a neuro-ophthalmic problem, this is a basic schema I use in order to localize the lesion. The image has to be captured with clarity by the globe and then transmitted with high fidelity to the primary cortex, from which streams of information then go on to the association cortices in the parietal and the temporal lobe for there to be some action, either in the form of verbalization or understanding. The eyes are guided to the target by precise eye movements, which are programmed and executed by the eye movement centers and the pathways in the brain stem. The entire process is underpinned by cognitive processes called attention. So this is the standard examination of the eye, and to the audience, you are all very familiar with this. But as a neuro-ophthalmologist, when I see a patient, I may have to do certain additional maneuvers. For example, for the afferent pathway, I may get contrast sensitivity, I may get ocular imaging, ocular electrophysiology, or neuroimaging. For the efferent pathways, besides fixation, alignment, and range of movements, I will test the optokinetic nystagmus, the vestibulo-ocular response, saccades, pursuits, vergence. A relevant cranial nerve examination is always critical, and when needed, neuroimaging for precise localization of the lesions. It gets a little tricky when you go to higher order of visual dysfunction, and these are things that I commonly use in clinic. I'll have the patient read. I can examine the patient for visual neglect, simultanagnosia, constructional apraxia, and prosopagnosia, which is a difficulty recognizing faces. So in the next few slides, I'm going to use case examples to go over this whole process, and which I hope will be very helpful to the postgraduates in the audience. So case number one is simple. It's a 47-year-old physician who presents with reading difficulty for 1 year. He claims to have difficulty reading fine print, and he has to enlarge the font and compute and smartphone to read. No significant past medical history. He goes to his ophthalmologist who does a basic eye examination, and the only abnormality is a poor visual acuity of J10. And by now you've correctly identified that this is a problem with image capture. So the image is blurred, probably because of presbyopia. So refraction is performed, and appropriate near add is given, and distance and near acuity now improved to 6.6 equivalent in both eyes, and you have a happy patient. Case number two is a 60-year-old male with acute painless progressive loss of vision in one eye, the right eye, for about 5 days. There is no headache or any other neurological symptoms. Past history is positive for sleep apnea, hypertension, and he's a chronic smoker. The basic eye examination now shows some abnormalities. There's reduced visual acuity, color vision, inferior field loss, and a right RAPD. Fundoscopic examination shows a right optic disc edema. And when you go along the schema, you now know that the problem is one of image transmission. This is an optic neuropathy that prevents the image from being transferred from the globe to the brain. So this is a schema for disc edema. And as you have, as I've summarized, this is a painless unilateral loss of vision with disc edema. And in this age group with this particular patient, the most likely etiology is going to be ischemic. And so you've diagnosed a right anterior ischemic optic neuropathy. Case number three is a 66-year-old patient with a 2-week history of ptosis of the right eye. And 2 weeks prior to presentation, he had intermittent double vision. He has a pressure sensation behind the right eye and denies any other neurological symptoms. You examine the eye and find that there is complete ptosis of the right upper eyelid. There is no proptosis. You open the eyelid, find that the eye is in a down and out position, and the pupil is about 5 millimeter and fixed in the right eye. Here, when you go back to the schema, the problem is one of eye movements. The patient is not able to move the eyes or the eyelid, and this is a third cranial nerve palsy. As I alluded to earlier, you now have to examine all of the cranial nerves, and when it was performed, this patient had absent corneal reflex and anesthesia in the V1 territory. So going back to the principles of localization, you know that the third and the fifth cranial nerves come together in the cavernous sinus in the superior orbital fissure. And so you will appropriately image this patient with an MRI, and there is a large middle cranial fossa meningioma that is impacting the cavernous sinus and the superior orbital fissure. And the patient is then sent for neurosurgical procedure to take out that meningioma. Case number four. This is a 66-year-old patient who presents with visual difficulty, says that there is difficulty reading, frequent falls. Family says that the patient runs into walls as if they are blind, but there are no other significant problems. Family says maybe the patient has some memory problems as well. You do a basic eye examination, find that visual acuity for distance and near is 6.6 in both eyes. Color vision, however, is absent, including the color plate, including the control plate. Stereo acuity is absent, and on confrontation visual fields, there's a left homonymous heminopia. The rest of the eye examination is normal. You now think the afferent system seems to be okay, the efferent system seems to be okay. So where is the problem? The problem seems to be in the association cortex or in attention. So as you know, the association areas, there is the spatial processing that occurs in the parietal lobe, and there is object processing that occurs in the temporal lobe, or the so-called Ver and the Watt streams. Next step, assess reading, and I hope you can hear this. The big box on the table. The two friends. Did not know what time to play, or the play would start. So this is a patient who was previously an high school English teacher. So you can see that her reading was significantly impaired. Next, you test for neglect phenomenon. So this is a alphabet cancellation test where the patient is asked to cancel all the C's and E's in a group of letters. And you can see the patient misses everything on the left side. So this is a neglect phenomenon. When you draw lines of various orientation and ask the patient to bisect it, you can see that there is a bias towards the right side. Patient was asked to look at this complex picture and comment on what's going on in this picture. And the patient was able to only focus on the mother cleaning the dishes and completely ignored the children who were being naughty on the left side of the picture, indicating that there was simultaneous. Patient had a cursory examination using Montreal cognitive testing. This is called alternate trails making. It tests executive function, and the patient was simply unable to connect the numbers to the letters in an alternating fashion. Patient was unable to copy the cube, and this is constructional apraxia, or draw a clock face. And as you can see, they only wrote 1 to 6 and completely ignored everything on the left side, indicating severe spatial deficit. An MRI of the brain was performed, which was reported to be normal, but here, for the sake of clarity, I draw lines separating the anterior and the posterior parts of the brain. And as you can see, there is significant atrophy of the posterior parts of the brain, and that gives you your diagnosis of Alzheimer's disease with a posterior cortical atrophy. So to summarize, a knowledge of the anatomy and functioning of the visual pathways is critical in diagnosing neuroophthalmic conditions using clinical methods that you would use routinely in clinical practice. And whenever your patient cannot be explained by a lesion of the afferent or the efferent system, always think of cortical visual disorder and use simple tests that can prove the point to you. So thank you for your attention, and I'll take questions probably at the end of this symposium with the others.
Thank you very much, Sachin. That was an excellent presentation, giving us exactly how we need to work up every patient we see with even suspected neuroophthalmic conditions. So a lot of patients are just referred with very vague complaints because it's only the neuroophthalmologist who applies his brain to see what's wrong with the patient's brain. And so thanks, Sachin. We'll just go on to the next talk, which is by Dr. Sangeeta Khanna, another RPC alumni. She'll be talking about cortical blindness. And Dr. Rebecca, if you could introduce Dr. Sangeeta, please.
Thank you, sir. So Dr. Sangeeta Khanna, she has done her fellowship in neuroophthalmology, and she's also in the American Board of Ophthalmology certified ophthalmologist. Now she's completed her medical school and ophthalmology residency at RP Center, AIIMS, New Delhi, followed by a second ophthalmology residence at Washington University in St. Louis, US. She obtained the fellowship in neuroophthalmology at Case Western Reserve University in Cleveland, Ohio, US, and she's currently the associate professor in ophthalmology at Kellogg's Eye Center, University of Michigan, and a fellow member of NANOS. So I would invite ma'am for her talk on cortical blindness.
Thank you so much for the kind introduction, and thank you to the RPC team for putting this together and inviting me. I have fond memories of being an RPC, a resident at RPC and a senior resident as well. So thanks to all my colleagues and teachers. So I want to start my talk, which is talking about cortical blindness. And let me make sure I can advance. Yeah, so I'll start with a case presentation. So we have a 59-year-old female who was admitted with a headache and altered sensorium, but her main complaint was that she could not see. So a bilateral vision loss, quite acute. And the only past medical history that she had was a history of hypertension. And so when you examine her in the hospital setting with a near card, her vision is symmetrically reduced in both eyes at 2800. Her visual field is generally restricted. She can track your face, so her appear intact, and the pupils are equal and briskly reactive. Anterior segment and the fundus exam is normal. So you have a patient who cannot see and an ophthalmologist who cannot see anything obviously wrong, because as ophthalmologists, we are used to being able to see the disease. So what are we dealing with here? Is it a retrobulbar optic nerve disease? But with a very brisk pupil reaction, that is less likely. Then is it a non-organic visual loss or a psychogenic visual loss? But before we jump to that conclusion, we need to investigate the retrogeniculate pathway and with an MRI, with and without contrast of the brain. So the brain MRI, as you can see here, shows T2 flare weighted on this T2 flare weighted sequence, hyperintensities in bilateral occipital lobes. And this is edema of the pathway, which is going from your geniculate, from the retrogeniculate to the calcarine cortex. So this is interrupted on both sides. So this is not an infarct, as you can see here, because on the diffusion, there is no diffusion restriction. So this condition is called posterior reversible encephalopathic syndrome, or PRES, and just has edema of that the posterior part of the cerebral hemisphere. So this patient had cortical blindness, which is secondary to PRES, and it was caused by uncontrolled hypertension. She had missed taking her medication for a few days, and with optimal control of blood pressure, her vision improved just over 3 days to 20/70, and further later on. So cortical blindness is a blindness which occurs due to striate cortex damage, but also the term is used to include the geniculo-calcarine pathway. And there are several causes of cortical blindness. The one we saw was PRES, which is under the subcategory, under the broad category of vascular causes. So vascular causes would include bilateral strokes, or edema due to uncontrolled hypertension or preeclampsia, etc. Toxic agents such as tacrolimus can cause PRES. Contrast agents used for cardiac and coronary angiography are known to cause cortical blindness, again, because of the insult to the same pathway. Infections, even including COVID-19, has been reported to cause hemorrhagic encephalitis and cortical blindness. Metabolic, such as hyperglycemia, hypoglycemia, hepatic encephalopathy, degenerative, just as exemplified by Dr. Kedar's case of Alzheimer's dementia, where there is posterior cortical atrophy, can go on to develop decreased central vision as well. And that would be a degenerative cause. And status epilepticus and tumor are other additional causes that can cause cortical blindness. So this, looking at an example of bilateral occipital infarct here, here you can see the diffusion restriction. There is the bright on DWI, and a corresponding dark on ADC. And this is just the CT showing the hypo attenuated lesions of the bilateral occipital infarct. So this is quite obvious, a cause of interruption of that the striate cortex and the geniculo-calcarine pathway. And of course, this has to be bilateral to cause cortical blindness. But and these are the patients which would show on field testing very restricted fields, but they have certain features which can be helpful. And the features are that these are superimposable deficits between the two eyes, so they are very congruous. If you look at this side, which is this will be superimposable. There's a degree of macular sparing here. And there is a larger macular sparing on the other side, causing this vertical step off. And this is a sign of that these are cortical, bilateral cortical visual fields. But the neuroimaging findings may not always be so obvious. So we have subtle neuroimaging findings causing cortical blindness. So one has to be very careful with the patient with cortical blindness in looking at this carefully. Here we have an example of hypoxia. This is a hypoxic encephalopathy where just you may see the cortex only lighting up on diffusion. This is a patient with hypoglycemia where on a flare you might see hyper intense and thickened cortex. It's a very subtle deficit. And this is an example of the posterior cortical atrophy where again can easily be missed if not paying attention, careful attention looking for it. This is a patient with CJD, a Creutzfeldt-Jakob disease, a Hayden-Hand variant. Again, a disease where it can be easily overlooked on imaging. This is a flare signal, very limited findings on flare, but there's a ribboning on the diffusion imaging, which is characteristic of this condition. So the key points with this cortical blindness to be remembered are that the visual deficits may be the predominant symptoms. So though this is a cerebral or a cortical problem, they may come to the ophthalmologist with just vision problems. They may not have other altered sensorium or other deficits. And they often present with bilateral symmetric vision loss. And sometimes the patient may not even be aware of their visual deficits, and that's called the Anton syndrome, based upon the first described patient by Anton, where it's a kind of an anosognosia, where the patients are not perceptive of their own deficits. On examination, the key points are that the pupil reflexes are normal. Of course, the fundus exam, the anterior segment exam is normal, and the pupil reflexes are normal because the pupil pathway diverges after the lateral geniculate nucleus. And therefore, the patients can be misdiagnosed as non-organic vision loss, and therefore careful examination with other tools such as the optokinetic nystagmus drum, a mirror would show no response in these patients, whereas a patient with a feigning blindness or non-organic vision loss, you would be able to elicit response. There'll be a loss of reflex, a blink to threat as well in these patients. And the visual field pattern, as discussed before, should also guide you to the cortex. These patients may also have distinctive visual symptoms in association with vision loss, such as visual hallucinations, which are often unformed flickering lights and shapes in the hemifield or in bilateral hemifields. After images, patient may describe patterns or cerebral metamorphopsia, a distortion of the images, in addition to subnormal vision. These are the references that I would recommend as useful references for the postgraduates here, but I'll be happy to answer questions later with the group. Thank you so much.
Thank you, Dr. Sangeeta. Thank you very much. Very nice presentation and extremely interesting with wonderful images. We'll go on to the next talk by Dr. Sharon Tao, who will be speaking on red flags in neuro-ophthalmology. I would request Dr. Swati to please introduce Dr. Sharon for us.
Dr. Sharon is head of neuro-ophthalmology department at SNEC Singapore. She has graduated in medicine from University of Sydney and completed her residency in ophthalmology in Edinburgh. She did her fellowship training in neuro-ophthalmology at Wilmer Eye Institute, Baltimore. And since 2006, she is heading the Department of Neuro-Ophthalmology in SMC. She has multiple publications, including book chapters in neuro-ophthalmology, ocular manifestation of systemic diseases atlas, as well as also neuro-ophthalmology section of clinical ophthalmology. Her research interests include epidemiology studies of neuro-ophthalmologic conditions in Singapore, specifically optic neuritis, ischemic optic neuropathies, and oculomotor nerve palsies. Over to you, Dr. Sharon. Thank you for joining us.
Hello, can you hear me?
Yes, your slides are also visible. Please go
Okay,
ahead.
great. All right, so I'm sorry, I'm trying to get back. Okay, greetings from Singapore. And I'm sorry, it was my fault for not sending in my updated CV. So I'm no longer the head since 2019. So I'm, as you said, a neuro-ophthalmologist from Singapore National Eye Center, and I would like to thank the organizers very much for inviting me to speak at your conference, and congratulations to all of you as you celebrate your 55th RPC Annual Foundation Day. I'll be speaking on red flags in neuro-ophthalmology, in the hope that the couple of cases that I'll be showing may serve as tips in your clinical practice. So my first case is that of a 79-year-old female Chinese who presented to another hospital for bilateral cataract surgery about a year ago, and after which she was told that she had advanced glaucoma in the right eye. And thereafter, she was started on eye drops to the right eye. But despite that, her right eye vision was continued to deteriorate. And then she came to our institution for another opinion. Just a minute. Okay. So on examination, her visual acuity, color vision, and pupil examination were normal. Intraocular pressures were well controlled, and these are the photos of her optic discs. These were her Humphrey visual fields. What do you think of her visual fields? Do you agree that these are glaucomatous type visual field defects? Serous OCT was performed, and these are the RNFL and GCIPL results shown. So she was referred to the glaucoma clinic when an astute member of the team made the following observations. Firstly, that the temporal rims of both discs were somewhat pale. Secondly, it was noted that apart from the glaucomatous type of arcuate field defects, there was a suggestion of a concurrent left homonymous hemianopic pattern of field loss present as well. If you look at the numeric decibel graph, it helped to support the suspicion of a left homonymous defect concurrent with the glaucomatous field defects. The values that are circled in red in the left field of each eye show that significant difference from the values on the right, suggesting the presence of another visual field superimposed on the arcuate defects. The patient was sent for urgent neuroimaging, and this contrast-enhanced CT scan shows a large aneurysm in the suprasellar region, displacing the optic chiasm superiorly and compressing on the right optic tract. The red flag in this case was unexplained vision deterioration in a glaucoma patient despite good pressure control, and the pitfalls were the failure to recognize other patterns of visual field loss apart from glaucoma, and missing subtle clues that were present, such as temporal pallor of both optic discs and nasal thinning of the GCIPL in the left eye, which is not in keeping with glaucoma. My second case is that of a 73-year-old Chinese female with a history of hypertension, hyperlipidemia, ischemic heart disease that presented to the ER with a sudden onset of painless right eye blurring of vision since the day before. On examination, the right eye had hand movements, visual acuity, and had a grade 4 relative afferent pupillary defect. Her Goldman visual fields showed severe loss of right eye visual field involving central fixation with a residual superior temporal peripheral field remaining. These are her fundus photos, which appear unremarkable, including the optic discs. Taking into account her past medical history and the nature of her presentation, a provisional diagnosis of posterior ischemic optic neuropathy was made. There are 3 subtypes of posterior ischemic optic neuropathy, or PION, that have been described, namely, in order of frequency, non-arteritic, perioperative, and arteritic. It is a diagnosis of exclusion in which other processes like inflammation, compression, infiltration, etc. need to be ruled out. Preliminary labs were performed and results are shown on the slide. ESR and CRP were markedly elevated along with some abnormalities in her full blood count. In the light of these results, a working diagnosis of arteritic posterior ischemic optic neuropathy was made. She was admitted, started on intravenous methylprednisolone 1 gram a day. A referral was made to the rheumatology team and an urgent temporal artery biopsy was performed. Histology confirmed the diagnosis of giant cell arteritis. The photos here showing the thickening of the media and intima that are infiltrated by inflammatory cells, fragmented internal elastic lamina, and the presence of giant cells indicated by the arrow. With prompt institution of adequate doses of systemic corticosteroids, vision loss in the fellow eye can be prevented. Otherwise, vision loss ensues in 25 to 50% of patients' fellow eyes within a week. At the same time, further deterioration in the affected eye is generally prevented. Our patient was an example of occult GCA, which is GCA presenting with ocular involvement such as AION, the commonest, CRAO, cilioretinal artery occlusion, or in the case of our patient, PION, without any systemic symptoms or signs typically seen in GCA, such as headache, scalp tenderness, jaw claudication, or constitutional symptoms such as loss of weight, fever, loss of appetite. Patients presenting with occult GCA constitute a fifth of giant cell arteritis patients. Clues that may indicate the diagnosis of GCA in such patients are a history of prior amaurosis fugax, diplopia, and eye pain. With prompt institution, going forwards. Although temporal artery biopsy is generally still considered the gold standard in diagnosis of GCA, in recent years, various investigative techniques have been reported as shown on the slide, together with their sensitivities and specificities. Color Doppler ultrasound is being used routinely in rheumatology clinics. It should be performed with high quality equipment by experienced ultrasonographers and in a timely manner. Some authors suggest that temporal artery biopsies need only be done in cases when the ultrasound is negative. That is, when the halo sign is not demonstrated. The halo sign shown here by the arrow is pointing to where it is, showing homogeneous hypoechoic wall thickening, indicating the thickened, inflamed wall of the artery, of the affected artery. Using high-resolution MRI, for example, 3T scanners, these can detect wall thickening and contrast enhancement in the temporal, occipital, and intracranial arteries of patients with suspected GCA. In this case, the red flag was the presentation of giant cell arteritis without systemic symptoms or signs. Thus, in all patients over the age of 50 years presenting with acute vision loss, do consider the possibility of giant cell arteritis. Thank you for your attention.
Thank you, Dr. Sharon, for an excellent presentation and highlighting the very, very important vision and in certain cases, life-threatening issues that can affect patients. We'll go on to the next talk by Dr. Clement Tan, who will be speaking on foxed by the obvious. Dr. Swati, if you could introduce Dr. Tan.
Good morning, Dr. Tan. It's a pleasure to have you with us for this Foundation Day scientific program. Dr. Tan is Director of Ophthalmology at NUH Health Services and Head in Department of Ophthalmology, NUH, and National University of Singapore. He did his fellowship in neuro-ophthalmology at King's College Hospital and National Hospital for Neurology and Neurosurgery in London. Dr. Tan's main area of interest are neuro-ophthalmology and cataract. He's recipient of several awards, including NUH Eminent Teacher Award in 2016 and Visionary Award, Eye and Vision Health Award in 2017. It's always a pleasure to listen to Dr. Tan. Over to you, Dr. Tan, for your slides. You can share the screen now.
Good morning, and thank you very much for this very kind invitation to be among this very stellar cast of speakers. I'm very impressed by the extensive program for this RPC day, and it is really amazing to see the range of topics that are going to be covered in just a few days. I'm going to share with you a couple of cases that caught me off guard and made me rethink or think harder about how I approach patients. They're all about third nerve palsies, and as you know, just a little revision of the anatomy. In a third nerve palsy, in a third nerve, the pupillary fibers on the outside of the nerve, and the vasa nervorum is on the inside. So typically in an ischemic nerve palsy, you may have a sparing of the pupil function, but in a compressive lesion, you would tend to lose pupil function early on. The cause of the third nerve also useful for us to remember, starts with the nucleus in the midbrain, passes through the cerebral peduncles in the cerebral spinal fluid in the wall of the cavernous sinus, as you heard from some of the one of the earlier speakers, then through the superior orbital fissure and where it's already split into superior and inferior divisions and supplies so many of the muscles in the eye, often causing difficulty in trying to fix the diplopia, though you can see you heard some remarkable surgery done earlier by Rohit and team. In terms of the causes of third nerve palsy, we do know that in general, the incidence of third nerve palsy increases with increasing age. And with increasing age, actually the cause, microvascular causes of third nerve palsy seem to also be a lot more common. We have been all taught that, generally speaking, if there is pupil involvement, we should immediately think of compressive lesions. But you can see that in a small percentage, up to 16%, not insignificantly small, but a smaller percentage of patients, the pupil can be involved in microvascular third nerve palsies. We tend to think of complete third nerve dysfunction, a loss of all the complete third nerve palsy occurring typically in microvascular disease, but it also occurs with compressive lesions as well. Ischemic lesions typically recover well, usually within a couple of months. And we had traditionally thought of them as having no pain, but we do see that up to 61% may have eye pain or headache. But what is quite clear is that in a microvascular third nerve palsy, you will not see aberrant regeneration. First case I share with you is a 62-year-old woman with a background history of hypertension, poorly controlled diabetes, hyperlipidemia, previous infective endocarditis, and a pituitary macroadenoma. You can see that she's had PRP, which tells you her diabetes was not very well controlled, and she had other eye surgery as well, and somebody had thought she had ocular hypertension and put her on timolol. She presented with diplopia and headache, and was diagnosed with a left painful, initially pupil-sparing partial third nerve palsy. So at the outset, the pupil was was a little bit sluggish, but the pupils were still equal on both sides, but the third nerve was only partial. So of course, she had an MRI and an MRA scan, and apart from some stenosis in the internal carotid and middle carotid arteries, the scans were otherwise normal. Over the next 3 to 5 days, this evolved to be a complete pupil involving third nerve palsy, which is not so uncommon for a ischemic third nerve palsy to evolve. She was managed as a ischemic third nerve palsy, but was reviewed closely because of the persistent pain. A resident had thought to review to do a pilocarpine test because he wasn't sure about the large pupil, whether it had been a different pathology, and thought that the pilocarpine test was positive, but this might be really a red herring. 2 weeks after her presentation, she seemed to start to recover, although still complaining a lot of pain. And this pain seemed to really bother her a lot. But 3 months later, the pupils were now equal. She seemed to be recovering more of the third nerve function, as you can see from the eye movements and the improvement of the ptosis. But importantly, when you look at the eye movements without lifting the lids and you see her eyes go to right gaze, there is a little bit of elevation of the left eyelid as she adducts the left eye. And so this is aberrant regeneration. A repeat scan was ordered, and here you can see that there is contrast enhancement around the cavernous sinus superior orbital fissure area, even in the red arrows, as well as some contrast enhancement of what looks like a enlarged lacrimal gland. So here we have a patient who possibly has an infiltrative or lymphoproliferative disease with the following differentials of diseases like sarcoidosis, TB, lymphoproliferative disorders, or just orbital inflammatory syndrome. Unfortunately, this patient declined biopsy and treatment, so we'll never really know what she had, but it tells you that we ought to be looking out for aberrant regeneration. Second patient, a 63-year-old woman with a background history of nasopharyngeal carcinoma who had radiotherapy years ago, and also some other medical conditions like hyperlipidemia and hypopituitarism following the radiotherapy. She presented with a sudden constant horizontal binocular diplopia, slight ptosis, no real significant what might have been and what she also presented with anisocoria, which seemed to be related more to having a Horner syndrome, but no other focal neurological deficits. And she had an MRI brain orbits which were normal, and no tumor recurrence from the NPC was found. 4 months from presentation, she'd already had acetylcholine receptor antibodies tested, single fiber EMGs, and repetitive nerve stimulation, and these were not suggestive of myasthenia. The patient did, however, observe that the diplopia only seemed to occur in the mornings and was transient. Pupils had not changed very much in size. And the right eye was noted to have, the eye that was originally limited was noted that her depression, looking down, was more limited after she had sustained abduction or adduction. And so it was thought that perhaps she had neuromyotonia. 6 months after presentation, she wasn't complaining of double vision anymore. However, a lid gaze dyskinesia was noted. We thought to order a PET scan, but there was no tumor recurrence. And so this was thought that maybe this was neuromyotonia with primary aberrant regeneration, which has been reported. And she remained stable thereafter with only occasional double vision. However, 4 years from presentation, she was brought in by ambulance for what was thought to be a stroke, and she had been complaining of headache and had complete ptosis of the right eye, the eye that had been involved, and this ptosis had occurred 1 week prior with the initial headache that partially improved. The paramedics noted some slurred speech, and at the emergency department, the right pupil was noted to be larger and fixed. She underwent immediate neuroimaging, and she was found to have a posterior communicating artery aneurysm. Now, the aneurysm looks really obvious on this, but going back to her original PET scan, right, her PET CT scan, and where there were source images for the CT scan, you might perhaps notice that it was possibly already there. These are photos showing the aberrant regeneration and the complete third nerve palsy that she had at the time of presentation with the aneurysm. And so what do we learn from all these cases? Entertain a really healthy suspicion about the pupil and review the patients more frequently. If there is aberrant regeneration, this is a warning sign that something else is going on. So keep examining the patient and always do it in the standard technique so that you will see the movement of the lids, and it's only visible if you look for it carefully. Third nerve palsies, I think I learned from this that perhaps we really should follow them up until they're completely recovered, and lack of recovery should prompt re-examination and maybe re-investigation. And so when the clinical picture does not fit or when signs change, re-investigate the patient. You never know what you might find. And I hope none of you will end up waiting 4 years to discover your patient has an aneurysm. That patient most likely had an aneurysm occurring after radiotherapy. And with that, thank you very much for your kind attention. And once more, thank you very much for the kind invitation to be part of this wonderful conference.
Thank you, Dr. Tan. Excellent presentation. In fact, that you picked up the aberrant innervation of the upper lid was an excellent demonstration of how to pick up very subtle signs. There was very little increase in the palpable fissure on adduction, and exactly those are key things you need to look at. You need to be aware of what you're looking for, and even slight changes should, raise the red flags in your mind. So excellent presentation. I also noticed in your slides you had written about the cocaine test. We are constantly looking for that, sometimes for our patients also, but we are always hoping to get a pinch of cocaine for us. But you have access to the cocaine test?
Not anymore. That as you can see, that was done some time ago when I still had a stash. They told me it's expired. I didn't know cocaine could expire, but clearly my stash. I bought 1 kilo in the old days when it was still easily available, but it's all expired, so they don't let me have it anymore. We sometimes steal some from the ENT. They still spray some for the nose, and but that stings like crazy, that preparation. So we are stuck with apraclonidine, I'm afraid. So this was when I still had cocaine. Now I don't have it anymore. I'm not sure we're allowed to discuss our sources for cocaine at this conference. It may not be the appropriate forum.
I didn't think, I'm sure many people will not think that cocaine has a use by date, and
yes, exactly. The pharmacy threw it away, so I can't do anything about it anymore.
Thank you, Dr. Taman. That was excellent. We'll go back to more discussions on sources and availability in a bit, and we go on to the next talk by Dr. Kumudni Sharma, who'll be talking about clinical and genetic profile of LHON patients. Dr. Rebecca, if you could introduce Dr. Kumudni, again another alumni of our hospital.
So Professor Kumudni Sharma, she is the head of the Department of Ophthalmology at SG PGI MS Lucknow. And in 1987, she actually started this division of neuroophthalmology under the Department of Neurosurgery. And she also helped in the upgradation of the neuroophthalmology services to a full-fledged department in the institute in August 2013. So she has been a pioneer in developing the neuroophthalmology in her institute. So she has done lots of work in association with neurosurgery, neurology. She established the department, as I just mentioned, and she has been the recipient of Indian Neuro-Ophthalmological Society Lifetime Achievement Award. So I would like to invite ma'am for her talk on clinical and genetic profile of LHON patients. Ma'am, if you could share your screen. Yeah.
Good morning, and thanks for the nice introduction. So I would be talking about the Leber's hereditary optic neuropathy, clinical and genetic profile, and our experience also. So as we know that LHON is an inherited optic dystrophy, which is called optic neuropathy, which is caused by mitochondrial DNA point mutation. And these all three primary mutations are present in 95% cases of LHON. These mutations are in the mitochondrial respiratory chain complex 1 gene, ND4, 6, and 1. The dysfunction of this complex 1 of the respiratory chain results into the less ATP production, more production of reactive oxygen species, and that later on results into apoptosis of the cells, especially the retinal ganglion cells. The retinal ganglion cells of macular area, that is a papillomacular bundles, is mainly involved because of their increased energy requirement. It's a disease of the young adult. 1177-8 mutation patients have a severe visual loss, and the 144-84 mutation patient, they have a better visual prognosis, and they show a milder disease, while 3460 mutation has a worse visual prognosis. The disease manifestation depends upon the load of the mutation. LHON is a clinical diagnosis. The patient presents with bilateral painless central visual loss, which may be simultaneously or sequentially. Usually the second eye involvement occurs after 6 to 8 weeks of involvement of the first eye. When we get the maternal family history of the visual loss, that helps us in making a diagnosis. The pupil in the initial stages are normal, but as the disease advances in the later stages, may show slight sluggish reaction. The fundus shows the pseudoedema of the disc with the telangiectatic peripapillary blood vessels which do not leak on fluorescein angiography. Some of the patients at the time of presentation may have a normal disc, or some may have a disc pallor. The field examination shows the classical central sequocentral scotoma. So sometimes it may be mistaken as a nutritional or toxic optic neuropathy. The OCT in the acute phase shows the thickening of RNFL, and later on the chronic phase may show shows the thinning of the RNFL, preferably of the temporal part of the disc. MRI in most of the cases is normal, but in some cases may show the T2 hyperintense lesion of the optic nerve chiasm of tract. As you can see in one of our patients, he had a hyperintense lesion of T2 on the FLAIR imaging, and which also enhanced on T1 imaging. So misdiagnosis of neuromyelitis optica was made, but later on genetic study we could find out the mutation 11778 in this patient. After the clinical diagnosis, we should rule out other causes of optic neuropathy, as I told you, the toxic and the nutritional and demyelinating disorder. And once we are sure, then we should get the genetic, to make the confirmed diagnosis, we should get the genetic testing done, which I showed in 95% of the cases, the primary mutations, one of the primary mutations will be present. When the clinical suspicion is very high and one of these mutations is not present there, then we can ask for the entire mitochondrial DNA sequence to find out the rare mutations. The visual prognosis is seen better in children, and the one who have a subacute onset and the one who shows the slow progression of the disease. There was an international consensus statement which was published in 2017 in JNO, where they divided this disease into the different stages. The acute stage, when the duration of the disease is less than 6 months, the dynamic is 6 to 12 months, and it is called chronic when it is more than 12 months. The various risk factors which were identified are smoking, tobacco chewing, and alcohol. LHON plus when the LHON patient have associated cardiac and the neurological or MS-like illness. So the treatment is mainly to prevent the risk factors like alcohol and smoking. The IGBinone and the CoQ are the synthetic ubiquinone which have been in the use for treating these cases from long time. These are the CoQ or IGBinone, these they act as an electron transporter, and they bypass the dysfunctional complex 1 and transport the electrons to the complex 3 from 1 and 2. So on the basis of the So on the basis of cumulative data so far published in the literature, the IGBinone has been approved by the European Medical Agency in 2015, and there was a conference held in 2016 where the experts who have been working in this field of LHON. They reviewed all the retrospective, prospective, and case series and the case reports on LHON patients, and they came to the conclusion that, and they even recommended that Idebenone should be started early in LHON patients who have a disease of less than 1 year duration. It should be continued for 1 year to see the effectiveness of this treatment, and if visual improvement is seen, then treatment should be continued for 1 year after the plateau phase is achieved. So the recent publication where they have where the authors they published their experience on treating this 111 LHN patient with Idebenone, they found that if they have if Idebenone is given early in the course of disease, and they recommended that it should be maintained for 24 months to see the maximum effect of the treatment. Currently, we have Idebenone, which is given the dose of 900 milligram per day in the divided doses, with avoidance of this factor, with supplementation of other micronutrients as a treatment of this disease at present. So we have a small group of 16 patients of LHON, in whom we found that 10 patients they showed 1177A mutation, and 2 patients we have a 3460 mutation, and 4 patients we could not get the genetic testing done. The age range from 15 to 35 years, and all the patients were male. The vision at the time of their presentation varied from count finger to 6/6. We followed them from up to the period of 5 years. The vision at the last visit was 636 to 660. As we know, in the Asian population, the visual recovery is better what we see in the Western population. So we also observed that most of the patients they showed a clinically relevant recovery of their visual acuity, or the one who did not recover completely, at least they showed the clinically relevant stabilization of vision. None of the patient had associated neurological or cardiac disease. All the patients have normal MRI, except one patient who had a T2 hyperintense lesion, and which we early thought of neuromyelitis optica, but in detailed history, we could make out, no, it is not a neuromyelitis optica, it is a LHON patient, and on treatment with CoQ, and the patient started showing some recovery of a period of 6 to 7 months. We treated all the patients of tablet CoQ, 300 milligram TDS, and tablet antoxivate, and vitamin B1, and folic acid and vitamin C, along with the good intake of a diet. Now, besides the Idebenone or a CoQ treatment, there is there's a more of studies are coming up with the role of gene therapy in this disease, and already 2 phase 3 trials have been finished, and where they found a very promising results, and the phase 3 trial is still going on. The earlier trial, they used the gene therapy, they gave the gene therapy only in the one eye, and the last one, the reflective study, they are giving it in both the eyes. All these trials, they reported a sustained and clinically meaningful benefit in the vision in LHON patient, and all of these patients who were enrolled in the study, they all had a 1177A mutation, which is a commonest one. And when they compared their results, they found a statistically significant benefit of this gene therapy when they compared it with the natural history studies. So that ends to my presentation.
Thank you, Dr. Kumudni. Wonderful presentation on LHON. We had a question on chat by Dr. Clement regarding availability of Idebenone lower cost. And yes, unfortunately, we don't have a 900 milligram tablet available. For neurology, they make it at 45 milligram tablet available. So patients have to actually, skip breakfast and eat those 20 tablets of Idebenone. But yeah, the cost is not all that much. They cost about, 10 rupees. So, $0.1 or, a little $0.15 a tablet. So, but yeah, 20 tablets a day for at least 6 months. So, thank you. We'll go on to the star event of today's morning session. We have with us Professor Frank Martin, who would be delivering the Professor Prem Prakash lecture. Professor Frank Martin graduated in medicine from the University of Sydney in 1966 So long before many of us here were even born, Dr. Frank Martin was an expert in medicine. He completed his training in ophthalmology at the Sydney Eye Hospital and undertook a fellowship in pediatric ophthalmology, strabismus, glaucoma at the Children's Hospital of Philadelphia and the University Hospital of Pennsylvania in 1971-72. He was the president of the board of Children's Medical Research Institute and chairman of the Asia Pacific Society of Pediatric Ophthalmology and Strabismus, Asia Pacific Myopia Society and Orthoptic Advisory Committee. He's of course currently president of these societies. He's been the past president of RANSCO in 97-98, of APAO in 2009-13, International Strabismological Association, the International Pediatric Ophthalmology and Strabismus Council, and a member of the board of American Academy of Ophthalmology. He's received numerous awards, including the RANSCO College Medal, the Jose Rizal Medal, the Michelle Beats Memorial Award, the ICO Mark So Golden Apple Award for teaching, a Secretariat Award from the American Academy of Ophthalmology, Honor Award from the American Association of Pediatric Ophthalmology and Strabismus, the Lintz Medal from the ISA, and the Archie Telfer Prize from Sydney Eye Hospitals. Dr. Frank Martin, still a clinical professor in the Department of Pediatrics and Child Health in Ophthalmology in University of Sydney. It is an absolute pleasure and an honor for us to have you deliver the Professor Prem Prakash oration for us here today.
Thank you very much, Rohit, for that very generous introduction. I am absolutely honored to be delivering the Professor Prem Prakash lecture to mark the 55th annual Foundation celebrations. I did a little research into Prof. Prem Prakash, and he's been one of the doyens in strabismus and pediatric ophthalmology. He and other esteemed ophthalmologists with an interest in strabismus established the Strabismological Society of India in 1985. He has mentored many national and international figures in strabismology, and he certainly has done a lot to make strabismus recognized as a very important subspecialty. In fact, it was the first subspecialty society that was established in India. Today, I'll be speaking on strabismus management in thyroid eye disease. Are we looking at a paradigm shift? Strabismus in thyroid eye disease is a challenge. It's a challenge for the doctor and it's a challenge for the patient. We have no conflicts of interest to declare. Now, when we talk about thyroid eye disease, we have to go back to Frank Felix Rundle, who published a paper in which he described the Rundle's curve. And Rundle's curve simply shows that we've got to, it gives us an understanding that there's an active phase in thyroid eye disease and a cicatricial phase. I had the good fortune in 1967 to be Professor Rundle's surgical resident. He was one of the most meticulous surgeons I've ever come across. He specialized in thyroid surgery. Now, in managing thyroid eye disease, well, we first control active disease. How do we do this? We've got available systemic steroids. These work well, but with side effect. Steroid-sparing agents such as methotrexate, it has mixed value. Irradiation certainly is very effective. More recently, the FDA has approved monoclonal antibodies, namely teprotumumab. We don't have this available yet in Australia. And it's extremely important when we're involved with active disease that we stress to the patient the importance of stopping smoking. Once the active disease burns out, we're left with the sequelae to manage. These involve the orbit, can be gross proptosis, may require orbital decompression, not only for cosmesis, but also the risk of compression, eye muscles, strabismus, which we'll be talking about today, problem with the eyelids, which can be from retraction or induced by us, the strabismus surgeons, and thyroid eye disease, doesn't matter where it's practiced in the world, it's best managed by a multidisciplinary team, endocrinologists, immunologists, orbital surgeons, strabismus surgeons, and oculoplastic surgeons. Now, approximately 15% of patients with thyroid eye disease develop strabismus, and all muscles may be involved, but most commonly it's the inferior rectus, the medial rectus, and the superior rectus. And the involvement of the two eyes can be quite asymmetrical. The patients are troubled by diplopia. They have to adopt an abnormal head posture to try and avoid a diplopia. And then they have the psychosocial effects, not only from their appearance, from the thyroid eye disease, but also from strabismus. The goal in managing strabismus thyroid eye disease is to give the patient a comfortable field of BSV in primary and down gaze, and good cosmesis. With the workup of the patient for us as strabismologists is no different for any other ocular motility workup, except here, I think it's very, very wise to image the orbits, get good quality imaging, so we can see what's happening to the muscles and see if what we see on imaging, does it match the patient's clinical picture. Here's a patient with a very large hypertropia, and here we can see the very large superior rectus, so imaging is imperative. Most patients can be managed without surgery. We have the use of prisms. We can use phenol prisms as a temporary measure initially, just to relieve the diplopia and the abnormal head posture. Later on, we can incorporate prisms into glasses. We may find that multifocals are not ideal, have to use separate reading or modified reading glasses or modified bifocals. Botulinum toxin has been described as useful in strabismus management. I have no experience with this. In some patients, the diplopia is so bad that we just end up with monocular occlusion. Surgery, if required, is delayed until we have 6 months of stable control. And if orbital decompression is going to be part of our management plan, that has to be performed before we move on to strabismus surgery. Whenever strabismologists meet, there's always discussion and controversy as to how you should go about managing these patients. Should you be doing it under a surgery under a general anesthetic or a local? Choice of suture. There's quite a number of experienced strabismologists who feel that in thyroid eye disease on the inferior rectus muscle, a non-absorbable suture is far preferable, because they say that with absorbable, there's going to be slippage, stretching of the scar, and overcorrection. Well, this is probably not due to the suture, but the fact that we've done a big recession and ending up with a very limited arc of contact of the muscle with the globe, plus there's still inflammation occurring within the muscle and changes occurring at the insertion. Should you use an adjustable suture technique or a modified hangback suture technique? There are no randomized controlled trials. I think it all comes down to personal preference. My preference is to use an absorbable suture and to use a modified hangback suture technique. My modified hangback suture, which I've been using almost since I commenced surgery, I take 2 bites at each end of the muscle, then a bite at the edge of the insertion, be it this medial rectus or be it inferior rectus, and then taking a second bite through the center of the insertion. So I have And with this, I can then do a temporary tie. I can then do an intraoperative abduction to see just whether I'm matching defects in the two eyes. And I've found this works extremely well. The classic cross swords hang back tends to bunch up the muscle. Linda Dargy does a very similar technique, except she takes a bite horizontal, parallel to the insertion and comes out in the center. So with strabismus surgery and thyroid disease, meticulous preoperative assessment and informed consent, it's important that the patient's expectations are going to match your expectations. You've got to consider the secondary and tertiary action of the muscles, especially the inferior rectus. Inferior rectus muscle, it depresses, but it also extorts and adducts. So if we do a big inferior rectus muscle recession to get good alignment, we might have very good alignment in the primary position, but in down gaze, a large A pattern and a diplopia and a very unhappy patient. I urge you to always use a very competent assistant when operating on the thyroid patient. These muscles can be just so tight that it can be very, very difficult to place your sutures into the muscle, let alone remove the muscle from the globe. Remember, the conjunctiva is fragile. Respect the conjunctiva and carefully elise the capsulopalpebral fibers when operating on the inferior rectus and superior rectus muscle to minimize the change in lid position. So my principles are that I know I'm operating on tight muscles, and basically all I want to do is relieve restrictions. Surgical dose tables are of little value. You're going to make your decision as to how much to do at the time of surgery. Try to avoid overcorrection. I like to do intraoperative abductions, and say if I'm operating on the inferior recti, I like to leave a little bit of restriction at the end of the procedure so I don't get an overcorrection, especially if I know from my imaging there's a large superior rectus muscle, because that then is going to pull the globe up and you're going to get overcorrection. And I find the modified hangback suture technique to be very valuable in achieving my goals. Let's look at a few patients. Here's a 55-year-old restaurateur, an avid golfer. He's persisted with treatments through the active phase, cicatricial phase. He's got a very marked chin-up head posture, and he's had decompression of the left orbit. He's got quite asymmetrical disease, and he's got vertical diplopia. Imaging confirmed that only one orbit was involved. He was a smoker, and I know for a fact that he didn't stop smoking because I saw him on the golf course with a cigarette hanging out of his mouth. So here he is in the primary position, left hypotropia, left esotropia, can't elevate, and he also has a restriction of the medial rectus on the left side. So what a surgical planning. We're going to relieve his the tightness, recess the inferior, and recess the medial. And here he is pre-op, post-op. Cosmetically, good alignment, no diplopia, still got a little bit of chin-up head posture. He's got a change in lid position. He's happy with this. He doesn't want anything more done. His problem was his diplopia, and that has been fixed. Gary, a 64-year-old builder, his thyroid had been stable for 12 months when he presented to me. He had vertical and horizontal diplopia with a tilting of one image. He had a chin-up head posture, and imaging confirmed both orbits involved. So here's Gary with a large left esotropia. He's got hypertropia. Now, he's either got lid retraction due to his thyroid disease or to fixation duress in attempting to look up. And we know from his eye movements, he's got both inferior recti involved, because that eye won't go up and that eye won't go up. But to what extent is the right one involved? Is it involved enough to require surgery? The way I determine this is that I patch his worst eye, which here is the left eye. If when I patch, his head posture corrects, or his retraction is relieved, then I know that this muscle is not badly involved, this inferior rectus. I can leave it alone. However, if it persists, then I know I've got to operate on both inferior recti. This is taken from Linda Dargis' paper. The right eye is the more severely involved. She occludes the right eye, has a look what happens, and here's the patient. Lid retraction goes and position, and so she ended up operating on one muscle. So Gary, he had both eyes involved, both inferior recti, both medial, 4 muscle surgery, relief restrictions, and we get a good result. With and here is upper lid, the fixation duress that was causing the retraction has gone. Finally, my patient is a 56-year-old businessman. He's a patient who I co-managed with one of my colleagues in India. She had this very difficult man to deal with. His thyroid eye disease had been stable. He's had strabismus and diplopia, but this became worse after he had decompression of his right orbit. So absolutely refused anyone to operate on his left orbit. Imaging confirms bilateral thyroid eye disease. Here is ocular movements, primary position, up gaze, the left eye won't go up, down gaze, the right eye won't go out, and he's also got bilateral medial rectus involvement. So what are we going to do with him surgically? He wants to look better, but he doesn't want anything done to the left side. So reluctantly, we explained to him that ideally he should have left decompression, and if the strabismus is worse, let's deal with it there and then, but he refused. So we finally agreed a staged procedure, and he had a right superior rectus recession and a medial rectus recession with a marked improvement, but he still has left proptosis, left hypertropia and esotropia, and 2 years have gone by. COVID has had an impact on our ability to operate, but he's still refusing further surgery. So wouldn't it be nice to have something that we don't have to worry about surgery and medical therapy that would allow us to change what we do? Well, teprotumumab has FDA approval for thyroid eye disease. It's an insulin-like growth factor 1 receptor inhibitor. It blocks the inflammatory autoimmune pathophysiology that underlies thyroid eye disease. So it acts at the orbit where we have inflammation. 2 multicenter randomized double-masked clinical trials evaluate the efficiency of teprotumumab. There was a significant mean reduction of proptosis of 2 millimeters in most patients. There was a significant mean reduction in clinical activity score, and the greater proportion of patients with a final clinical activity score of 0 or 1 than in the placebo group. Also, there was a higher diplopia responder rate, an increased improvement in Graves' ophthalmopathy quality of life score. So here we have what looks like a very valuable drug to use in thyroid eye disease, but there are adverse events, and these were common: muscle spasm, nausea, alopecia, diarrhea, fatigue, hearing impairment, hypoglycemia. However, despite these significant adverse effects, They were mild, and most of the patients in the trial tolerated them. Very few withdrew because of the side effects. So we have teprotumumab, which gives better outcome than placebo in respect to proptosis, clinical activity score, diplopia, and quality of life. And in the future, there may well be a paradigm shift to medical therapy. So conclusions from my talk. Strabismus in thyroid eye disease is a challenging problem. Many patients can be managed without surgery. Delay surgery until 6 months of stability in thyroid eye disease. At surgery, relieve restrictions. Be prepared to make intraoperative changes to your surgical plan. Dose tables mean nothing. A monoclonal antibody therapy with teprotumumab may change the way we manage thyroid eye disease. Thank you.
Thank you very much, Professor Frank Martin, for an excellent presentation on thyroid eye disease. Thankfully, we don't get that much patients to operate on thyroid eye disease. Somehow we don't see so much strabismus, but in our limited experience, it has been a very big challenge. And as you rightly said, the nomograms really don't work. And possibly it's intraoperatively that you see how the muscle is and the force duction test, and take a plan on how much you're going to recess. And the tip on actually checking whether it requires bilateral or unilateral surgery is also extremely essential. So before we move forward, we will give the Dr. Prem Prakash Oration Award to Dr. Frank Martin. Unfortunately, there is a huge distance, so we will be doing it electronically at the moment, and we hope to be able to send the award to Professor Martin eventually. Just a bit about Professor Prem Prakash, which Dr. Frank Martin had alluded to. Professor Prem Prakash was the head of strabismus services at the Dr. RP Center and served also as the chief of RP Center for a period of time. He established strabismus as a subspecialty at RP Center, and actually with his enthusiasm and energy, actually as a subspecialty all over the country. He founded the Strabismological Society of India, which was the first subspecialty association of ophthalmology in the country. And truly so, many of us here would consider him as the father of strabismology in India. He has been a mentor of mentors. He was the mentor of my mentor, Professor Pradeep Sharma, who speaks so highly of him. And it was a very short while under which I had opportunity to work under Professor Prem Prakash. He was a recipient of several awards, including the P. Siva Reddy International Award by the All India Ophthalmological Society in 1995. So it's an absolute pleasure for us to award the Professor Prem Prakash Oration to Professor Frank Martin, and we'll just so this is the Oration Award, and we hope, like I said, we will be eventually sending it to you. This is the logo of the RP Center, and this, along with the award, we hopefully will be sending it to you. And thank you very much, Professor Frank Martin, for accepting the award and giving this wonderful and excellent oration in the 55th Foundation Day celebrations of RP Center. Thank you very much, sir.
Thank you.
We'll just take a few questions. We have a little bit of time, so we'll take a few questions in the meantime. Anything our panelists, our speakers would want to say before we look at the chat box for the questions?
Can I ask Minaski a question? With amblyopia, what do you say to the parent when they tell you my child refuses to wear a patch and I can't insert eye drops?
And Dr. Meenakshi, possibly Dr. Meenakshi. may have left. She is disconnected, but a very tough question, Dr. Martin, a very, very tough question. Of course, thankfully now we are having options in the form of diagoptics and very interesting innovations that are come, including from India, Dr. Santhan Gopal. So we have options which we are trying in these patients who refuse occlusion and of course are unwilling for eye drops. So we've been exploring their utility in patients like this. As Dr. Meenakshi said, we usually always use the conventional interventions like occlusion and or penalization as the first step. But those who are reluctant or who are non-compliant or who do not improve significantly with treatment, we offer them the alternatives. Any other experiences among the panel? Sir, what is your experience in the matter?
I always find it very hard because here we know we can actually give the child vision back, restore vision, which is what we aim to do as ophthalmologists, preserve vision and restore vision. And here's a parent. I try to spend time with the parent, but we do find there are some where compliance is just it doesn't occur. And that frustrates me. I wish I could find some way to manage these children.
The good thing is that we are seeing a lot of interest in amblyopia management and a lot of research is going on. So we hope that eventually the gold standard will not remain what has been so for more than 100 years. So we hope that with more technology coming in and the next generation being more adept at using technology, they may find the alternative interventions easier, better, and of course more acceptable. Any other comments or questions? We just have about a couple of minutes before we go on to the next alumnus session.
Rohit, may I have a question?
Yeah.
I noticed with great interest the fantastic strabismus surgery that you presented, and also Dr. Frank Martin, with these really large angle strabismus. My question is, what about those with very small angle, especially torsional diplopia, where it's very easy to over or under correct them, and if they can't fuse very well? What do you do in those instances where small angle torsional is really disturbing to a lot of patients, but it's so hard to find appropriate therapy? Can I just get your thoughts on small angle torsional or vertical diplopias?
Dr. Frank, please.
Thank you. Well, that is a challenging question, and because when there's a small angle, if it's simple vertical, a very small, I'm going to say a 6 to 8. Say, let's take a cataract patient. Someone has had cataract surgery, and wonderful 6/6 vision, but vertical diplopia due to a right hypertropia, some tightness in the inferior rectus, measures about 4 to 6 prism diopters. They don't want to wear glasses. Well, I found a very old operation still very useful. Just doing a marginal myotomy, and that will give them, usually I do 2 small cuts, and that will give them 4 to 6 prism diopters and allow them to fuse. Now, if there's torsion as well, if there's torsion present and you've got a small angle, this is more difficult because the Hirata Ito you can't undo it if you do it. So I think with these ones operating on the inferior rectus muscle, offsetting a small amount, possibly combining it with a small recession, that will correct the torsion. I think we sometimes overlook the easy operation, which is the inferior rectus, and we go for the more complex, the Hirata Ito. It's good for our egos, but may not be as good for the patient.
Thank you, Professor Martin. Yeah, truly, I think small marginal matmees, or even the central matme that's been described by Kenneth Wright, would be useful for those small angles which do not accept prisms. And yes, prisms can be a little difficult because the angle varies, and torsion, of course, can be very, very difficult to handle. So it's just like that. Small angles are tougher to handle, just like soft cataracts are tougher to manage than hard cataracts now. So the small angles are tougher to manage than the large angles that you can get away with, and kind of satisfy your ego about doing some wonderful surgery. So great. I think I'll thank each one of you. Lovely, wonderful talks from the speakers, an excellent session, extremely enlightening, with some wonderful learning points we all took from this. And thank you everybody for being a part of the RP Center Day Foundation Day celebrations. We of course will go on to the next session, which is also a pediatric ophthalmology, strabismus and neuro-ophthalmology session, in which we will have some of our ex-alumni presenting some very interesting talks. But thank you very much. Thank you very much, Professor Martin, and all the speakers for being a part of this wonderful session. Thank you, everybody.
Thank you.
Thank you. Bye.
We just start in a bit, I guess, in just a couple of minutes.
Mahipal's takeover, I was here. Beto, either now.
So I think we can start the session.
Yeah.
Just let us know when we go live, please.
Yes, doctor, we can start the session. We are live.
Yeah. So a very good morning, everyone. Now, as we just discussed the updates, now we move on to the basics in strabismus and neuro-ophthalmology. So the session would be chaired by Dr. Santhan Gopal, Dr. Kumudni Sharma, and Dr. Rohit Saxena. The panelists are Dr. Amrita Kapoor, Dr. Digvijay Singh, and Dr. Abdul Shamir. And I am Dr. Rebecca, who would be moderating the session. So let's start with the first topic of the day, which would be presented by Dr. Gunjan Saluja. Well, Dr. Gunjan Saluja are RPC alumni. She's a consultant strabismus, oculoplasty, and neuro-ophthalmology services at Bhatia Netralaya, Bhilai, Chhattisgarh. So, Dr. Gunjan, please, you can share your screen. You have to unmute yourself.
Sorry. Yeah, so I hope my slides are visible. At the outset, very good morning, everyone. And at the outset, I'd like to thank everyone for giving me this opportunity to present today. It's always great to be a part of RP Center. And I'll begin my talk. I'll be discussing about advances in the amblyopia therapy. So by definition, amblyopia is the decrease in visual acuity because of abnormal binocular interaction or because of form visual deprivation for which no underlying physical cause can be found, and can be classified as strabismic, refractive, and visual deprivation amblyopia. Refractive can be further classified as anisometropic or ametropic. The most accepted pathophysiology of amblyopia has been proposed by Ubel and Wiesel, who have demonstrated the effect of sensory deprivation on the ocular dominance columns. And it was found that the eyes which were actually the non-dominant eye, which were basically patched, they found that the V4C layer of the visual cortex had shrunken, whereas those of the non-deprived eye were expanded. So coming to the basic workup in amblyopia, looking at the visual acuity, fixation pattern, grid reflex, following that ocular motility, alignment, head posture, sensory functions, and fundus evaluation. Basically, we have to rule out any other physical cause for the low vision, and we have to see which category of amblyopia is it fitting. So the management, early identification and intervention in critical age group ensures recovery and restoration of binocularity, age, duration, refractive error, associated ocular deviation, ocular modia opacities, and patient compliance are some of the important considerations which one should look at before beginning the management of amblyopia. So the first and foremost step is the optical correction. So age-appropriate cycloplegic refraction and prescription of glasses and contact lenses is essential. The basis is that it removes the image blur at the fovea and induces visual pathway stimulation. ATA3, that is amblyopia treatment studies, which have been conducted by the PEDIC group, have also shown that the effect of optical correction decreases with increasing density of amblyopia and also with the advancing age of the child, and hence it becomes more important to give a proper correction at the proper age. And this is the preferred practice guidelines as proposed by the American Academy, as well as in consensus with the AIOS on the prescription of glasses. Now, coming to the therapy, the most accepted therapy still remains occlusion, which can be either commercially available or homemade patches. However, the success rates tend to decrease with advancing age, but still a trial should be given even in older children and adults, depending upon their acceptance. Preferential stimulation of the amblyopic eye is what is the basis. So occlusion of the dominant eye is what is done. Occlusion also helps in improvement in strabismic amblyopia and should be prescribed before the surgery is planned. Occlusion can be either full-time or part-time, and part-time occlusion definitely is better as it promotes binocularity. And even the ATA studies have shown that in patients with severe amblyopia, part-time occlusion of 6 hours is equal to equally efficacious as 12 hours occlusion And in patients with moderate amblyopia, 6 hours occlusion is equivalent to 2 hours occlusion. So, but there are some patients who don't respond to occlusion and they are labeled as occlusion failure. Occlusion failure is labeled when there is no improvement in the best corrected visual acuity of the amblyopic eye on 3 bimonthly follow-ups. And usually an improvement is expected at around 16 weeks or 3 months. Poor compliance, older age, severe amblyopia, and an astigmatism of more than 1.5 diopters is considered to be important, to be a risk factor for occlusion failure. Maintenance therapy and slow tapering is important so as to prevent the recurrence of amblyopia. Most of the times, patients come back with a recurrence because the occlusion has stopped suddenly. So slow tapering is important. Other factors which can result into recurrence, as shown in a study done at RP Center, were older age of onset of treatment, younger age of cessation of occlusion, and larger visual recovery. So as to wean off occlusion, penalization can be done. It's the partial occlusion and it defocuses the image in the better eye. Penalization can be either done by optical or pharmacological means, where optical penalization can be done in the form of overcorrecting plus glasses using translucent filters or sticking tapes on the spectacles or ground glassing the spectacle glass. Pharmacological penalization can be done by using 1% atropine eye drops. Now coming to the newer modalities, one of them is the liquid crystal glasses, which consist of an electronic shutter, which is controlled by a pre-programmed microchip incorporated into optical refractive lenses. There are large organic molecules which have electric polarity and are suspended in a gel-like liquid. So whenever an electric voltage is applied, the spatial orientation of those molecules is changed. This creates a black lens. So whenever the electric voltage is there, the lens turns black and then the shutter closes. So whenever it is on, it is closed. And whenever it is clear, the shutter is open. Because of its cost, it's not very widely used still. Now coming to the next newer modality, that is the active vision therapy, which is really something when, everyone wants to explore. And it is done in the form of near vision task and fast pointing activities with or without occlusion. The mechanism proposed is that it re-educates the amblyopic pathway by intense sensory and motor interactions. Constant attention stimulates neuromodulatory pathways, which involves dopamine and acetylcholine, and further stimulates visual processing and enhances plasticity of the visual cortex. Also, it improves orientation, stereoacuity, and contrast sensitivity. So active vision therapy can be either in the form of monocular, means one eye patched and the child is asked to play the games with the amblyopic eye, or could be with a binocular active vision therapy in the form of dioptic games using anaglyph glasses or polarized glass or virtual reality systems. So monocular video games along with occlusion therapy have shown a significant recovery in the visual acuity. Again, this was a study which was done at RP Center. Now coming to the next, that is dioptics or a binocular active vision therapy. It definitely is better as compared to monocular because both the eyes are being used. Binocularity and stereopsis development would be better. The basis is that the amblyopic eye is shown a higher contrast image and the dominant eye is shown a lower contrast image, as is seen in the image also. And the activities are such that the interaction is required from both the eyes. As the binocular functions improve, the contrast difference between the two eyes tends to reduce. Another active vision therapy game, which is very commonly used and prescribed, is the Tetris game, which is played using red-green glasses, so that the child is seeing the red blocks with one eye, the green blocks with the other eye, and the background color is such that it is seen with a combination of both the eyes. Other games with there are
अपना मास्क साफ और मुंह ढक कर पहने रखिए। मास्क साफ पहने रखना नियमित दिशा निर्देशों के अनुसार एक दंडनीय अपराध है और सख्त कार्रवाई की आती है।
Everyone to please mute themselves.
प्रसाद को नियंत्रित करने में आपके सहयोग के लिए धन्यवाद। Request your attention, please. Please wear your mask covering the nose and mouth.
May I continue? So basically, other modalities and other dioptic therapies which are there include the IBIT, that is interactive binocular treatment system, the virtual reality games, and they can be paired with shutter glasses also. And there are certain videos also which have been described for the same. The binocular iPad therapy results in greater learning effects than monocular training, and a large number of trials have shown that they do significantly affect it. But poor compliance due to repetitively playing the same games is something which is of a greater concern. And again, the cost effectiveness is something which has to be overcome. Now, the next question which arises while we are describing the dioptic therapy or the active vision therapy is for how long this has to be given. So various studies have shown a large number of variations, and ideally active vision therapy with patching in one eye, that is monocular therapy.
Gunjan, I would like you to summarize, please.
Yes. So in the recent studies, even 2 hours per 2 weeks for 2 weeks have also shown it to improve the visual acuity by 1.5 lines. But compliance still remains a concern, and that has resulted in these variations. So long-term studies with large sample sizes are still required. Now, I'd just like to speak through this, and as Santan Gopal sir is there, he will describe this better. This is the orthoptic, that is the Made in India Myopic Management Program, which consists of a black screen with 3 rows of LED light, where the light comes on and off for 300 milliseconds, and patients are seated at 1 meter distance and are handed over the laser light. The procedure is conducted for 30 minutes, and patients may need up to 30 sessions, and it has been found useful in patients who are resistant to occlusion therapy, and is based upon the mechanism of magnocellular pathway stimulation. Pharmacotherapy with levodopa, ceticolin, donepezil, and citalopram have also been tried. Amblyopia in therapy in adults, again, managing amblyopia in adults remain a challenge. However, a chance should be given using occlusion, active vision therapy, and perceptual learning. Thank you.
Thank you, Gunjan, for the comprehensive overview of amblyopia. We'll take all the questions at the end of the session. So quickly moving on to the next topic. As Dr. Asha is not available today, Dr. Sujit would be presenting on her behalf. So Dr. Sujit, if you could present your talk on adjustable strabismus surgeries. Dr. Sujit is a consultant pediatric ophthalmology at Win Vision Eye Hospitals, Hyderabad. So you can share your screen, Sujit.
There is no option here.
Dr. Gunjan, can you stop sharing, please?
So I have stopped sharing my screen.
Sujit, are you getting the option now for screen share?
I'm not getting any option here, sir. Yes, the host has asked you to start.
Just try again, screen share. You at the bottom screen, you'll be seeing that green arrow. Sujit, while you figure out, I think we'll just go on.
Yes,
Dr.
sir.
Ankur, right? We'll
Yes,
just
sir, sure.
work with you. Our team will work with you. In the meantime, we'll have Dr. Ankur, who will be presenting on management
Sure.
of sixth nerve palsy. We'll just
Sure,
get back. Dr. Ankur will be presenting from here. So in the meantime, in the back, we'll work with you to show you the screen share.
Can you put my slides on the...
So Dr. Ankur, he has his practice in Jaipur. He's heading the Max Vision Eye Care Center, and he's also presently the treasurer of Strabismological Society of India and Indian Pediatric Glaucoma Society. And so I would like to invite you, sir, to start your talk on management in sixth nerve palsy.
Thank you, everyone. And I'm very happy to be here at the Foundation Day and meeting friends and teachers and everyone physically after a long gap of more than 2 years. So I'll be talking in brief about management of sixth nerve palsy. So the sixth nerve palsy has signs and symptoms of horizontal diplopia, worsening towards the affected side. There can be a phase turn, and the measured esotropia would be concomitant with a greater esotropia in the field of action of the muscle. So sometimes we have acute onset diplopia post-trauma. So it's a case of traumatic sixth nerve palsy. All that is required is observation and follow-up, because some of these patients do recover very well with observation. This is a case of 34-year-old male presented with sudden onset double vision. He has history of mild headaches on and off associated with occasional vomitings. There is no neurological illness otherwise, and there's bilateral abduction limitation suggesting a bilateral sixth nerve paresis. On examination, the vision is 6/24 and anti-segment is absolutely fine, but there is a florid disc edema along with a space occupying lesion, which is a very large lesion suggesting of a brain tumor. So a dilated fundus examination is a must in all acute onset sixth nerve paresis, because it could be a pseudo-localizing sign, and we can actually have something like a brain tumor which could be life-threatening. So management options would be occlusion, prisms, and Botox in the acute phase. And we think about definitive surgical management after stability of deviation for about 6 months. So surgical intervention can be broadly divided for a partial sixth nerve and a complete sixth nerve. For partial sixth nerve, we have options of MR recessions, LR resections, planning an RNR surgery, and RNR can be combined with contralateral MR recession. Now, this is a case of left post-orbitotomy sixth nerve palsy, and the patient undergoes RNR and she recovers pretty well with almost a near normal recovery. So this is before the surgery and after the surgery. For total sixth nerve palsy, we have a lot of options like partial VRTs with MR weakening procedures, which could be Botox or recession. We also have full tendon VRTs with MR weakening procedures, or rectus muscle union procedures with MR weakening. There are various procedures described in the literature, like Hamilton, which is a partial VRT having temporal halves of the muscles, the O'Connor's full tendon VRT with LR cinching. Carlson and Jampolsky advise adjustable partial VRT. Then we have Jensen's muscle union procedures, Kushner modified by using the middle halves, but all these could have problems of strangulation of vessels. Then Rosenbaum talked about full VRT with Botox to the MR, and then there was Foster's augmentation to this VRT to augment the effect of this VRT. So these days we have this Nishida's procedure, which doesn't divide the muscle. Originally, it was described with muscle split. Later on, the muscle split was avoided. And what we do here is we take a bite 8 to 10 millimeters from the insertion, and then we place the medial end of the superior and the inferior rectus 10 to 12 millimeters radially away in the midway between the LR and the IR and LR and the SR. So this can be made adjustable with doing an MR adjustable as a adjustable modified Nishida procedure. This is a case of left traumatic sixth nerve palsy, and the patient undergoes large MR recessions with half-width VRTs. We can see that the alignment is fine, but there's some amount of widening of palpable aperture of the left eye. This is the same patient pre and the post-op. Another case of post-traumatic sixth nerve palsy of the right eye. And there's a history of RTA 2 to 3 years back. There's a diplopia in primary gaze in the face turn to the left. The patient undergoes right MR recession, a large MR recession with superior rectus transposition with Foster's augmentation suture. So we have a pretty good alignment here. Another case of post-viral sixth nerve palsy for 3 years. She also undergoes a similar procedure where we do a large MR recessions with superior rectus transposition with Foster's augmentation. And she also has fairly good alignment, at least in the primary gaze. This is another case of post-traumatic sixth nerve palsy with a very tight medial rectus. We again do a MR recession with SRT because we have shifted to SRT these days. We also get a very good alignment, and a little bit of abduction is also there in this patient following the SRT. This is another case where the FDT was relatively free. The patient had problems of diplopia and cosmesis. So the patient undergoes large MR recession with SRT and Foster's augmentation. There was slight overcorrection in the first post-op day, but then gradually he slipped back. There's slight ESO again, which is coming back to this patient. So in acute cases with no disc edema, we can do an observation. In children, there is no need for neurological evaluation. They should be examined every 2 weeks till the full recovery is there. If it is persistent for more than 3 months, then neurological evaluation is a must. Or if it is worsening, then a neurological evaluation is a must. For young adults, we should look for risk factors. For older patients, we should rule out diabetes, hypertension, atherosclerosis, and GCAs in pretty older patients. Patient with diabetes vasculopathy can have a good recovery. Patient with increasing esotropia, developing neurological signs and symptoms, a detailed neurological evaluation is a must. Occlusions can be done to prevent amblyopia, to prevent contracture of MR and allow phase turn. Prisms can be used for small angle deviations. They can increase the binocular diplopia free field for the patient. Botox can also be used in the acute phase as a temporary measure so that there is no contracture of MR. So in the end, I would just like to say that the careful assessment and a proper choice of procedure is the key to success in management of sixth nerve. Thank you.
Thank you, Dr. Ankur, for an excellent overview of managing sixth nerve palsy, a rather difficult surgery to do. So thank you. We'll go. Have we managed to correct the? So we go on. So in combination after sixth nerve, we go on to present management of third nerve palsy, and we have for that Dr. Anand Sethi. He recently completed a senior residency from RP Center in pediatric ophthalmology and strabismus. Rebecca introduced Dr.
Yeah, so well, as Sir just mentioned, he's our RPC alumni, and currently he's working as a pediatric ophthalmology and strabismologist consultant at Mirchia's Laser Eye Clinic, Chandigarh. And he would be presenting his talk on the management of third nerve palsies.
It is truly a proud moment for us. All of them have been senior residents here at RP Center at different times and all coming together, presenting some excellent surgeries, presentations. Is absolutely a matter of honor for us in RP Center. And thank you everybody for coming and making these celebrations a time to remember. Dr. Anand.
Good morning, and thank you, sir and ma'am, for the introduction. I'll be talking about oculomotor nerve palsy and its management. In the previous session, Professor Rohit Saxena has discussed about the surgical management, and I would like to add a neuro-ophthalmology aspect as well. So, beginning with the neuroanatomy, the third nerve, as we know, or the oculomotor nerve, supplies the superior rectus, inferior rectus, inferior oblique, and the medial rectal muscles. Also is responsible for the accommodation and the contraction of the pupil. The third nerve nucleus consists of many subnuclei, and the important part is that the central caudal nucleus supplies the bilateral LPS, and the superior rectus nuclei supply the contralateral superior recti. So the in nuclear palsies, sometimes if the subnucleus is involved, ipsilateral superior rectus may be spared and ptosis can be bilateral. Coming to the fascicular part, the etiology of lesion can be all same as the nuclear palsies, except it can be involved in demyelinating lesions as well. So we know these syndromes, that is the Weber syndrome, in which the third nerve nucleus with the cerebral peduncle is involved, and we see cranial nerve third nerve palsy with contralateral hemiparesis. And in the Benedict syndrome, in the medial midbrain, the involvement of the red nucleus and the medial lemniscus adds contralateral tremor as well as impairment of touch, position, and vibration sense. In North-Nagel syndrome, we have ataxia due to the involvement of superior cerebellar peduncle. And in Cloud syndrome, we have features of both Benedict's and North-Nagel syndrome. And we have the Perinaud syndrome, in which the dorsal midbrain is involved. It includes the involvement of medial longitudinal fasciculus, cranial nerve, fourth cranial nerve, and the aqueduct of Sylvius. This can lead to a pathological lid retraction and this convergence retraction nystagmus. on attempted upgaze. That is also associated with the vertical gaze palsy, superior oblique palsy, and hydrocephalus. In the basilar part, this oculomotor nerve lies in close proximity to the posterior communicating artery and can be affected by aneurysm of the posterior communicating artery and the junction of the internal carotid artery. This leads to total external ophthalmoplegia with involvement of the pupil. And in head trauma, the subarachnoid hemorrhage or intracranial bleed can lead to the uncal herniation and compression of the optic nerve at the tentorial margin. In intracavernous part, it runs in the lateral wall of the cavernous sinus, and in the anterior part, it divides into the superior and inferior division. It is accompanied by the cranial nerve 4th, 5th, and 6th, and can lead to painless or painful involvement of the oculomotor nerve in lesions like carotid cavernous fistula, granulomatous inflammation, as we see in Tolosa-Hunt syndrome. And multiple nerves are involved in these cases. And the intraorbital part, again, depending on the division which is involved, we can have different presentation of the oculomotor nerve palsy. And this is accompanied by proptosis and chemosis, usually because of the orbital lesions. Then the pupillomotor fibers lie superficially in the nerve and can be affected by compressive lesions like aneurysms or tumors. And thus pupillary fibers are involved in these cases. And thus we need neuroimaging in these cases. And something about aberrant regeneration. Aberrant regeneration may follow acute traumatic and compressive, but not vascular third nerve palsies, because the endoneural sheaths which may be breached in traumatic and compressive lesions remain intact with vascular lesions. So these include lid gaze dyskinesia, that is MR to LPS or IR to LPS dyssynervation, and pupil gaze dyskinesia as well. And it can be primary regeneration, that is a sign of intracavernous lesions. In these cases, the primary presentation is with aberrant regeneration without any previous involvement of the optic nerve. In this, we need a neuroimaging to rule out any cavernous sinus lesions. In secondary aberrant regeneration, old third nerve palsy may develop aberrant regeneration, and it can be seen in traumatic cases as well. So localization, depending on the presentation, as we have discussed. The important part is that the cavernous sinus lesions may present with primary aberrant primary aberrant regeneration, which needs to be evaluated. Then diagnosing when do we need neuroimaging? In isolated complete or partial internal dysfunction, that is only pupil is involved, then aneurysm possibility of aneurysm is very low. In partial external dysfunction without internal dysfunction, there is a moderate risk of seeing an aneurysm, and these patients need to be monitored for progression of third nerve palsy, and MR angiography may be needed. In complete external dysfunction with completely normal internal function, there is a very low risk of aneurysm, and these patients can be observed, and if there is no improvement in 4 to 12 weeks, then we can opt for angiography in these cases, and MRI, of course. Then partial external dysfunction with partial internal dysfunction, these patients again need to be observed for progression of internal dysfunction, that is the pupillary involvement. Then complete external dysfunction with partial internal dysfunction, or these are known as relative pupillary sparing palsies, in which anisocoria is less than 2 millimeters. Again, there is a low risk of aneurysm in these cases. Highest risk of aneurysm is seen in patients with isolated complete internal dysfunction, that is pupillary involvement, with partial or complete external dysfunction. Up to 86 to 100% cause aneurysms are responsible for these palsies. So coming to the surgical management, and surgical goals are to minimize the diplopia in straight ahead gaze and to increase the field of binocular vision wherever possible, and to improve ptosis whenever it is possible. Factors affecting decision making, whether the palsy is complete or partial, whether there is aberrant regeneration, whether the patient is willing to undergo surgery in the contralateral eye, and the status of the force reduction test and any restrictions. In cases where there is adduction beyond the midline, that is medial rectus function is present, we can opt for supramaximal recession and dissection procedures. In cases of aberrant regeneration, when there is a medial rectus to LPS aberrant regeneration, we can opt for the recession of medial rectus in the other eye, the contralateral eye, to improve the ptosis. And then we come to lateral rectus transposition procedures. These are indicated when there is the adduction is very weak and eye is not able to move beyond the midline. The forced duction test is negative, and there is poor force generation on AFGT. So the split lateral, split LR to MR transposition was in the modern version was introduced by Dr. Beeson Gokigit. It was prone to undercorrection. So at our center, we introduced the posterior fixation suture in these surgeries to improve the results. These the split LR to MR with posterior fixation suture is a non-adjustable surgery, and the results there can be misalignments post-operatively.
I think we can summarize,
yes,
Dr. Anil.
Okay, ma'am. Sure. So the adjustable lateral rectus to medial rectus transposition was introduced by Shah et al. And we can also do a full tendon medial transposition of the lateral rectus, and we can also tackle the vertical deviation in these cases by going through the superior or the inferior route. Then we have the periostal fixation of the lateral rectus in cases with a tight FDT where the transposition is not possible. And then we can also have a globe anchor to the medial orbital wall in severe, in total third nerve palsy with no medial rectus function. And yeah, that's it. Thank you. Thank you for your attention.
Thank you very much, Dr. Anand. Excellent presentation overview of managing third nerve palsy. I think we have got the link back with Dr. Sujit. So we'll go back to his talk on adjustable strabismus surgery.
Dr. Sujit, if you could share your screen, please.
Yes, ma'am, I'm sharing.
We would request the speakers to stick to the timeline. Are you able to share your screen, Sujit?
1 minute, ma'am.
Yeah, please. Yeah.
Can you see my screen now?
No, Sujit, we can see you, but not your screen.
You cannot see my presentation?
No, Sujit, we can only see you.
Maybe we can.
Again, I think, Sujit, we'll just come back. We'll go on to Dr. R. Muralidhar and his talk on Duane's retraction syndrome management options. Dr. Muralidhar, again, another old RPC alumnus, but he has experience of among the best institutions. Of course, after RP Center, he's had experience with Shankar Nethralaya and Arvind, and now he's working with the Eye Foundation at Coimbatore and a sheet anchor for not only pediatric ophthalmology, strabismus, neuro-ophthalmology, but I think the right hand of Dr. Chitra Ramamurthy, who is the chairman ARC. So Murli has a lot of things on his plate. Welcome, Dr. Murli.
Thank you very much, sir. Thanks for the kind invitation. And really nice to see you, sir. Sorry, I could attend only virtually. So can you see my slides, sir?
Yes, Murli, please go ahead.
Okay, so thank you, sir. So I'll be discussing on management options for Duane syndrome. And so we basically divide Duane syndrome into two types for clinical purposes. One is esotropic Duane syndrome and the exotropic Duane syndrome. There are many classifications, but for purposes of management, we classify it into ESO and exo-Duane syndrome. So for ESO-Duane syndrome, please remember that for any Duane syndrome, you need to attend to the systemic associations. You also need to attend to refractive surgery and refractive error and amblyopia, but primarily we'll be discussing the surgical management. So for esotropic Duane traction syndrome, you can do either unilateral medial rectus recession of the involved eye or a bimedial recession. Please note that on the side of Duane's retraction syndrome, we usually go up to 4.5 to 5 millimeter as the maximum. If you exceed this, you run a very high risk of producing a consecutive exotropia, and your decision is guided by the force reduction testing. And you can combine with differential recession. I'll be discussing that in the slides to come. So for esotropic Duane syndrome, we have three main goals. One is to improve the primary position alignment. Second is to improve the abduction, and third is to improve the head posture. So we can consider transposition if there is no significant co-contraction, that is narrowing of palpebral fissure more than 50%, and no significant up or down shoot. So grade the abduction restriction. If it is 4-, then again we check the force reduction test for abduction, and if force reduction test is positive, combine it with a recession of the medial rectus. So the options, my preference here in Duane's is either for one vertical rectus transposition or for the Nishida transposition. So if there is insignificant co-contraction, as I mentioned, that is narrowing of palpebral fissure less than 50% or no significant up and down shoot, you can consider vertical rectus transposition plus or minus medial rectus recession. So if there is co-contraction, then this transposition procedure is to be avoided. So this is a patient with orthotropic Duane syndrome. The patient is orthotropic in primary position. There is no head posture. She does have a significant co-contraction, but unless the patient complains, we usually don't offer surgery for orthotropic Duane syndrome. So now the next patient, this patient has an esotropic Duane retraction syndrome, not the abduction restriction. This redness is because of allergy. She also has a narrowing of palpebral fissure that is roughly 50% of that in primary position. So we did a bimedial recession for this patient. By left side of around 4.5 and the right side around 5.5 on an adjustable. We didn't have to adjust. And this patient, the head posture was corrected and she was satisfactorily aligned in primary position. This patient had a large head posture, but the esotropia in primary position was relatively small. So I did only a unilateral medial rectus recession. So she had a small residual ESO in primary position. The head posture substantially improved. And I mean, she was satisfied, but maybe a bimedial recession or with the right on adjustable was also another option. She did elect for further surgery because she was perfectly happy with her head posture. This was a head posture pre and this was a head posture post. So this is yet another patient. This patient also has a unilateral left side Duane's retraction syndrome, esotropic Duane's retraction syndrome. But please note that she has a mechanical upshoot. Note that there is no hypertrophy of the left eye when she looks to dextroversion, but the eye jumps when she looks either up or down. So in addition to the medial rectus recession, I combined a Y-split of the lateral rectus, left lateral rectus Y-split. So in esotropic Duane's retraction syndrome, you need to pay attention to the head posture, to the deviation in primary position, and also to the presence of co-contraction, which in this patient was addressed with a Y-split. Note the severe upshoot here and resolution of upshoot with LMR recession and Y-split. So this patient doesn't have evidence of significant co-contraction. So the force reduction test for abduction was positive. So we did a left medial rectus recession with Nishida's procedure. Thanks to Ankur for giving the post-operative photographs, because the patient after surgery went back to Jaipur and Ankur updated me with the post-operative photographs. So the alignment is satisfactory in primary position. She had good resolution of the head posture. So just I'll just play the videos later if time permits. And now we come to exotropic Duane's retraction syndrome. So if the abduction is good, I'll share the videos at the end if time permits. It's not playing from the presentation, so I'll play it from outside. But exotropic Duane's syndrome, if the abduction is good, then we prefer to retain some of the lateral rectus function. So we do a large LR resection or a LR resection with bisplit, depending on the primary position deviation. I have no experience with the LR Farden, but it has been described. And if you decide to do LR deactivation, I combine it with an adjustable split VRT or a single vertical rectus transposition as a second sitting. And if the abduction is already substantially restricted, then you can consider LR deactivation. So fellow eye LR recession, please note that for isotropic, I mentioned that both eye bimedial recession can be done, but here fellow eye LR recession is controversial. So everything depends on the surgeon's choice. It could be done staged or simultaneously. Please note that transposition has 50% less effect than what you plan for sixth nerve palsy. And we need
Have we lost the connection? Can we reconnect with Dr. Modi? We seem to have lost the connection with Dr. Modi. So in the meantime, I think we'll have Dr. Digvijay start his presentation. If we get back with our connection with Dr. Murli, we'll go back to his talk. Next talk is by Dr. Digvijay Singh, who will be speaking on infantile nystagmus syndrome.
So Dr. Digvijay, well, he has been my senior resident at RP Center, and currently he's the director of the Noble Eye Care Center, Gurgaon. And also he's the president of Young Ophthalmology Society of India and the treasurer in Indian Neuro-Ophthalmological Society. So, sir, he would be presenting his talk on infantile nystagmus syndrome.
Thank you, Rebecca, Professor Rohit, Professor Tityal, for having me here at the RPC Foundation Day celebrations. And it's indeed a pleasure always to come back to your alma mater. You feel you never left it actually, but that sensation always remains. So I'm going to talk about infantile nystagmus syndrome, and I'll discuss a few cases basically, to show that it's not something that's very difficult. As residents, we always used to find a case of nystagmus and we'd be running away from it. But if you think of it logically, it's quite easy to manage. So infantile nystagmus syndrome is basically a congenital nystagmus. It would tend to present in the first 6 months of life. It's binocular. It's there in both the eyes. It's uniplanar. There is no oscillopsia, so there's no sensation of the world moving that the child will feel, or an adult who's had infantile nystagmus syndrome. It gets abolished in sleep. It is dampened by convergence. It increases on effort of on fixation effort, and there is a null point which is definitely present, and that's a hallmark. The null point may be in primary gaze or in one of the side gazes. In terms of symptoms and signs, typically, there would be some decreased vision because of this nystagmus, maybe some asthenopic symptoms. There is no oscillopsia. You can actually see a wriggly dancing eye movements there. The nystagmus itself could be jerk or pendular, and it may be associated with a squint or a DVD. And there is an ascending low phase on EMG. So that's just some of the features that you should be aware of in infantile nystagmus syndrome to make your diagnosis, particularly when you see it in adult patients. Now, management could be non-surgical or surgical. Non-surgical management basically is going to be optical management, giving glasses, contact lenses, prisms to induce a convergence that will help dampen the nystagmus. You could use botulinism, acupressure, certain medications like baclofen, and all have been described in the non-surgical management. But the definitive management for some of the factors that I'll cover now is surgical, but then also the nystagmus itself is not really changing very much. Surgical management can be done to induce adduction or basically convergence, because that's going to dampen the nystagmus. It could be to shift the face turn, the null position from a side to primary position, or it could be to dampen the whole nystagmus itself. or to reduce the amplitude of nystagmus. And so the first, that is the induction of adduction or convergence, can be done by bilateral medial rectus recession or weakening of the medial recti. This is there only where there is binocularity. That's where it will work. Shifting of the null position, we'll discuss some cases as well, can be done by one of the three procedures that's described here, whether it's Kestenbaum or Anderson's. And you can do a supramaximal recession of all 4 horizontal recti to reduce the amplitude of nystagmus. So most of the times, the surgeries on infantile nystagmus are actually being done for the correction of the face turn or an associated squint or DVD. And over time, different procedures have been described by different surgeons. But most often what we are using nowadays is the augmented Anderson's, where we are going to be doing enhanced recession of the yoke muscles based on the side of the face turn. But other than that, the procedures began with small recessions, which weren't all that effective, went on to include resections. But I think as of now, the larger recessions is what works best. So let's look at a few cases. The first case is a 7-year-old boy, and he's had a amblyopia in the past. You can see that the vision in one of his eyes, the right eye, is not all that good. There is some occlusion therapy that he's had in the past. He has shown some recovery, but not quite complete. And there is a manifest latent nystagmus. If we look at this video here while we see it play, so he's basically got a squint, as you can see, as well as he's got a slight face turn here. And you can notice the nystagmus, and we're having to correct his face turn in between, to show you in the video. So here, the first thing that comes is that what is it that we want to correct? So we want to definitely correct the, we want to correct the face turn. We also want to correct the intermittent exotropia that he's having. So that becomes an indication here. And since we saw that the dominant eye is the left eye in this case, so we know that we'll have to use that eye to correct the face turn of the nystagmus. So we're going to be doing an MR recession for that eye, but then we are inducing more exotropia, and therefore to correct that larger amount of exotropia now, you have to do bilateral LR recession. So that's how you will correct it. And if you look at this video in the post-op period, you can see that his face turn is corrected, his strabismus is corrected. Of course, you have to continue to emphasize that the need for glasses is there. The next case we see is a slightly older male now. He's recently got a computer job, and after that he started having a severe neck ache. He wasn't really bothered about his face turn earlier, but as you can see here, there is an intermittent exotropia, and the vision in both eyes is slightly different. He's got a dominant eye, which is his right eye in this case. And as you can see here, there is a face turn which is towards the left. So an intermittent exotropia, there's a face turn towards the left. The right eye is his dominant eye. So in this case, we can take advantage of the dominant eye as well as the exotropia and actually just correct one muscle, which is the right lateral rectus. That is going to give us a correction both on the face turn as well as for the exotropia, and that's what we do. So again, determine what you want to do, determine which is the dominant eye, and then make your plan for surgery. And as you can see here in the post-op, he's now reading quite straight, and he's been fairly comfortable. In fact, he's been in that job for now, I think the last 8 years or so that I know him there. So this is another case that you can see here. This is a patient who's an international patient who has come with nystagmus. He's had a squint surgery in the past in the right eye. There was an esotropia earlier. That eye is amblyopic, as you can see. So we know that the dominant eye here is the left eye, and that esotropia actually has led to a consecutive exotropia, as you can see in the picture here. And look at how substantial his face turn is. So he's reading here on the chart, and you can see that there's a strong face turn to the right as well for him. Again, we need to identify that the dominant eye is his left eye. We know that we need to now correct an exotropia, and he's got a right face turn. So just like the earlier case, we can do with just one muscle operating the lateral rectus in the dominant eye. That takes care of both the squint as well as the nystagmus in the face turn, and see how beautifully the face turn has got corrected, as you can see here. So the next case that I'm coming to is the case of a delivery boy. So he's basically, he was in one of the Swiggy or Zomato, I don't remember which one. He was a delivery boy, and he used to typically be riding his scooter with a little face turn, and he'd always be doing that, and it was becoming a problem for him. So again, he had an orthotropy, as you can see. There's no squint at all. There is a face turn, and this is a case. We know that the left eye was slightly dominant, well, almost co-dominant, but the left eye was slightly dominant. So we chose that eye, and we've done augmented Anderson's procedure. We've done a lateral rectus recession in one eye and a medial rectus recession in the other eye, so that we don't induce a squint. We maintain orthotropia as well as correct his face turn. And that's his post-op picture. He's been pretty happy after that. Not that I got any free delivery from him, but nonetheless, he's quite satisfied. Well, let's come to one more case. This is again an international patient who's had intermittent exotropia. There is a nystagmus, as you can see on this video, as well as a slight face turn, not a very large face turn, but there is a face turn nonetheless. And sometimes to look at the face turn, you actually have to make them read, lower and lower on the vision chart. Sometimes they don't have a face turn for the larger size or 660, but as you go down and down the smaller optotypes, that's when they start to show a face turn. So again, here we were able to document that there was a dominant eye, which was the left eye. Here we want, and the other interesting thing is that she was also having a substantial A pattern, as you can see here in the 9-gaze picture. So here we wanted to correct the intermittent exotropia, we wanted to correct the pattern as well as the face turn. So we needed to correct both the superior obliques. So we did, so we chose the dominant eye to correct the face turn, but that also induced a little more squint for us. Therefore, then we had to do both the lateral recti and both the superior obliques to correct the face pattern as well. And as you can see here now, afterwards, she's pretty happy and satisfied with her outcome, as well as the pattern is corrected and the exotropia is corrected. So if you approach infantile nystagmus syndrome in a logical manner, step by step, it's quite easy to manage. It's actually all simple logic. Thank you.
Thank you very much, Dr. Digvijay. A very difficult topic of infantile nystagmus syndrome, managing very, very well. And of course, you also show that RPC alumni, whether they are placed internationally or in India, are always international. So thank you, Dr. Digvijay. We'll go on to the next speaker, which is Dr. Gazella.
Hello, am I audible?
Yes, Gazella, you are audible. Thank you. So Dr. Gazella will be talking on non-glaucomatous optic atrophy.
I think
so basically Dr. Gazella, well, she's our RPC alumni who is currently working as a glaucoma consultant at LVPI Hyderabad, and also practicing pediatric ophthalmology and strabismology. So yes, Gazella, you can share.
We'll take you, Gazella, first, and then we'll go back to Sujit. So the Hyderabadis will be clubbed together.
Is my PPT visible?
No, I think you need to share your screen first. Yeah, now it's visible.
Yes, Gazella, go ahead.
Okay. So my topic today is non-glaucomatous optic atrophy. I'd like to thank everyone at RP Center for this amazing opportunity to join with this celebration, especially Professor Rohit Saxena and Dr. Rebecca. So I have no financial interest. Let's start off on a lighter note. Let's see, glaucoma and non-glaucomatous optic atrophy. Yes, both are evils for the eye, both having their own disadvantages and very similar in many ways, but of course different in quite a few ways as well. So how do we differentiate between the two? So first we have to take a proper history taking, look properly for any specific signs and revisit the history after examination. Of course, we have to know which diagnostic procedure to ask for and correlate between all of the above. So today we'll do a little bit about optic disc examination and see which are the key features which make it glaucoma and discuss a few cases and try to differentiate between the two. So first of all, we talk about optic disc size. Here we see two discs. One is larger in size, one is smaller in size, both of course having glaucomatous changes, reiterating the fact that we have to look at small discs very properly from the glaucoma point of perspective and from the ischemic optic neuropathy perspective as well. So cup disc ratio has no meaning. As we can see here, all these discs have different cup disc ratio, but all of them are healthy. We have to remember the isn't rule, where inferior rim is usually the thickest and the temporal is the thinnest. So some features which are specific for glaucoma, one is notch. Here we can see two notches of different sizes, both of them corresponding to the corresponding visual field effect. We have to differentiate between normal RNFL, like here, where we see the normal striations superior and inferiorly. And we have to be able to identify an RNFL defect as seen here inferiorly. Disc hemorrhages, of course, more specific to glaucoma, especially normal tension glaucoma. And usually they will leave an RNFL defect. So the first case was a 47-year-old male who had a history of being diagnosed as glaucoma elsewhere. He was on timolol, but he had no family history of glaucoma and no history of use of steroids, and he was hypertensive. So his vision was 20/20 and IOP was 15 and 14. If we look at both his discs, first we may say that there is inferior thinning of the rim, but more marked than that is the temporal pallor with a few hypertensive retinopathy changes. If we look at the red-free filter, here we can see superior and inferior RNFL is normal in both the eyes, but there is loss of the PMB fibers, papillomacular bundle fibers. So we did visual field. Here we see a sort of a centrosacral scotomas on both eyes, even on 10-2. When we did RNFL OCT, we confirmed that there was loss of RNFL fibers temporally with corresponding loss of GCC nasally. Slides are not moving. So yes, we revisited the history, and he said that he was unable to read because he had focusing problems, most probably due to those scotomas. And so we asked, he was a vegetarian by diet, and we called him back for color vision contrast, which was deranged. And he had vitamin B12 deficiency ultimately after we did quite a few blood investigations, and we treated him for the same. So case 2, we have a 67-year-old female diagnosed as glaucoma elsewhere, also started on AGM, had a history of pulmonary TB, but she was treated. She's also a hypertensive. Vision was 20/40, 20/30 parts. IOP was 16 and 18. And if we look at both her discs, it looks like she has bipolar excavations, seeming to be like glaucoma. And pallor was obviously there. Looking at the red-free filter, we can see that because of the CR degeneration and the cataract, we could not really make out the RNFL. We did a visual field. On first look, it may seem to be like a biarcuate scotoma, glaucomatous visual field effect. When we looked at the 10-2, it seemed to be respecting the midline, the visual field effect. So we asked for imaging and finally diagnosed her to have an acute on chronic infarct and left-sided PCA with chronic infarcts on the right side. So we had to send her to a neurologist and physician. The third case, a 45-year-old female who came with decrease in vision in the left eye for 6 months. Also, again, diagnosed as glaucoma. She had stopped the medication herself. She had very less vision in the left eye, hand movement, and IOP was normal. So we did a visual field of the seeing eye. This is the optic disc photos. Right eye, of course, we can see healthy with healthy RNFL. Left eye had cupping, and there was a kind of inferior notch with superior excavation. On doing visual field of the seeing eye, it was normal. So we diagnosed her as query NEIO and query NTG. We did blood investigations for the same, which were all normal, and she was lost to follow up. And when she presented again, she came back with this visual field effect of the seeing eye. And after we did imaging, we found her to have a pituitary mass. So another case, 17-year-old male who was also on timolol and had no family history of glaucoma, 20/20 vision with 16 IOP in both eyes. These are his disc photos. So here, of course, we can see kind of superior excavation with corresponding supranasal RNFL defect, more clearly seen on the red-free filter. And after we did visual field of the patient, he had these inferior field effects in both the eyes. And we did RNFL, of course, no normative data for his age, but there was superior loss and corresponding temporal loss of the GCC. So we came to the diagnosis after doing DDVT and it was normal range, we came to the diagnosis of SSOH. So I will not go into the details of SSOH, just that it is similar to NTG because of rim thinning, normal IOP, RNFL defect, but it is different because it is in the supranasal region and there is no progression with time as seen on this GPA analysis. So yes, evaluation of the optic disc can be very subjective. Even specialists can make some mistakes. So we have to correlate everything from the vision to the investigations, like a few differences, usually glaucomatous, of course, not always, will usually be in the elderly. There will be a family history, central vision will usually be preserved. Even color vision, pupil reaction will be normal, except in very advanced cases. And there is difference in both the optic disc, wherein glaucomatous will be more deeply cupped with excavation, usually superiorly, inferiorly, whereas in non-glaucomatous, it will be more in temporal. And usually residual rim is pink in glaucomatous. Dishemorrhages are common. And as we saw in the cases just now, that the visual field effects are also very different. And we have to correlate between the disc and visual field effect, which usually will not correlate in case of non-glaucomatous optic atrophy. So we should always be able to differentiate between the two, because we cannot just advise AGMs for everyone, because there are adverse effects of AGMs, which we should not subject the patients to. And also we have to diagnose cases which can be life-threatening. So the take-home message is we have to do proper history taking. We can revisit the history after we have done all the examinations. We have to concentrate on color vision, contrast, pupil reaction, and do a red-free examination of the disc always. Do a visual field and correlate it. And if there is progressive visual loss, even after you have achieved this low IOP, we have to reassess the patient. Thank you.
Thank you, Gazella, for an excellent presentation. We will go back to Dr. Sujit. Hopefully, yes, he has been able to do his screen share now. He'll be speaking on adjustable sutures and strabismus surgery in place of Dr. Asha, who couldn't join us. Thank you, Dr. Sujit, for taking her place and your presentation.
1 minute. Yeah. Lovely good morning. Sorry for the inconvenience. I'd like to thank Dr. Rebecca ma'am and Rohit sir for giving me the opportunity for presenting in RPC Day. So there is no surgery in general which can give 100% accurate results or ideal results, but one technique in strabismus surgery is which can achieve target angle or make patient diplopia free, or both, is an adjustable technique. There are several factors that decide surgical response, which can be quantifiable, like preoperative angle, age, incompetence, like pattern deviation or near distance disparity, axial length, refractive status. And there are non-quantifiable factors like paresis or restriction. And still there are unknown factors like neuronal inputs, accommodative and fusional mechanisms, and number of sarcomeres, which can be vary from person to person per unit. So small history, Bilshowski is the first person who described the adjustable suture technique in early 19th century, before which there were recessions and tenotomy procedures. And later O'Connor proposed cinch shortening loop. But adjustable technique was popularized by Jampolsky, who introduced a bow tie knot technique. So basically the procedure in adjustable suture technique is we attach the hanging suture, which can be adjusted accordingly based on the angle. Still, there are factors that can change the effect of target angle, like healing process, edematous tissues, like especially the tenons, patient's ability to focus, and the change in length tension curve while adjusting. Adjustment can be done 4 to 24 hours, or it can be delayed as late as 6 to 14 days, but there will be discomfort and additions, which if some people have advised use of sodium hyaluronate during the primary sitting itself, so that adjustment will be easy. So the indications are wherever the results of conventional surgery are unpredictable, like large angle strabismus, restrictive disease like thyroid disease, post-RD surgery, paralytic strabismus, especially cyclovertical paralysis like bilateral superior oblique palsy, previous trauma, resurgeries, etc. And an uncooperative patient is an absolute contraindication, and these are some of the related contraindications. And while adjusting, one should be careful about patient having oculocardiac reflex, possible bradycardia, nausea, syncope, so that care should be taken that he may not end up in complication. And this is a surgical diagram showing a bow tie technique in which sutures are tied together in a single loop bow, similar to the shoelace. If you want to adjust, we can release the suture and tighten or loosen accordingly. And this is a sliding noose technique, where a noose is created between the distal pole and the tie and this insertion side. And this suture can be adjusted accordingly based on the deviation required. And special cases like pediatric cases, for esotropias, immediate post-operative in the recovery, we can assess the angle, and we can adjust by using a topical proparacaine, or IV propofol also can be used. And the releasable adjustable suture technique has also been described in children, where a 1 to 2 mm additional recession can be achieved in case of residual esotropia by just releasing the suture. An adjustable inferior oblique technique has also been described, where a suture is left in between distal and proximal part of inferior oblique, so that over elevation in adduction can be titrated. And similarly, adjustable Fayden surgery, semi-adjustable suture described by Kushner, where central sac can be created or advanced based on the required target, or adjustable superior oblique technique for Brown syndrome, where chicken loop suture can be titrated accordingly. So I'll be discussing a case of 6-nerve palsy, which was admitted in RPC during my residency. He was admitted basically for esotropia, but on complete examination, the patient not only had a recovered 6-nerve palsy, but he also had a bilateral traumatic optic neuropathy. And this patient had a bitemporal hemianopia. Though the squint was not appearing that much, the patient on examination was mainly complaining of central vertical strip scotoma. He was mainly taking right face turn while navigating. So the patient is having this kind of picture. This is a courtesy from IVK. He had a central scotoma like this vertical strip on primary gaze. So he was taking a face turn for compensation. So at that time, Professor Pradeep Sharma had planned for LR application 8 mm and MR adjustable recession. This is a surgical video. I'll directly jump to the recession part. LR application has already been done, and MR recession with hemi hangback was done. This is a 3.5 mm scleral bite, and 6 mm additional recession from insertion site has been placed, and a bow tie suture has been passed, and a knot has been placed with the 60 silk. And this is a traction suture on the conjunctiva, which can be adjusted accordingly post-operatively. And post-op, after 4 hours, the patient complained of diplopia. Basically, what happened was the patient had a overcorrection, because of which the nasal overriding of nasal field happened, and patient was complaining of diplopia. Is the voice audible? There is a voice over on this.
See how to adjust the sutures after medial rectus recession.
I think it's not audible. So basically, what was done was this is a releasable suture. On pulling this, the suture will open up, and short and long suture has to be identified, and we just pull the suture, the knot will open up.
In the following,
see, we have opened the loop, and the suture has opened up. Since the patient has got overcorrected for esotropia, we are just advancing the recessed MR
of the adjustable suture. Pull the short end completely, and
we're just going to pull this 60 silk.
Both ends to tighten.
And we have tightened the MR so that the final position will be 3.5 from the insertion side.
For the resolution of diplopia.
And we'll just cut the sutures once the patient is diplopia free. This is the post-op picture. The field effect has resolved and the patient was happy. So the final take-home message was, is adjustable suture technique useful in difficult situation to prevent large over or under corrections? Although may not be used in routine simple squints, it is indispensable for certain patients. Thank you.
Thank you, Sujit. Thank you very much for taking us through adjustable strabismus surgery and showing the video of the 1.5 knot and its adjustment. We'll now go on to the next presentation by Dr. Saranya. We will be now going from the strabismus part to the neuro-ophthalmology, and Dr. Saranya would be speaking on Leber's hereditary optic neuropathy. While she was with us, she had done some extensive work on LHON. Dr. Saranya.
Thank you, sir. Thank you so much for your kind introduction.
So Dr. Saranya is currently working as a consultant of ophthalmology in MIOT International, Chennai. She has also served as assistant professor in Sri Ramachandra Educational and Research Institute. So Saranya, if you could present.
Thank you, Dr. Rebecca. It's my pleasure to be back to RP Center. It's like home away from home, I should say. Thank you so much, sir, for giving me this opportunity. And moving on, Leber's hereditary optic neuropathy. It is a maternally transmitted disease, and because of mitochondrial mutations, and it occurs mostly in young males in the age group of 15 to 35. Even though extremes of ages have also been reported, the incidence is 1 in 30,000. And because it is mitochondrial, the affected mother can transmit the disease, whereas the affected father will not be able to transmit the disease. So this is what happens. This is a beautiful picture in which you can see the mitochondria inside the optic nerve. So what exactly happens in this mitochondria is that the transfer of electrons happen. That is, the energy is produced in the form of ATP from the food we eat in the level of mitochondria. So various complexes are involved in the mitochondria, like complex 1, 2, and 3. So whatever happens with LHON happens in the complex 1. So the end product is the ATP generation is stopped. This happens mostly because of the genetic mutations. These are some of the common mutations, that is 11778, 3460, and 14484. So this is the most common mutation, and it is most severe also. The 14484 carries better prognosis, and 3460 serves as an intermediate between these two. So this is the pathophysiology. As already told, because of the mitochondrial mutations and along with the environmental factors like cigarette smoking and alcohol consumption leads to this complex 1 deficiency in the mitochondria, because of which ATP is not produced. Since ATP is not produced, the cells lack energy. So the end result is retinal ganglion cell death, leading on to optic nerve degeneration. We have done a study about the frequency of primary mutations of LHON patients, and we found that most of our patients, that is almost 27% of our patients, had 11778 mutation. And the signs and symptoms are patient present with acute painless loss of vision. It starts in one eye and then it can involve the other eye after weeks to months. So it is sequential involvement. The patient will present with vision loss in color vision, and the peripheral vision is usually spared, and the fundus picture is a pseudoedema kind of picture. So based on these signs and symptoms, and also along with the mitochondrial mutations, we can come to the diagnosis of Leber's hereditary optic neuropathy. So this was just a brush up of the basics. So is there any treatment for LHON? Usually we prescribe conservatively multivitamins or elements like coenzyme Q have been prescribed, but there have been lots of improvement in the past 4 to 5 years in this field. So there are some agents like mitochondrial modulating agents, and those agents which inhibit the apoptosis, and gene therapy specifically. A lot of research has gone into the gene therapy, stem cell therapy. And if at all, if patient presents in the later stage, low vision aids, and most importantly, avoidance of stresses. Once we diagnose the patient, we have to tell them to avoid the stresses like smoking and alcohol consumption. And we'll talk in detail about each of these agents. The modulating agent of mitochondrial electron transport chain, coenzyme Q, and idebenone, and cysteamine, and KH176. All these elements act in the mitochondrial level. They act as electron carriers. So a special mention has to be made about the idebenone. Idebenone is usually used in cases of Alzheimer's disease and other diseases like Duchenne's muscular dystrophy. Research has happened in the area of LHON also. Idebenone, what it does is it transfers the electrons directly to complex 3. So even if complex 1 deficiency is present in LHON, they carry the electrons directly. So the ATP generation keeps happening. So that is why idebenone is helpful in these cases. This is a wonderful study which was done, the RODOS, that is a rescue of hereditary optic disease outpatient study, in which they have given idebenone to these patients. Even though the change in BCVA was not observed, in the post-hoc analysis, they found there was change in the mean visual acuity. So this was a promising study, but the problem is they gave in a dose of 900 milligram per day. The usual dosage available in the market is only 90 milligram. So procuring the drug in itself is a big task. So further developments had to be done in that area. And they did a follow-up study also, in which they found that even after discontinuation of the therapy, there was beneficial effect in the form of maintenance of visual acuity. So even after the cessation, the patients had beneficial effect in their study. The other agents like those which inhibit the apoptosis, trials are going on, but the results are not yet available. You should just know the name, that is elamirotide. Gene therapy, a special mention has to be made about gene therapy because in the past 5 years alone, a lot of research has happened in the gene therapy. There are various modalities by which gene can be introduced: allotopic rescue, mitochondrial incorporation, gene shifting, or nuclear transfer. So the gene is associated with adenovirus is injected intravitreally, and the effects have been seen. We might have little concerns about the side effects because of the introduction of virus, but there were studies about the side effects and safety profile also, and they concluded that not much of side effects have been noticed. So they went ahead with human trials. These were a few trials which were conducted in 2016. They showed improvement in visual acuity in almost 6 of the 9 LHON patients. And this Guy et al. Showed favorable results in patients using low and medium doses of allotopic gene therapy also. There are some recent developments like rapid increase in visual acuity was also noted after gene therapy. And the interesting part is that even if gene therapy was injected in one eye, the effect was seen in both the eyes. Some say this might be because of the possible spread through the chiasma. That is, the virus is injected into one eye. It might possibly spread to the other eye through the chiasmatic region, or it can be because of the placebo effect, because in all these trials, sham injection was given to the other eye. So this may be a placebo effect also. And some suggest that it might be because of the spontaneous visual recovery. So we don't know what exactly was it. There are a few named trials which I'm going to mention. One trial is rescue. As the name indicates, even before the visual damage occurs, that is in acute cases, the injection is given, and they have noticed visual improvement at weeks both 48 and 72. And the next trial is reverse. As the name suggests, to reverse the optic nerve damage after 6 months, and within 1 year they have injected, and there was a continuous improvement which was noted. Actually, rather than expected, instead of acute cases, in chronic cases, the reverse trial showed better effects even than rescue trial. Reflect is another trial in which bilateral injection has been given and the reports are awaited. So the last, this is the last slide. So stem cell therapy, stem cell ophthalmology treatment study showed improvement in visual acuity, but again, further research is warranted. So I request Professor Rohit Saxena sir to pursue further research in LHON and consider doing gene therapy studies in future, sir. Thank you for this opportunity. It's so nice to be back in RP Center after years. Thank you so much, sir.
Thank you, Saranya. Thank you very much. Yes, we hope to be part of an international trial for gene therapy. Of course, there are a lot of regulations in India, unfortunately, that have prevented us from going forward for gene therapy. But yes, thank you for an excellent overview. In fact, bringing us up to date with all that is going on in the world for LHON, something that is very, very disheartening, because we have these young, predominantly males in their peak age, when they are looking forward to so much in life. They come with severe visual loss bilaterally. So that's a very unfortunate experience for them and for us. And we hope in future we should be able to do something more for them. We'll go on to the next talk by Dr. Anita Gangar, who will be talking on OCT in neuro-ophthalmology.
Dr. Anita Gangar and myself, we both have been together as senior residents and then senior research associate at RP Center. And currently, Dr. Anita is working as associate professor at Sir Gangaram Hospital, New Delhi. So Dr. Anita would be presenting her talk on OCT neuro-ophthalmology.
Very good morning to all. Thank you, Dr. Rebecca, for the kind introduction. And I would like to say thanks to Dr. Rohit sir and the whole RPC team for giving me such an opportunity. It is indeed a pleasure to come here. So I'll be discussing OCT neuro-ophthalmology. I have no financial interest to disclose. So OCT is a very quick and reproducible tool which is based on low coherence interferometry, which gives us a cross-sectional images of retina and optic nerve head. So just a brief outlook of the print, OCT print, what we get. So the upper part gives us the patient details, and then the second section tells us the scanning protocol, then the RNFL thickness maps, then the summary of the parameters protocol, then the retinal nerve fiber deviation map, and then we get the retinal nerve fiber thickness graph. And here it shows the retinal nerve fiber thickness as per the different quadrants and the clockwise distribution of the retinal nerve fiber thickness. So my points of discussion would be the imaging parameters useful in assessment of neuroophthalmic diseases, the disease-specific OCT findings, and the pitfalls to be aware of. OCT in neuroophthalmology, it actually represents a surrogate marker of neuroaxonal integrity in the afferent visual pathway. It helps us in diagnosing the disease monitoring, and to prognosticate the disease. So most variable structural parameters in OCT, we've found RNFL thickness and the GCL thickness. So first, coming to the optic neuritis, the most common neuroophthalmic disease, OCT can be used as a quantitative tool to monitor the course of a treatment. Initial spike in RNFL thickness due to axonal exoplasmic flow stasis can mask the earliest sign of axonal degeneration. So here comes into picture the macula OCT scan, where we see the GCL layer thickness, which is an important adjunct to the RNFL. So this study done at Dr. RP Center, which evaluated the changes in the retinal nerve fiber thickness and the visual functions in the optic neuritis and the multiple sclerosis patient, and concluded that RNFL thickness is reduced in optic neuritis as well as multiple sclerosis patient with and without optic neuritis, and the pattern was similar to the Caucasians. So there is another study, I was part of this study. Here the retinal nerve fiber layer and GCL layer changes were observed on OCT in an early multiple sclerosis patient. And the study concluded that GCL IPL thickness is more sensitive clinical structural marker than the RNFL in early MS patients. And it correlates with all the visual parameters better than RNFL thickness. So this patient, MS patient with optic neuritis in the left eye, we can see the initial spike of RNFL thickness, increased RNFL thickness, which was masking the axonal degeneration. Second patient, she was 21-year-old female patient, had a resolved optic neuritis in the right eye. And here we can see the RNFL thinning. So NMO spectrum diseases, how we can differentiate these from the multiple sclerosis. Normally RNFL affected in all the peripapillary quadrants in NMO patients, whereas in the optic neuritis, mostly the temporal quadrant. In NMO patients, normal RNFL values are seen if there is no attack of optic neuritis, whereas in MS patient, even without the optic neuritis attack, the values are affected. Mean RNFL loss is around 20 microns in MS patient, whereas it is profoundly high in NMO patients, and higher prevalence of microcytic macular edema is observed in NMO patients. So then comes to the ischemic optic neuropathies. OCT can be used to identify the treatment effects. Thickness of macula, OCT, and GCL complex is expected to provide a better structural indicator of axon preservation and loss. And sometimes distinctive altitudinal pattern of ganglion cell loss can correspond with the altitudinal visual field effect in a patient. So this was a acute NAION patient, 50-year-old male patient, showed RNFL thickening in an acute phase, but yes, GCL IPL is showing the abnormal thinning. So here, this was a patient of NAION 3 years back, showing the thinning of superior-temporal sectors of the peripapillary RNFL. So one point to consider is the floor effect. OCT limits the detection of progressive RNFL GCL loss above the 30 to 50 microns. So it should not be interpreted in isolation. And after the MS studies, future role of OCT in Alzheimer's, Parkinsonism disease is getting established. So then comes to the papilledema, where we can quantify the edema, disc edema with the OCT, and RNFL measured with traditional OCT scan cannot differentiate whether the disc edema is decreasing due to the reduction in ICP or ongoing axonal loss. So here GCL can tell us better that decrease in GCL indicates that axons are all indeed dying off. So here the patient of unilateral disc edema showing normal, showing the edema in the left eye, but the GCL IPL thickness was normal despite a RNFL thickening at present. So here the prognosis of the case is good. Another patient of bilateral papilledema, where the RNFL thickness was increased along with the GCL IPL thickness decreased in that acute phase as well. So we can prognosticate the case accordingly. So there was one study by Mark J et al. Where they had shown that there's an inward positive angulation of peripapillary RP basement membrane relative to the peripheral peripapillary regions. And in their study, they have documented the straightening of this angulation with the reducing disc edema. Papilledema versus optic disc drusen, yes, in thinning of RNFL and GCL is normally noted in ODDs. And there is a subretinal hyporeflective space can be seen between RP and choriocapillaries, which can be suggestive of ODD. And for buried ODD, usually enhanced depth OCTs are better. In optic atrophy and LHON, we usually see the gross RNFL and the GCL thinning. OCT in pituitary tumors, a study done by John J. et al., they have shown that even before the visual defects come in a pituitary tumor patient, we can see the nasal hemiretinal ganglion cellular thinning corresponding. So this is a very important adjunct. OCT can be proven in pituitary tumors. So what are the pitfalls? Different machines use different protocols. So patients should be reviewed on a same machine with the same scanning protocol. All the OCT measurements are compared to the normative data of Caucasian subjects, so which must be considered, especially while observing the pediatric patients. An actual placement of measurement area should be checked and amended if manually it is needed. Thank you so much for the kind attention.
Thank you very much, Anita, for an excellent overview of OCT, the role of
Thank you
OCT
so
in
much, sir.
neuro-ophthalmology. We'll now go on to the last presentation, which is investigations and management of IIH by our very own faculty, Dr. Swati Punjale. She is pediatric ophthalmology, strabismus and neuro-ophthalmology, heading that part in Unit 1. Along with Dr. Rebecca, and has done extensive work in neuro-ophthalmology. Dr. Swati, please.
Thank you, sir, for that introduction. It's indeed looks like an RPC Foundation Day. We have alumni from all over India. Some of them have been international also. So yes, keep the RPC flag flying high. With that note, I am going to talk about IIH today. So IIH as idiopathic intracranial hypertension, as we all know, is a disc edema which is secondary to the elevated intracranial pressure. And due to the increased incidence of obesity, there is is associated with increased incidence of IIH also. It has been seen that moderate weight gain around 5 to 15% is associated with the greater risk of IIH as compared to non-obese patients. Of course, one must rule out other secondary causes of IIH like systemic causes and medications, and also hematological disorders. So clinical features, as we all know, are headache, which is diffuse, more worse in morning and increases with head movement. It is generally associated with nausea, vomiting. Photophobia may or may not be there. Diplopia may be present because of the abducens palsy, pulsatile stenitis. What is more common and the more morbid complication of IIH is the visual impairment. What was once considered as a benign disease is not benign anymore, and the visual loss is seen in around 40% of patients, out of which around 10% may actually land up in blindness. So the clinical diagnosis still remains a diagnosis of exclusion. More or less, the diagnosis is a clinical diagnosis depending on the modified Dandi's criteria or Friedman criteria. The diagnosis depends in presence of the classical clinical symptoms along with the normal neuroimaging. So this fact has to be very, very stressed upon, that the neuroimaging, whether we want to do CT scan, MRI, and MRV as well, should be normal to call that patient as an idiopathic intracranial hypertension, along with the raised LP pressure. So in absence of papillary edema, there are certain subtle soft signs which may point out towards the IIH, but it's not always confirmatory. And one must always diagnose IIH with caution in absence of papillary edema. So certain signs on brain MRI, the most important thing is to rule out any intracranial lesion, space occupying lesion. Along with that, if you have features like distension of perioptic subarachnoid space, partially empty cella, flattening of posterior sclera, and increased tortuosity and elongation of orbital part of optic nerve, all these are very soft signs that may point towards the IIH. It's also important to rule out cortical venous thrombosis on MR venography. Visual field analysis, the most common kind of visual field defect seen is blind spot enlargement. There may be generalized peripheral suppressions also in these patients, but the more importance of visual field is also in the monitoring of disease. So once the patient has developed the visual field defects, it's important to monitor the visual field to understand whether the disease is progressing or improving with the treatment. Role of OCT, as just highlighted by Dr. Anita, I'm not going to get into detail of it, but yes, it's an important way to diagnose these optic disc edema from pseudoedema, particularly disc drusen. The another important role, of course, to monitor the effect of the treatment and also determine the cause of the loss of vision. So serial loss, so the serial decrease in RNFL layer on OCT will give you a false sense of security that this particular patient is improving, as you can see from this example where the patient had raised RNFL thickness, which gradually came down to the normal level over the 6 months. But then this patient also had the thinning of GCL layer. So let's not just go by the RNFL thickness layer. We should also look at the GCL layer. Around 30% of patients who have normal RNFL may have low GCL. So that may be the most important cause of poor recovery of vision in these cases. Then in our study, we also found that it's the GCL which correlates better with the visual field, mean deviation on visual field, and also visual acuity. So the management is mainly targeted at the management of prevention of loss of vision and also the management of headache. So these are the two important symptoms that need to be taken care of whenever we are managing a case of IIH. So removal of a cause, if any, is the first line of management, followed by weight loss. A lot of emphasis is nowadays is being given on weight loss because the results that the studies that have been done have shown that the weight loss management definitely helps in decreasing the edema. Medical management in form of acetazolamide and surgical management. So it has been seen that the weight loss of around 6 to 15% leads to early resolution of papillary edema. And in our study also, we found the similar results. We found that the patient who had more change in BMI had greater increase in visual acuity, greater gain in visual acuity, a better improvement on mean deviation, which correlated with more decrease in BMI. Even the grades of papillary edema when decreased with the decrease in BMI. So this just shows that how important weight reduction can be in these cases, and it's now considered as the primary mode of management and the first line of therapy where the visual field loss or the visual acuity loss is minimal. Then the medical management, the treatment of choice is acetazolamide. A recent study, IIH treatment trial, has given us as now a clinically based evidence that the greater improvement is seen in mean deviation if we use acetazolamide, and also there is greater improvement in grade of papillary edema. So the initial starting dose is around 1 to 1.5 gram, with maximum recommended dose of 4 grams. But unfortunately, this kind of dose is not tolerated by patients. So most of the patients actually sometimes end up in using less than required dose. The common side effects are, of course, paresthesia, lethargy, altered taste, and hypokalemia. Another important drug that is now being used in management of this disease is topiramate, which is basically a carbonic anhydrase inhibitor, and at the same time also suppresses the appetite. So it's not only just helps in management of headache, it also helps in management of weight. So these are the two important medications that is used nowadays. Coming to the surgical management, so indications are very clear. If there is a rapid, acute, progressive vision loss that has been documented on follow-up, and also in the patients where the medical treatment is failing. So these are two common indications for the surgical management of the case. So there are particularly 3 types of surgical procedures that need to be performed. So cerebral fluid diversion procedure, vetroperitoneal shunt, or ventricular arterial or lumboperitoneal shunts are used, optic nerve sheath decompression, or venous sinus stenting. So this is just a small video to show ONSF. So we go through the limbal approach because the exposure is better, just like in strabismus surgery. Hook the muscle, separate the muscle, secure it with 6-0 vicryl. Again, cut the muscle. These are the non-absorbable sutures. Pass through the stump of the muscle, box sutures. Then once the sutures are passed, so when you retract the globe medially, the sutures help in retracting the globe. Retract the globe medially, and you can see there's a lot of fat over there. That's the common problem with these patients because they are obese. There's a lot of fat over there. We need multiple retractors to retract that fat, to remove that fat from the way. Expose the optic nerve. It can be identified by the presence of vessels, central retinal arteries, and central retinal vein. Then you can enter with a keratome, give a nick till the fluid gushes out of the sheath. And it's not just important to, make a slit over there. Just like in trabeculectomy, we make a window, a small window is made in sheath also in this case. And then the muscle is sutured back at its original insertion and conjunctiva is closed. So it has its own complication in form of anisocoria, double vision, optic nerve head hemorrhages, trauma to optic nerve, and arterial occlusion. But what is more important to note is that these effects, whether they are CSF diversion procedure or venous stenting or ONSF, these are all temporary measures. The long-term goal still remains the management of weight. So to conclude, if there are clinical features of IIH suggestive of papillary edema, please do a neuroimaging to rule out any intracranial space occupying lesion and cortical venous thrombosis, LP, which should be around 250 mm or more. If all these causes are ruled out, we can diagnose IIH, but also look for these secondary causes. As far as management is concerned, if the minimal visual loss is there, the medical management has to be considered. But if the vision loss is severe, ONSF has to be done. And if headache is the more prominent symptom, then CSF diversion procedures are what is needed. With that, I conclude. Thank you.
Thank you, Dr. Swati, for an excellent overview of the IIH and its management. I thank everyone for being a part of this pediatric ophthalmology, strabismus, and neuro-ophthalmology session. As you can see, we are not only proud of our alumni who have done exceedingly well, but it's always a pleasure when they come back and present here and interact with us. So thank you everybody, including our alumni, for being a part of the 55th Foundation Day celebrations. And we'll now move on to the orations at the main auditorium. Thank you, everyone.
Thank you so much, everybody, for joining in. Thank you so much for all the doctors, the chairpersons, moderators, and panelists. And thank you so much for all the speakers to value the time. And we will see you all at the next session at 1:30 p.m. Thank you so much, everybody. Hello, everybody. A very warm welcome at the 55th RPC Annual Foundation Day celebrations. So our today's session is going to be about marching forward in ophthalmology. I would just quickly like to announce the speakers we are going to start with. If they are here, please join as panelists so you can conduct your sessions. We'll be having Dr. Santosh Hunawar, V. Sujata, Swapna Nair, Gitansha Sachdeva, Pooja Khamar, Colonel Vijay K. Sharma, Dr. Nupur Gupta, Dr. Sumit Lahani. Oh, we have our panelists here.
I think Vanati ma'am is mute.
Podium is on mute. So I'll have to repeat all that all over again, I guess. So Dr. Nupur and Dr. Rachna will be co-chairing along with me. Praful, Shikha and Lomi is here to moderate along with our panelists, Dr. Amar, Sharath and Afreen. We have none other than Dr. Santosh Hunawar, who is the pride of our RPC alumni. And I think he needs no introduction, with phenomenal work both in academics and as the editor of Indian Journal of Ophthalmology. He's taken IGO to heights as never before. Hearty congratulations to Dr. Hunawar on this fantastic achievement, and over to you on ocular surface tumors, what is new?
Thank you, Vanati, for the kind introduction. It's a pleasure to be at RP Center Alumni Day and present to you recent advances in ocular tumors, ocular surface tumors. I'll be briefly covering imaging, topical therapy, surgery, plaque brachytherapy, and target therapy as well. Imaging has revolutionized the management of medical retina, and so it has revolutionized the management of ocular surface tumors. For example, these are 4 pigmented tumors that you have here. Sometimes you wonder whether a pigmented tumor that you're looking at is a nevus or a melanoma. Of course, there's a clinical checklist, which is very useful. Presence of microcyst is supposed to be diagnostic of a nevus, whereas melanoma is more solid. And if you have any doubt at all, you can do anterior segment imaging. And if you see microcyst, then obviously it confirms a nevus. Clinical application is in this child who's just 12-year-old with a fleshy pink lesion. You don't know whether it's a nevus or a melanoma. It has vasculature as well, feeding vessel, and there are intrinsic vessels as well. It is breached the limbus and abutting against the cornea just a little bit. But when you do imaging, you find microcyst, confirming that it is a amelanotic nevus. One more clinical application is in ocular surface squamous neoplasia. Keratin, rose Bengal, and abnormal vascular pattern together have a very high sensitivity and specificity and diagnostic predictability. But when you have a confounding clinical situation, if you do anterior segment OCT, Carol Karp had described that if you have hyperreflective corneal epithelium, which is hypertrophic and abruptly ends with a snout, then that is diagnostic of ocular surface squamous neoplasia. So you have a clinical diagnostic tool right there. Now, apart from that, when you excise a malignant tumor, you not just want to have margin clearance, but also base clearance. Margin is very simple to detect. You do a slit lamp evaluation and you have the margin right there. You stain the lesion and you have a very precise estimation of margin. But when it comes to base, sometimes it's difficult to estimate the base, and you have imaging. You can see that what you see in imaging is what you get on histopathology. So if you do imaging well, you can judge as to what should be the level of dissection. This is an example of corneal OSSN. You'd never know whether it has stromal invasion or not. How do you tell? Sometimes OCT and UBM can help predict if there is stromal invasion. You can see splaying of the stroma there. That is a normal stroma. So obviously this patient will not work with topical therapy, will not work with simple excision, may need a full thickness excision and penetrating keratoplasty or even plaque brachytherapy. It will also help you tell whether a patient has anterior segment invasion already. These patients, it's difficult to do gonioscopy, difficult to peep beyond the angle, but when you do imaging, you can say that all of these patients have anterior segment extension. Something new is OCT angiography, where you can remodel 360-degree of the limbal vasculature, and this may help predict early recurrences in patients who have been treated with topical therapy. Coming to topical therapy, we have chemotherapy in the form of mitomycin and 5-fluorouracil, but now we have interferon alpha 2b, which is as expensive as these two other agents, but it is more gentle on the cornea. You have immunotherapy where you aim to completely eradicate the tumor, immunoreduction where you want to make it smaller so that you can do a less extensive surgery, and immunomodulation where you want to enhance the local immune system to minimize the chance of recurrence. These are small tumors which go away with topical therapy. This is a little larger, but a recurrent tumor that has gone away with topical immunotherapy. The most important indication, of course, is corneal OSSN. This is an example where my cornea colleague had done a biopsy from that area. And that's the exact area where there is a subtle corneal scar after the rest of the tumor was eradicated by topical therapy. So possibly if there is a tumor at the pupillary axis, then you would want to do topical therapy. This is a precious graft in a patient with xeroderma pigmentosum, and the graft host junction has a OSSN. And this is the third graft in this patient, and surgical intervention may tip the balance off in favor of a graft rejection or a failure. Whereas with topical therapy, you can see a clear graft after the tumor has gone completely. 6 clock hours of tumor, more than that, there is a chance of primary limbal stem cell deficiency if you were to excise it. But with topical therapy, that doesn't happen. Diffuse OSSN is a very good candidate for topical therapy. You can see after 3 months, the tumor is completely gone. And for much extensive tumors involving the palpebral conjunctiva as well, earlier we were doing orbital exenteration. Currently, we treat these patients with injection interferon and topical interferon augmented. And about 50% of patients don't need orbital exenteration with this treatment. Immunoreduction is a principle where if you have a tumor there, that is the epicenter around which there will be zones of carcinoma in situ, severe, moderate, and mild dysplasia. All these go away with topical therapy, and what you're left with finally is the invasive tumor that can be amenable to a small surgery. Immunomodulation is for xeroderma pigmentosum and HIV positive patients. When you talk about surgery, we do an extensive mapping of the lesion and carry a large fundus diagram, like a large diagram, to the OT so that we know exactly what we are dealing with. And we completely excise the tumor. Surgical excision remains an excellent option. But what is new in this is the use of intraoperative OCT, because OCT, as I said, is predictable of the base, and that actually mimics histopathology. And along with that, primary limbal select simple limbal epithelial transplantation actually helps salvage surfaces in large tumors. And of course, we have protocol for adjuvant therapy. What is beyond surgery is plaque brachytherapy for patients who have scleral invasion. These patients who have full thickness scleral invasion, limited anterior segment extension, were earlier subjected to extended enucleation. No longer so. All these can be very easily treated with plaque brachytherapy. Even patients who have anterior segment extension can be treated with plaque brachytherapy. In patients who have a risk of corneal perforation or tectonic integrity, loss of tectonic integrity because of primary surgery, you do a primary plaque. Without excising the tumor, you can place the plaque on top of the tumor, and you can see nice results after plaque brachytherapy. Extensive melanoma, you can see anterior segment involvement already, but the patient was keen on eye salvage. The other eye had macular scar, so he hadn't had good vision in the other eye. This was again salvaged with rotational plaque brachytherapy, where 360-degree of the ocular surface was treated. We have a conformal plaque as well now, which is a much better design. And strontium is coming back. With all this, we have about 90% eye salvage in patients who have scleral invasion. For advanced tumors with intraocular extension, this patient had a nasal tumor, multiple excisions elsewhere with intraocular extension, a clear case for extended enucleation. Here we planned stereotactic radiation, and that worked very well in this patient. You can see the choroidal tumor gone and the patient's eye salvaged with reasonable vision maintained. You can see the choroidal tumor gone, ciliary body component gone, all with stereotactic radiation. Vaporization is something new for conjunctival lymphangioma. These are nice results of vaporization. And I don't think I have time to talk about target therapy, just to say that For melanoma, we have worked out the mutational spectrum and the target therapy that is useful. Pembrolizumab, nivolumab are working very beautifully. This is our own patient where the patient received nivolumab for regional lymph node metastasis, and incidentally his ocular surface recurrence also went away, making a case for primary treatment with target therapy in patients who have conjunctival melanoma, if you know the mutational spectrum. So in conclusion, I would say that there are a lot of changes that are happening in the realm of ocular surface tumors. Imaging, target therapy, and innovative use of radiation have taken it to a new level. Thank you so much.
Thank you, Dr. Honavar, for a very beautiful presentation, taking us through all the OSs. And any questions?
Yeah.
So in cases where you've used it in palpebral involvement,
Yeah.
have you also tried it where the eyelid margin is involved? And how's your
Eyelid
experience?
margin involvement, injection interferon, I have tried. Of course, it doesn't work in all patients, but in half the patients, it does work with extensive cryotherapy as well, not alone.
May I now invite Dr. Y. Sujata, RPC alumnus. She will be talking to us on the successful management of lag ophthalmos.
Good afternoon, everybody. First of all, I'm thanking Dr. Tityal sir and Dr. Namrata for calling me and giving me this opportunity. This is not mine. Okay. That is another V. Sujata's. My slides, please.
This is going on. Like ask Dr. Navar sir. For this different injection, your surface commerce So for this, when you're using interferon injection for ocular surface commerce neoplasia, like how you prefer, like when to go for topical or when to decide to go for injection, perilesional injection?
Okay, for localized tumors which are much placoid and flatter, diffuse, I would prefer topical treatment. If the tumor is more extensive, thicker, involving palpebral and corneal conjunctiva, then I would prefer it.
Any specific signs on ASOCT for corneal OSSN? Because we reported recently one case. I think people I can discuss later on.
I'm going to share my experiences with the common condition common to all the ophthalmologists, irrespective of the branch of ophthalmology. That is a lag ophthalmos condition. So the definition goes like this: inability to close the eye because of the various lid problems. And lagos means here in Greek, an animal believed to sleep with eyes open. Imagine ourselves how it looks and how it complicates our eyes when the lids are open like this. And the prevalence usually goes 10 to 20%. And usually it is a sign to many causes, not a disease by itself. And various other problems like absence of blink reflex, no corneal resurfacing, corneal dryness, exposure keratitis, corneal ulcerations, and finally perforation, loss of eye. All these complications can result from lag ophthalmos. One of the very dangerous conditions usually overlooked by many ophthalmologists. So this is an extreme case of lag ophthalmos. And the classification goes like this: congenital or acquired, unilateral or bilateral, scleral or corneal, and temporary or permanent, nocturnal or diurnal, upper lid or lower lid causes, and mild, moderate, severe lag ophthalmos. And other classification is physiological, mechanical, spastic, paralytic, and functional lag ophthalmos. And nocturnal lag ophthalmos is usually results in morning irritation, foreign body sensation, scratchy eyes, and mucus discharges. And Enlargement or protrusion of the eye, one of the causes for lag ophthalmos due to mechanical causes. Structural loss or mechanical impairment of the lids and marked ectropion can cause this lag ophthalmos. And protrusion of eye can be because of ophthalmos or frank proptosis due to various conditions like thyroid ophthalmopathy and orbital inflammations and retrobulbar mosses, tumors, and all the conditions from various age groups, from small babies to elderly persons, all can cause this lag ophthalmos. And coming to structural loss or mechanical impairment of usually congenital ablepharon or microblepharon. Here you can see the ablepharon conditions, and leprosy can also cause lag ophthalmos. And these are the various cases with lag ophthalmos due to leprosy. And the facial palsy can occur at various age groups, from small children to elderly. It can result in severe lag ophthalmos. Sometimes Bell's palsy can resolve, but other causes of facial palsy should be taken care. Sometimes surgical also required. And functional, extreme debility or unconsciousness or general anesthesia and neuropathic keratitis, all these things can cause functional lag ophthalmos. And see, usually the lower cornea is exposed in case of paralytic lids, but finally it can cause entire cornea loss and loss of eye. And other causes of ectropion are enumerated here. And even small children with trisomy conditions, mongoloid faces can also have this type of picture. And ectropion due to spastic or cicatricial and senile, all the causes of ectropion cause this lag ophthalmos. We need to search for the cause and then do the surgery. Here you can see the post-operative due to ptosis surgery. It can cause sometimes lag ophthalmos. If the cornea is not exposed, usually it resolves. But if cornea is exposed, we need to redo the surgery. And other causes where this severe conjunctival protrusion can cause lag ophthalmos here. And orbital varices and other orbital causes can cause lag ophthalmos. And here it is Mikulicz syndrome and Prozera and various ectodermal dysplasias, and all the causes of lag ophthalmos are enumerated. And usually the complications are usually exposure keratopathy, poor sleep, severe dry eyes, corneal ulceration, decrease or loss of vision, cosmetic blemish also. And coming to the medical management, usually the nocturnal ointments, taping of the lids, nocturnal moisture goggles, and treatment to the dry eyes and corneal ulcers, and frost suture is required sometimes to protect the cornea. And here you can see the punctal plugs, how to insert them to prevent the severe dry eyes. And these are the bandage contact lenses to help the corneal conditions, amniotic grafting for the various conditions of cornea because of lag ophthalmos, and eyelid retraction management. Usually thyroid treatment is required, and sometimes Botox injections and a correction of the upper lid retraction surgically sometimes required. And surgical management, usually tarsorrhaphy or canthoplasty, tarsal stripping, medial canthoplasty, and entropion surgery, ectropion surgery, recession of levator for the levator retraction, all these things are required sometimes. And surgical management, usually lid spaces, lid weight implants, gold weight implants, and skin and mucous membrane cartilage grafting, temporalis transfer in the case of leprosy, and facial grafts, and palpebral springs, etc. are required. Here the lid spacer you can see sometimes required for the upper lid. And gold weight implantation is one of my favorite surgeries. And in paralytic lag ophthalmos, we can place the gold, which is inert, non-allergic, and stable. Here are the various gold plates. And here the surgery, how the steps of the surgery. See the pre and post-operative results of gold plate implants. And here, all these are the pre and post-operative results. And sometimes it can result in some complications like exposure of the gold weight and or ptosis because of heavy weights. And we need to take out when the weight is exposed. And primary repair of eyelid lacerations is very important. It should be done in a meticulous manner. And it is the secret to prevent the traumatic lag ophthalmos. See, if you don't repair properly, this is the result: upper lid and lower lid cicatricial ectropions. And proper repair is required. to prevent this dangerous complication. See, here you can see that proper suturing at the primary stage can prevent the leg ophthalmos. Tossography is very important. Still, I'm seeing the various cases, tossography being done with unsightly appearance of these big bolsters, rubber bolsters, which are actually not helping, and they're touching the cornea and damaging the cornea more. So coming to cosmetic tossography, small bolster is sufficient, that is plastic small bolster is sufficient to correct this condition, lag ophthalmos. See how you can see here, the smallest bolster used, central tossography being done, and these are the other various surgeries like lateral canthoplasty is required, skin grafting required for the cicatricial ectropion, and other so many here you can see the how to do the direct closure with 3-layered suturing. There are so many videos are there, but due to scarcity of time, I'm not able to show them. And you can nicely repair. These are all cutted beard surgery should be done meticulous in case of coloboma of the lids. And coloboma may be due to surgical coloboma or congenital coloboma, sharing of the lids. And here you can remove this kissing nevus meticulously to prevent the lag ophthalmos. And thank you very much.
Thank you so much, ma'am. That was an extensive coverage of this topic, lag ophthalmos, so many causes and etiologies, and I think you've covered it excellently.
Thank you.
So, any questions, ma'am? How's your experience with treating lag ophthalmos or a lid retraction in TED patients, thyroid eye disease patients? I mean, how's your experience in that?
Yeah, good question. Usually we treat medically this condition if thyroid is taken care and anti-inflammatory treatment is sufficient. If it is not sufficient, then we need to place some lid spacer to the upper lid so that the lid can come down. Very rarely it requires surgical treatment. Otherwise, very severe cases we need to do this tossography temporarily.
Thank you, ma'am. I'd like to invite our next speaker, Dr. Pooja Kumar. Dr. Pooja is consultant and trainer at Narayan Nethralaya. Her basic training in ophthalmology from Narayan Nethralaya only. But the best part about her is her keen interest in basic and translational research, and she is on the editorial board member of 2 of the most difficult journal to publish. Even I'm still trying for that, Journal of Refractive Surgery and Journal of Refractive Case Report. And she has won several awards from ESCRS, ISCRS, AO. So I request to start your presentation, and I welcome you on behalf of RPC family.
Thank you everyone, and I would like to thank the entire RPC family and Jeevan Tityal sir for having us here. So today I'm going to be talking about advanced imaging of epithelial and stromal interaction in refractive surgery. I don't have any financial interests, but as the refractive surgery is evolving, and all we know is that our patients need more than 6x6 vision. So how the epithelium and stroma role comes into picture, I'm just going to be talking about it. So refractive surgery just started with refraction, keratometer, then modern day topographers, and then biomechanics. So now if we have to take a decision, a lot of them would rely on the topography and biomechanics to see whether the patient is eligible or not, and then they go ahead with surgery expecting everything would turn out to be good. But then there are a set of pre-op challenges that, topographies are suspicious, so we might not go ahead, but the biomechanics is extremely perfect. Should we go ahead or not? And the post-op challenge is like everything is fine. We've chosen the perfect patient for the surgery. We've done the refraction correctly, but post-operatively patients might have blur vision or a lot of glare halos, or they might even land up into post-LASIK ectasia. So why are we dealing with all these challenges when we have chosen our patients extremely well? We need to have a newer perspective when it comes to refractive surgery now, and that's how it's called as understanding the modern day refractive surgery. We do have an area of all the screening indices in any topographer you choose, whether it's Pentacam, Cirrus, Galilei, the most commonly used, and they have a set of cutoffs which will tell us that our patient is normal or it's a suspect form flush keratoconus, where we would not like to touch the patients. But are these adequate in the modern day refractive surgery? What we are measuring right now, we are measuring the surface, which is the which is also including the epithelium. but actually we do the refractive surgery on the stromal level. So what we should actually be measuring while taking a decision whether to operate or not is at this level. This is epithelium. Epithelium can be of various hypertrophy, hyperplasia, everything, and it might mask the actual stromal surface. And if we do a surgery just taking the topography into consideration, we might land up into challenges, because eyes with normal corneal stroma might have epithelial changes or inferior steepening. It may mimic keratoconus on any anterior corneal topography. It might help lead us to inaccurate diagnosis. And that is why epithelial mapping, a differential diagnostic tool, is important when you're dealing with a modern refractive surgery. Now, a few years back, we had a lot of inhibitions because we didn't have many tools to measure the epithelial thickness. But now all the modern day OCTs like the Fourier domain or the spectral domain OCTs help us in getting the epithelial mapping. So we will come to know whether the epithelium is normal or not. If the epithelial is regular, what happens, we'll say. So eye is just not what we look on the surface. It is made of it starts from the tear film and it goes up to the collagen where what is involved in refractive surgery. So let's just look at few cases, because cases is what we look into. If you see here, there's a little bit of inferior steepening here. Bad D is suspicious. Maybe it's because of the inferior steepening what we are seeing. A very good corneal thickness of 545. The CBI, which is the corneal strength, is absolutely normal. So is this a case where we would want to go ahead and do a refractive surgery? Is this a case where we are seeing the true inferior steepening? The answer is probably no, because if you can see here, this is the epithelial map. The center is around 63 and the periphery is around 52. So there is a difference of 11 microns from the periphery to the central. And this is exactly correlating to our area of inferior steepening. So the inferior, and if you see here, there is no stromal elevation. The stroma is actually flat or normal. And again, no posterior elevation in the area of inferior steepening. So the inferior steepening, what we are seeing here is actually not a true form for keratoconus, but epithelial hyperplasia, which is seeming as an inferior steepening. And we might avoid a refractive surgery in a patient which is not normal. This is one more similar case, inferior steepening, but epithelial hyperplasia, which is actually seeming like a form for keratoconus, but everything else is normal. So this is a patient which needs the attention where we should treat epithelium. Now, these are the 4 cases. This is a normal epithelium, which are abnormal. Abnormal definition is a difference of 5 microns between the center and periphery is labeled as abnormal. Now, what if I go ahead, okay, let's say topography is normal. I've not looked at the epithelial map. I go ahead and do a refractive surgery. Post-op healing is also going to be impacted. A normal epithelial will heal normally, and an abnormal epithelium will lead into a post-op epithelial hyperplasia, and which can lead to post-surgery abnormal vision. And that's why your patients are unhappy post-surgery with glare and halos, where they don't, where when everything is normal, the vision is 6/6, which is 20/20, but the quality is poor, and that's why they are unhappy. So it's very important for us as we move forward that we might have to look at the epithelial profile to see what the post-operative outcome might be to give a good quality of life to our patients. If there is an epithelial hyperplasia or abnormal epithelial or irregular epithelium you see before surgery, it doesn't make, it is not necessary that you don't treat the patient or don't do a refractive surgery. It just means it's a poor ocular surface. So treat the patient for ocular surface for around 4 weeks. And then after that, you can go ahead with a surgery. That means post-surgery patients will have a good quantity and quality of vision. The second part of my talk again is stromal imaging. This is an absolutely healthy topography. We can go ahead and do the surgery, but if you see the epithelium here is a donut pattern and there is some amount of stromal elevation and a posterior elevation present. So even though the topography is normal, there is no posterior elevation seen here, but epithelium, as it being a donut sign and a stromal elevation present, it raises some suspicion. So this is one case, and this is similar second case where you can see a donut sign of epithelium, stromal elevation, and a posterior elevation. So now what does that mean? Can we go ahead and do surgeries in this type of cases? Professor Dan Reistein has already published that a donut sign of epithelium is a sign of early keratoconus, or it's a sign of evolving keratoconus, a form fresh keratoconus. So we have to be extremely cautious whenever we see a donut shaped of epithelium, even in a normal cornea. And it doesn't mean you don't do a surgery, but prefer doing a PRK extra or a smile extra or a phakic IOL in these patients, because any cut would lead to post-refractive surgery ectasia. So again, differentiating suspicious from normal corneas with epithelium and stromal imaging is extremely important, and stromal changes are masked by epithelium thickness profile. So as we move forward, if we can incorporate the epithelial imaging in the refractive surgery, it would be very good. Thank you all.
Thank you, Dr. Pooja, for the excellent talk. Now, I would like to invite Colonel Vijay K. Sharma, who is a consultant at R&R Hospital, and he has many, many publications on cornea and refractive surgery, to his credit, to present his talk on high-risk keratoplasties.
Thank you, Chairpersons. I think my slides are visible.
Yes, they are.
Oh, okay. So I'll be discussing about high-risk keratoplasties. So in the high-risk keratoplasties, we know that cornea has an immune privilege because of it being avascular in nature. The anterior chamber associated immune deviation that also contributes to the immune privilege of cornea, as cornea is dependent upon the aqueous for entire physiology. The corneal antigen presenting cells are quiescent, and there is absent expression of MHC class 1 and 2. So that is why in the host beds which are avascular and non-inflamed, the graft survival is very good. But if the host beds are inflamed and vascularized, the graft survival reduces markedly. 30% of transplanted corneas, they experience at least one episode of immune rejection, and 1/3 of these lead to eventual graft failure. If we see the mechanism that it has an induction phase and an efferent phase. In the induction phase, there occur activation of corneal antigen presenting cells, dendritic cells, which sensitize the proliferation of T cells in the draining lymph nodes. So this efferent phase is mediated by the lymphatics. The efferent phase is mediated by the blood vessels, the delivery of immune factors at the site, including inflammatory cytokines and all these things. This ultimately lead to graft rejection. Various factors which have been described as a high-risk factors for corneal transplant, they include the host bed vascularity. As CCTS, the collaborative corneal transplant study, it gave us a good insight into the high-risk corneal transplant. It defined the high risk as a cornea with 2 or more quadrants of deep stromal vessels prior to surgery. If there are stromal vascularization in all 4 corneal quadrants, then it doubles the risk of rejection and increases the severity of immune response against the graft. It also reduces the time taken to reject the graft. So after the corneal rejection, the reversal also depends upon the corneal vascularization. More the vascularization, difficult the reversal is. The second factor which is important as a high risk are the regrafts. So increase risk when the 2 or more grafts have previously failed. If we see the rejection rates, the 40% is after first graft, it increases to 68 after the second, and 80% after the third graft. The CCTS recognize the risk to be 1.2 for each successive graft. This is because of pre-sensitization, immune memory, and inflamed and vascular milieu from the previous surgical insults. Other factors, pre-existing diseases such as herpetic keratitis, uveitis, atopic dermatitis, they increase the chance of graft rejection. Hot grafting, that is when there is an ongoing active inflammation at the time of grafting, that also increases the chances of graft rejection. Poor ocular surface, history of glaucoma, history of previous surgeries other than penetrating keratoplasty such as glaucoma surgery, they also increase the chances. One of the most important factors are if there are iridocorneal adhesions, and also the number of quadrants these iridocorneal adhesions are present, that also increases the chance of graft rejection. Vitreous adhesions are also important mediators. In pregnancy, it's although a state of relative immune suppression, but it has been found that there is increase in chances of graft rejection. And in the postpartum also, due to re-establishment of immune competence, the rejection rate increases. Limbal stem cell deficiency, it's a state of chronic inflammation, and also it invites a lot of inflammation and can lead to graft rejection. Young host beds, the rejection is seen higher due to the robust immune response in them. Male donor to female recipient, because of the HY antigen, the rejection episodes are more compared to male or a female to male recipient. So the measures that we can take to reduce the risk of allograft rejection in the preoperative period, reduction of corneal vascularization, multiple methods have been tried, the cautery, the cryo, use of anti-VEGF agents in terms of drops or subconjunctival injections or intrastromal injections, steroids, and 577 nanometer yellow dye laser. But different varying rates of success has been achieved. No one standard method has been found which is foolproof to decrease the vascularization, but it can be adopted as per the individual's assessment. HLA matching, although CCTS did not find any relevance of this, but nowadays many studies have come from especially the European countries where HLA matching and MHC matching are being found to be important. And if it is not done, then there is a graft rejection chances are higher. The IOP control and limbal stem cell deficiency management are also important. In the post-operative period, topical steroids, systemic immunosuppressives, especially the mycophenolate mofetil, that decreases the chances of rejection by around 50%. These are routinely being used nowadays. T regulatory cells, then tolerogenic dendritic cells, and even systemic administration of interleukin-2 have been tried, but these are still in the research phase. The most important aspect that I want to highlight during my talk are the intraoperative factors. Now, if we see, this was an individual who had undergone earlier optical penetrating keratoplasty, which had failed. He had this iris, which was, there were extensive synechia, which was present almost in the 3 quadrants and at the graft host junction. So after the second regraft was done, and after the regraft was done, the iris was pulled back using a single pass 4th row, and it opened the angle, the intraocular pressure got controlled, and the patient is maintaining now good corneal clarity. It has been almost now 9 months follow-up, and he has maintained the good clarity. So managing the iris is very important. Now this is almost similar case. Now in this, this was a perforated corneal ulcer, fungal corneal ulcer, where initially a therapeutic penetrating keratoplasty was done. And if you see, these iridocorneal adhesions are one of the most important factors that we can actually remove during the surgery. So we have to take all these precautions to remove these iridocorneal adhesions, because they are one of the important mediators of chronic inflammations. Like in this case, if you see almost 360 degree, the iris is stuck up at the graft host junction. So it has to be removed. The problem occurs once you do the transplant. At that time, if we do not take care of iris again, these iridocorneal adhesions can reform. So now you can see this has been done. There are posterior synechia all around. This pupillary membrane was removed. A cataract surgery was done. And once this surgery was completed, then the trephination was done. This cornea was removed. We regularly use Meligan ring under the open sky to achieve a stable chamber for implantation of IOL or removal of cataract. And at that time, we also usually do this pupilloplasty, be it under the open sky or it can be a single pass 4th row, depending upon the conditions. So it pulls the iris away from the angle, and also the chances of formation of iridocorneal adhesions are much more decreased if we are able to do this, and thus reducing the inflammation post-operative. So this was the patient. After this, now we have achieved, in this case, if you can see in the pre-operative period, there is the pupil is not central, but here the pupil is central, AC is well formed, cataract is removed, and it's relatively a quiet graft. So chances of rejection, they further decrease if you manage intraoperative parts in this way. So many a times when you are performing the surgery, open sky penetrating keratoplasty, triple procedure. So in that cases, you usually end up with either your rhexis is lost or there is a vitreous loss, and iris, it can prolapse. So many factors can happen. So in these cases, we, as I had mentioned, that we use Meligan ring under the open sky like this. The phalanges of the Meligan ring, they are tucked under the host margins, and once this is done, you achieve a very stable chamber. It's just like a closed chamber to work with, and you can then complete your entire surgery, rest of the management very comfortably. So once you are able to do this, your chances of vitreous loss or other things, they decrease significantly, and then you can do the corneal transplant in a better way with minimum complications. Another factor is the limbal stem cell
Vijay, I think
deficiency.
you have to
Yes.
conclude soon. Yeah, thank you.
This is the last one, ma'am. 30 seconds more, ma'am. Okay, so this many a times you get when the epithelium is irregular. So in such cases, what we also do is we transplant the limbal stem cells from the same eye, if they are available, to the graft host junction. Once we do this, the regularity of the epithelium is maintained over a period of time, and the inflammation also decreases. Now here these stem cells have been transplanted to the graft host junction because this acts as a barrier for migration of epithelial cells, and it can lead to chronic inflammation. And once this is done, it will decrease the inflammation and also the chance of graft rejection. Thank you, ma'am.
Thank you, Colonel Vijay. That was a wonderful talk. And we have next speaker, Dr. Nupur Gupta. She will be speaking on the management of dry eye diseases. Over to you, ma'am.
Thank you, Dr. Lomi. So I'll be discussing about dry eye disease, which is a very common clinical conditions. The prevalence of dry eye disease in our setting ranges from around 20 to 30%. And actually for meibomian gland dysfunction in the hospital population, it came out to be around 50%. So more than half the young adults also having meibomian gland dysfunction. So I'll walk you through some cases which come to our OPD and the management options that we have. This is a clinical picture of a 36-year-old female who presented to us with an instantaneous breakup time and a Schirmer's test of 5 and 8. The underlying causes of dry eye were ruled out, of excessive contact lens wear, of any epithelial instability, bullous keratopathy. She was managed with carboxymethylcellulose 1% 2-hourly along with an HPMC 0.3% gel thrice a day. She responded on addition to topical N-acetylcysteine 10%, and we had to add a low potency loteprednol 0.5%, so that she recovered in around 4 weeks' time. A systemic workup did not reveal any autoimmune disorder. And if these patients do not respond, we can insert a bandage contact lens to remove the lid viper syndrome, or we'll have to remove the filaments under proparacaine drops. This is another patient who had a history of refractive surgery done 1 month back, who presented with a breakup time of 2 seconds, was treated conservatively with copious preservative-free topical lubricants. The advice given to her was to reduce the use of digital devices, and computer vision syndrome was treated empirically, and lifestyle modification was done, and she responded to treatment. It is important to look for compromised ocular surface preoperatively and treat it before the LASIK surgery or any corneal refractive surgery is planned. Another case of a 40-year-old female who presented to us with post-radiation dry eye. She was a known case of thyroid carcinoma and had an instantaneous breakup time. She was managed with copious lubricants and topical cyclosporin 0.05% twice a day. So the armamentarium that we have is a plethora of lubricants. We have to tailor it to the patient and see which, whether we want to give a carboxymethylcellulose or a polyol or trihalio. So it depends on what the presentation is and whether the patient belongs to the postmenopausal age group or has an underlying systemic disorder or the cause is iatrogenic. This is another case of a 30-year-old female who was diagnosed as Sjogren's syndrome and when the ANA antibodies were found, and we had referred the patient to the rheumatologist on the complaints of dry mouth as well. So these patients have to manage, apart from the top ocular medication, with oral pilocarpine with the rheumatologist consultation. Another patient who was on treatment for around 4 years outside, came with a lot of filaments. This is the clinic picture under the cobalt blue filter, which shows multiple filaments and staining, fluorescein staining. He was referred by us to the rheumatologist, came out to be Sjogren's syndrome on lacrimal gland biopsy. This is the other eye of the same patient, showing extensive staining and filaments. We do come across some patients who have a chronic limbal stem cell deficiency because of the poor ocular surface. This lady was a case of rheumatoid arthritis. So this has to be treated along with the rheumatologist to actually achieve achieved remission, and this patient was actually treated with mucous membrane transplantation of both the lower lids in complex and severe ocular surface disease, where you have a very poor ocular surface. A minor salivary gland transplantation also comes to our respite. Another case where we have transplanted from the other eye of a normal eye with limbal stem cell deficiency, a simple limbal epithelial transplantation has been done. And in end-stage disease, the keratoprosthesis is the only option with us. Just to put into perspective, patients with vernal keratoconjunctivitis do have ocular surface changes. A recent study conducted at our center, we found that the patients with VKC have a TBUT, mucin deficient dry eye, and the thing that we noted was a lower lipid layer thickness. So the meibography also revealed that they do have a lipid deficient dry eye as well. Hence, lubricants only will not suffice. You have to replenish their lipid layer tear film. And they even show a squamous metaplasia on the impression cytology. So the management actually involves the TFS DUCE2 algorithm, which aims at triaging questions, ruling out any systemic disease, iatrogenic causes, any lid adnexal problems, doing a risk factor analysis, symptom questionnaires along with either a TBUT or a tear osmolarity or ocular surface staining to classify them into either an evaporative type of dry eye or an aqueous deficient type of dry eye. Thank you.
Thank you, Dr. Nupur. Do we have any questions? Okay, I now invite our next speaker, Dr. Sumit Lohane from Mumbai. He is going to be speaking on ocular surface squamous neoplasia management, medical or surgical. With us virtually.
I think as Dr. Sumit is logging on, Nupur, can I ask you that?
You're not audible here. Ma'am, we are not able to hear from your mic. Am I supposed to start my presentation? This is Dr. Sumit here.
Yes, Dr. Sumit. Can you hear us now?
Yeah, now it is audible. Thank you.
Please go on.
So I would like, is my screen visible?
No. Not yet. Yes, now it's visible.
I would like to thank RPC faculty, alumni, Jeevan DTL sir, Namrata ma'am, Vanati ma'am, and everyone for giving this opportunity for me to present in this RPC alumni function. And this is again honor and a privilege to present in front of all the distinguished faculties. Now, again, it becomes a little pressure situation when you want to talk around the same topic after your mentor talks. But I would like to try and limit my talk to the treatment of OSSM. So this is one of my favorite slides where we see three lesions and they are appearing almost similar to each other. And once you see them individually, it becomes very difficult to diagnose unless you have a comparative picture like this, which tells you that what you are looking at is a benign condition, pre-malignant like actinic keratosis, and a malignant as OSSM. So basically, you need to see them as a difference, and unless somebody points it out for you, you will not be able to understand that there is some difference, which tells you that what are you looking at is a diagnosis of a tumor. So there are certain features which are very important in OSSN, like a feeder vessel, keratin, intrinsic vascularity, rose Bengal staining, all of which together can clinically diagnose a OSSN on slit lamp itself. So there are various varieties, placoid, nodular, diffuse, and of course there are rare varieties like pigmented and mucoepidermoid. So when I talk about all this, what are the treatment options? We have a lot of treatment options from observation, biopsy, chemotherapy, radiation, and the exentration as a surgery. Now look at this 4 tumors. These are different types of OSSN. And then I show you the pictures which are post-treatment. Now, how were they treated? Were they treated with the same surgery options? Were they treated with all of them treated with the radiation or a different ways? So let me tell you, they were treated with all the different ways. And let's try and explain why this was done. So when you have a very small tumor near the limbus, which is hardly 2 to 3 millimeter and well confined, and this is a post-treatment, post-surgical clinical picture, which shows a small conjunctival scar. And in such lesions, a very small lesion confined to the limbus can be very well treated surgically. So surgery is a one-time treatment and completes the cure for the patient, especially those who are not able to follow up. So what do we do exactly in the surgery? It's an excision biopsy with the no-touch technique where we take a clinical 4 millimeter margins. We do a double freeze thaw to the margins, alcohol keratoepitheliectomy, partial lamellus keratectomy, and then the surface reconstruction with the amniotic membrane graft. In OSSN, surgery is not the full and final treatment because after that you need to send it for the histopathology and your pathology should confirm that your margins are negative. What if they tell you that your margins and the base are not negative and they are positive? How do you go ahead then? Then there is a simple protocol that you need to follow. That if there is a resection edge positive, which is only as a dysplasia, you can either observe or start on the topical chemotherapy. If the resection edge is positive in an invasive manner, then you need to re-excise, taking the patient to the OT again. If the base is positive and localized, the cryotherapy works there, which you do intraoperatively too. But if the resection base is positive and diffuse, then you need to go ahead with the plaque brachytherapy. So surgery after histopathology completes your treatment. Now here we do a plaque brachytherapy in a primary fashion because we know this, what we are looking at is the invasive tumor, and for the invasive tumor, it is very difficult for you to do a lamellar sclerectomy or the full thickness sclerectomy, or even the chemotherapy will not function in this case. So plaque brachytherapy becomes very important for the eye salvage and the complete tumor eradication. So this is one of the picture pre-op of a nodular OSSN and the post-treatment treated with the plaque brachytherapy. Now, is there any way to predict the base positivity? As Santosh sir pointed out that you can do a high resolution anterior segment OCT, and depending on the thickness of the tumor, you can actually make out that what are you looking at is an invasive thick tumor and not only intraepithelial carcinoma in situ that you are treating with. Now, if the surgery is such a good option, then why don't you stick to the surgery and why do you want to go ahead with the further option? Because many of the different literature and the papers suggested that the recurrence of the OSSN post surgery, depending on the way it is done, is almost varying from 15 to 52%. And especially when you get such type of a tumors, which are more of a corneal and more of a caudal involvement, how are you sure about removing all the margins? So in this case, again, a large tumor is treated non-surgically and still you achieve a remission. So how it is done? By giving a topical chemotherapy. When do you give it? There are special indications that there is more than 2 quadrant conjunctival involvement, 180 of limbal involvement, clear corneal extension on the pupillary axis, positive margins post-excision, and patient not willing, not fit for surgery. What options do we have in chemotherapy? We have mitomycin C, 5-fluorouracil, and in immunotherapy, we have interferon alpha 2b. I'm again not going into the details of this, but these are the options available. MMC becomes a little toxic on the ocular surface. Interferon, on the other hand, is quite surface friendly and can be given even for the long term. For mitomycin C, what regimen is used by the rule of 4, a 0.4 milligram per ml 4 days a week for 4 weeks with the 2 weeks of the treatment-free interval. Interferon alpha 2b, 3, 5, and 10 million injections are available, and topically we give it as a 1 million injection, 1 million per ml as an injection. So these are few pictures where we treated patients with the injectable interferon along with the topical, and you can see that a complete remission can be achieved only with the interferon without surgical intervention. Again, this appears as an infiltrate, corneal infiltrate, but post treatment you just get vascularization, and just post 3 interferon injection you can achieve this. So surgical or medical management, it depends on what kind of lesion you are seeing and what do you do in a bad cases which are chemo-resistant and invasive. In such cases, where there is again anterior orbital, mid-orbital extension, your chemotherapy may not work in such cases, and exenteration becomes an option to treat such cases. Now again, coming back to the first slide, when you see all these 4 cases, how do you treat it? First, with the surgery. It's a large involving entire of the cornea, interferons, or nodular one with the invasion. You will need excision plus radiation, and a large, again superficial, no invasive, a simple chemotherapy can work. So different type of OSSN, depending on your imaging and the clinical diagnosis, can be treated with the various modalities of the treatment to achieve complete remission. I acknowledge my mentor, Dr. Santosh Onava, sir, and thank you for a few of the clinical pictures from him. Thank you again for patient listening.
Dr. Sumit, that was a lovely presentation. Thank you. I have one question for you.
Yes, sir.
For the plaque brachytherapy you're doing for the invasive OSSN and all, unlike in that intraocular tumors, we check the apical dose at the apex. Whereas in case of plaque brachy for surface tumor, how you calculate it? Like you take the base as a dose, or how you calculate that, and how you measure the thickness of the tumor here?
Sir, again, now here, when are we giving radiation for this OSSN, it is not primarily we are putting it on the tumor directly. Many times we have done a primary excision. The thickness of the tumor you have calculated pre-operatively does not make much sense here because we are going to do an excision. So basically you want to give it for the scleral invasion that is happening. Considering the scleral thickness of 1 millimeter, you want to irradiate the ender of the sclera, and the dose is calculated depending on that scleral thickness there, considering it as around 1 millimeter. So you don't want to give a large dose. A 2000 CGY dose, centigrade dose is good enough to give in such cases. So that is enough. So you don't actually calculate till the apex of the tumor because that is not very much feasible in these cases.
Okay, thank you. Actually, we are also doing the same thing here, but the doses out, while calculating doses, like 200 centigrade, sometimes very high for the sclera to take. The risks of scleral necrosis are there. So, like exactly what is the doses you follow? The maximum scleral doses you follow in your practices there.
So again, sir, it depends on how much your quadrants and of this is involved. So if there is a 2 quadrant involvement or more than that, then we might have to do a plaque rotation also. And depending on your quadrant involvement, we give it in either 1 quadrant completely, and then for a particular dose which is calculated by the software. Again, we don't want to give a very high dose, and that the tumor thickness does not make any sense there. But as you said, we are not crossing it more than 2000 of the dose, but that 20 grades of the dose is good enough to treat that much of a tumor. I think Santosh sir is there, and I think he can better explain this.
Dr. Sumit.
Thank you, Dr. Sumit. I will now invite Dr. Nikhil Gokhale for his next presentation on post cataract tunnel infections. Dr. Nikhil Gokhale is a very famous corneal surgeon in Mumbai and one of our senior alumni, and his work on vernal keratoconjunctivitis is one of the much quoted publications in corneal academics. Over to you, Dr. Nikhil.
Yeah, you can hear me?
Yes, we can hear you.
Yeah. Thank you, Dr. Vanati. I think it's a pleasure to be back at the RP Center today, not physically, but virtually, and surely will be back there again in the coming time. I think I would like to talk about tunnel infections that we encounter after cataract surgery, which may be phaco or SICS, and which typically could be the main tunnel or the side port, and can involve, most often, they may be corneoscleral infections and may involve the anterior segment. There can be a spillover of inflammation into the vitreous. However, we can also get frank endophthalmitis and panophthalmitis. And some of these cases may be early onset following surgery, and some may be pretty late onset, sometime weeks after surgery. Some of the problems that we typically see are because the clinical picture does not give any clue of the nature of infection, and these are vision threatening. We cannot treat them empirically. Taking a microbiology sample, processing it is a technical challenge. There is a difficulty in distinguishing the infection versus inflammation in many of these situations, especially after we stop steroids. And because these infections are deep-seated, there is a high load of organisms and often atypical organisms. The treatment is challenging, with medical therapy often failing, and we need to do surgery. And when there is associated endophthalmitis, it becomes still a big difficult challenge where we have to combine our service with a posterior segment surgeon, and often outcomes are not very good. However, when we have infections localized to the anterior segment, a medical treatment followed by surgery if needed can have good results. And of course, we need a good laboratory support, and we need to inform the microbiologists that we might encounter acid-fast organisms, and not to throw away the plates at 48 hours, as is done in many laboratories. Also to remember that wrong reports can be quite misleading and disastrous. And then when we have early infections, it could be bacterial or fungal, but we can have atypical organisms such as mycobacteria and nocardia in late onset infections. So I'll share with you some of the cases. These were two cases of methicillin resistant Staph aureus, where once we identified that this was a MRSA, we put the patient on vancomycin and the side port abscess responded pretty well. However, the second case here is also a methicillin resistant aureus, but he continued to worsen despite medical therapy, and finally required a patch graft surgery, and we could salvage the eye. Sometimes you can get tunnel infections with fungus, and as you can see here, the patient's perforated despite adequate medical therapy, and we have to do a patch graft to again salvage the eyes. There are patients, for example, on the top you can see that he had a therapeutic graft for a temporal tunnel infection, subsequently an optical graft, and you can still give the patient good vision. And the pictures below, as you can see, is a patient who is more than 15 years following a therapeutic keratoplasty and still enjoys about 6/9 vision after so many years, and the graft stays clear. So you can have good results in selected cases. In patients who have nocardia infection, they often come as clusters. And these were two cases which I originally encountered in my practice in 2007, where we had to do patch grafts to salvage the eye. And this were a series of 5 cluster infections. And again, these patients require patch grafts. To note that the anterior chamber tap was sent by the cataract surgeon revealed staphylococcus, and this can totally misguide our choice of medical treatment in these cases. So we need to be cautious about the results that we get. Remember that nocardia will respond better to amikacin, cefazolin, cotrimoxazole, and the fluoroquinolones. Histopathology is very important because many of the times the organism is actually found when you do a histopath of the corneal button, and often the microbiology in the initial few scrapes or biopsies may turn out to be negative. There can also be certain situations where medical therapy alone may heal. For example, the one above is a case of aspergillus infection, and the one below is a nocardia keratitis, both which responded to medical treatment alone, which is of course not very common but can happen. So I would show it here. And this is an unusual infection with Burkholderia, which are very resistant organisms, which can persist in biofilms, and they're often found to contaminate pharma products. Just to say, a very large series of these infections were reported from South India due to contaminated anesthetic drops, and they can be a nightmare to treat. Whenever we do patch grafts in these situations, it is better to do it early rather than late. Often these are small size grafts, they're technically demanding, the eye is pretty inflamed, and there is often positive pressure, but the outcomes can be very good, especially when there is no endophthalmitis and infection is limited to the anterior segment. Sometimes either the patient or the surgeon decides not to do surgery. So this series of picture is of a patient where surgery was not done. You can see that the infection flared up. Subsequently, there was a lot of vascularization, granulation, distortion of the anterior segment, synechia and a membrane. And eventually I could manage a YAG membranotomy and give some vision to the patient, though he continues to have secondary glaucoma. So with such a distorted anterior segment, I would like to stress that surgery probably is a better choice in these cases, and you need to decide early and do it well before these changes do happen. And of course, you can have problems. This is a patient who had a descemet detachment or a tear while I was doing the graft, and he now will require optical keratoplasty in future. And especially when you have significant infection which involves the sclera, or where there is extensive loss of tissue or posterior segment involvement, even despite the best approach that we might do, we may still not get good outcomes in some of these patients. And I'd like to thank the Hinduja Hospital, where most of the microbiology sampling has been done for my cases. And I think without the help of a good microbiologist, I must say that you can probably not be able to treat some of these difficult cases. And also I would like to thank many of the ophthalmologists who send me these cases, without which I would not have had the experience to treat some of these very difficult cases. I once again thank Dr. Titial, Dr. Namrata, Dr. Vanathi, and all others at RP Center for arranging this wonderful meeting. Thank you.
Thank you, sir, for the wonderful lecture. I would like to ask you one clinical scenario that I am facing currently. If you don't have any microbiology report and the infection is not progressing that rapidly, and the inflammation suddenly flared up in the case of tunnel infection, would you like to add steroid, or you'll avoid that?
My general dictum is that no diagnosis, no steroid. For any condition in the anterior segment where I don't know what I'm treating, I would never use steroid. And in a tunnel infection, I would absolutely not use, because all, as I mentioned, these atypical organisms, they are, if you give steroid, the eye is quiet and white. As soon as you stop them, they start to get inflamed, and the eye starts, getting exudation in the anterior chamber and so on. So the infection is sitting there. And if you give steroid, you're only masking the inflammation or the signs of inflammation without the infection actually going. And there is no way to know that, the infection is responding to what treatment you have given. So I tend not to use steroid in these situations.
Any steroid alternative?
Frankly, no, actually. We use cyclosporin drops in some of these fungal infections, but that may be more to protect the graft rather than, control the inflammation there.
Thank you, sir.
Thank you.
Now I would like to request Dr. Ilan Kumaran, who is an illustrious RPC alumnus and is now the medical director at Navshakti Netralaya in Bangalore, to present his talk on future in IOLs. He's here with us physically. Over to you, sir.
Professor JST sir, who was my teacher, Dr. Namrata Sharma, and Dr. Vanathi, who handheld me during my junior residency, and I finally ended up joining in her seat, and all the faculty of RP Center for giving us this opportunity. The topic for today, something which is our bread and butter. What are we going to see in the near future? And finally, the last slide will say what my wish list is. If you look at this particular slide, the one thing that we have achieved to a certain extent, and there are many which we have not achieved. Number one, are we able to provide a vision, a refractive error, something like what we provide in LASIK, a premium or at least a premium monovision, correct the astigmatism, not just correct it, but also take care of the post-operative rotations? Are we able to provide a good vision, not just good refractive correction to these post-corneal refractive surgery patients, and something which has been a holy grail for all of us, presbyopia? How we are doing with this? Many of them we have corrected. Presbyopia we have been able to manage. Some of the other factors with good biometry we have been able to manage and give mostly happy patients, leave mostly happy patients. But is it true? There are still patients where we can't give a clear vision without aids, despite the best of the biometry, best of the IOLs, whatever it is. And as many patients ask this question, vision of a teenager. In fact, some IOL companies were advertising it. With the available options, we have either a multifocal, trifocal, whatever focal, and pseudo-accommodative, accommodative lenses, pseudo-accommodative lenses. While multifocality produces dysphotopsia and needs time to adjust, pseudo-accommodative, there's capsular fibrosis and then the zipper effect. So they're not very comfortable. What are the options we have? I'm just put up two different options. I think many of you would have heard about the dual optic IOL, which was placed in the back. This is something like it, but the difference is the fluid is placed in the periphery. There's a central distance correcting power. And whenever the accommodation is triggered because of the action of the ciliary muscles, these fluid is pushed to the center, thereby in an accommodative IOL, it becomes more convex, helps for the near vision. Not very successful, but still some trials are going on. How about this? Place two different kind of fluids in the bag, fill the bag completely. The upper part of the IOL, which is actually the lighter one, has a higher refractive index. And when the person looks down, that goes behind something like this, increases the power. Again, not very successful, not very. Now, herein comes the concept where we are not very successful. So how about reversing the surgeries? One is just changing the optics, leave the haptic behind. And luckily the hydrophilic material is used here so that there is no capsular adhesions which can be removed. Or the second thing is placing a capsule inside the capsule so that the lens can be placed here and can be comparatively easily removed if need be. But what is really interesting is this. It's been interesting for the past 20 years because I remember very clearly when I joined as a senior resident, Dr. JST sir talking on this. Light adjustable IOLs. What do? Implant somewhere close to the refraction. Check the refractive error. Take up this patient again for the surgery, not surgery, a procedure. And what do we do in this procedure? Now, these polymers can be photo activated. So the lens is placed, we have measured the refractive error, usually around 3 weeks. Then the first set of UV exposure is done, which photopolymerizes certain area. So this becomes fixed. The rest of the non-polymerized area moves in. Like in this case, it has moved to the center, thereby increases the power. And then once we are happy with the power, expose this completely to UV rays so that everything becomes photopolymerized. Now, what is the problem that's happening here? Number one, this patient has to wear a glass for the next 3 weeks, and every session is done once in 3 days. The glass has to be UV protective. He should not get exposed to any UV light. Number two, what happens to the later, whatever happens with the capsular contraction and other changes, not addressed here. Just shortly. So when you change the central part, it becomes more convex. Change the peripheral part, it becomes more concave. That's how you correct both hyperopia, myopia, as well as certain amount of astigmatism. Something very exciting happened in the last few years. Why not use femtosecond laser? Femtosecond has been invited. It has been used in every stage of cataract surgery. Why not use it here? So this is a hydrophilic lens that was placed. And then later on, once the refraction stabilizes, maybe a few weeks to 3 or 4 weeks later, the lens is subjected to femtosecond laser and multifocality or change in power was done to that. With the help of femtosecond laser, we could design the rings, change the cylindrical power, change the spherical power, as well as introduce multifocality. Now, these are the results. We'll come to it later where it was done. These are the results that were obtained. Target of 0.5. You can see the target and the actual changes almost reflected. Now, what is so exciting about this is not creating this multifocality, but whatever you create can also be reversed. So this reversible, if the patient is not happy, it could be reversed. Now, what is happening here, instead of polymerization, this is a hydrophilic IOL. When it is subjected to femtosecond laser, refractive index decreases. That's how the power was being introduced into this lens. Again, if you want, you can recreate it. This is one such study by Nick Mammalis. Now, what is this phase wrapped structure? Now, when an entire lens was subjected to femtosecond laser, the changes you can see here, change in refractive index of 0.001 translated into just 0.4 diopter. So they thought about a phase wrapped structure. What this just means is the entire power was given in one area, surface, and that was changed. Now that they could manage up to 3.3 diopters with accurate prediction. There's something that's exciting. Maybe it can come into the market. Two other very exciting things. We have a lot of IOLs, but each one behaves differently in the eye. So if we can find out whether how these things behave inside the eye, that would be great. So these two investigations to find out how an IOL, another 2-3 slides, I'll be covering. How an IOL behaves in a certain eye, if we can find out for that particular patient, we can avoid. Last part, the electronic IOLs. Here, the first electronic IOL was where the stimulus came from periphery of the IOL. How the thing was used, okay, I don't know, but it changed the center. There's no report available for this. But now what is happening is, uses sunlight, and this is an autofocus lens. The energy is from the sunlight, so that as soon as you look at near, it just focuses for the near, and when you look at periphery, it focuses for the periphery. This is the advantage we have with this. Ideal lens, of course, difficult. This talk was first given in 2012. All the slides have changed except this. This has been my, sorry. That has been my dream. An IOL that can give something like a Google Glass. That had been my dream. Thank you once again for the opportunity.
Sir, you're using presbyopic IOLs?
Presbyopic, yes. None of these IOLs.
Okay. So mainly multifocal IOLs?
Trifocals and EDOFs.
Okay. And sir, if a patient comes to you vis-a-vis these IOL surgeries with when you compare with presbyopic LASIK, what is your take on it?
My experience with presbyopic LASIK has been very less. In fact, I stopped doing after 4 or 5 cases.
Okay.
They are thrilled in the first 1 or 2 years, and after that, the problems start. They come back with all sorts of problems. In fact, even one of the ophthalmic surgeon who got it done also is not. So presbyopic laser refractive surgery, I would like to avoid. And whom am I offering it to? Someone with lesser work, say housewives or homemakers or one of those kind of things, and only in the hyperopes. That's all. That is the only place where I am doing a, if at all, if I am forced to. As regards presbyopic IOLs, very comfortable, but then even with the most modern IOL, strictly warn the patient about the dysphotopsia. This is what I am doing. Thank you.
Thank you, Dr. Ellen. And we will now move on to our next speaker, Dr. Sujata Das. Dr. Sujata Das needs no introduction. Has done phenomenal work in the field of cornea and eye banking and heads the cornea services of LBPI Bhubaneswar. I think you're logged on, Dr. Sujata. Over to you for your talk on microsporidial keratitis. Welcome, Dr. Sujata.
So good afternoon. Thanks to Professor T.T. Namrata Vanati for including in your Foundation Day. So I'll be talking on microsporidia, which is no more a new bug, because 10 years back, microsporidia was new bug, but I think Pythium has Can you see my slide? Can you see slide?
Yes, ma'am, it's visible.
Visible? Yeah, I don't know. Something came here. Cannot. I'm not able to hear. Is it visible?
Ma'am, your internet connection looks little weak.
Okay. Just 1 minute. Because I'm not able to share also. Stop share. Is it better now?
Not yet visible. The
Is
first
it
slide has
better?
appeared. Yes.
Yes. Okay. So I was saying new bug because Pythium has taken bug now. So before HIV it was rare, but now say this occurs in immunocompetent also. First case was reported as stromal keratitis in 1973. Initially, it was reported in patient, how now immunocompetent patients worldwide, not only restricted to any country or any state, and the prevalence it varies from 0% to 50%. A source of ocular infection is not very clear, and it occurs more commonly the next. If you see this in 2001 and more than 150 cases reported in different places, I feel the infection is more commonly reported because we are more aware of the infection. We reported this as a cause of epidemic keratoconjunctivitis because it happens more in rainy season, and that too every year. Most of the infection are keratoconjunctivitis. Stromal keratitis is also not very uncommon compared to fungal bacterial alleviated, but currently we see a lot of stromal keratitis again due to increased awareness of the ophthalmologist. Most common lesion, few coarse, minute raised lesion. Precipitate around 30 years. And first visit, because of the surface lesion, most of the time you're not able to. You can see limbitis and endotheliitis in few cases. Diagnosis, it is mild. The first common differential diagnosis is adenoviral keratoconjunctivitis, and chlamydia, thigason will come later. So adenoviral keratoconjunctivitis will have bilateral, mostly bilateral, whereas microsporidia will be unilateral, and it is polymorphic lesion. And the ages, if you see, these are microsporidia, whereas in adenoviral, there will be hairs surrounding the lesion. Another mostly bilateral, again waxing and waning pores, and will come like years. They will not acute symptom, and intermittent cornea is clear. Stromal keratitis, which is not conjunctivitis, in the more differential diagnosis is herpes stromal keratitis. They present again waxing and waning pores. Sometimes in scar or diagnosis, but I think ophthalmologists should start suspecting negative and not responding to standard medical therapy, especially if you are treating as herpes keratitis. If they are not responding, we should think that. As I told, they may present as a non-suppurative or suppurative to start with. And this which is you see, and we've noticed the keratic precipitate in contrast beyond region, and most of the time they don't respond to medical management. The for stromal keratitis has been reported as trauma, topical steroid, contact lens use, and patient with HIV. But I think at this point of time, we should not give focus on HIV because it happens in immunocompetent. So surface water, domestic animal contact has been reported. These are keratoconjunctivitis patient. Final visual acuity is more than 20/30 in 80% cases. We saw in July, August, September, October the highest incidence. Most common complaint is tearing and redness. The patients usually get all today when it is proven that it is self-limiting and lubricant can help. If you see the diagnostic criteria, KOH 99% and gram 90%. Keratic precipitate in 20%, normally seen after and time for resolution and surface lesion resolves again is 2 to 18 days. So outcome is good in keratoconjunctivitis. Most of the time in keratoconjunctivitis are enough. If not, then confocal myopia can help, or KOH or is sufficient to diagnose. Transition 11 long back to diagnose species. Histopathology, if you are doing is corneal keratoplasty. The treatment has been reported many things, but I think only lubricant is enough. If there are a lot of things, you can do epithelial debridement. And surgical upper stromal keratitis, nothing else except surgery. 1 or 2 reports are there where PHMB has been reported. Keratoplasty, penetrating keratoplasty is advisable because proven penetrate intact descendant membrane, there is a high risk of recurrence. So to conclude, keratitis may occur more commonly than believed. Ocular infection in immunocompetent patient, although rare, but it should be suspected in stromal keratitis. And debridement essence clinical resolution of keratoconjunctivitis, and in absence of medical therapy, early surgical treatment can be planned for stromal keratitis. A diagnosis, simple microscopic evaluation of corneal scraping can diagnose microscopic keratitis. Thank you.
Thank you, ma'am, for the wonderful lecture. Microsporidia, I have learned about diagnosing treatment such cases at LBP Bhubaneswar only under your guidance. Thank you for that. After this, we move on to our next lecture by Dr. Saurabh Patwardhan. Sir is an RPC alumni. When I joined as a SR, he used to be the most sought after SRs at RPC. And I think he may not be knowing, but his notes for SRC exam are still after RP Center. He, I think, took surgical training of resident to a different level using YouTube, Facebook, live streaming, everything. And he has invented an iTorik Patwardhan app that you must have known about that. With this, I welcome sir to RPC from the RPC family, and I request you to deliver your lecture.
Thank you, Praful. And it's a great pleasure to be back in RP Center in front of my colleagues. I wouldn't call juniors because they taught me so many things, and I'm happy that I can still continue to teach what I learned from RPC to my students. So my lecture, actually it's a video. So as Praful mentioned that I started my YouTube channel maybe 7-8 years back, but I started actively doing it 3-4 years. And my aim is basically for the young surgeons who wants to get more tips. So in a practical way, easier way to tell them how to do things. So this is one of the videos which I will. Hello friends, this is Dr. Saurabh Patwadan and I'll be talking about how to put IOL in the bag in case of post-capsular rupture. We already have 3-piece IOLs and non-foldable IOLs which are meant to be placed in sulcus in case of PC rent. Then why do you really want to take the risk? But there are some situations like in case of premium IOL like multifocal EDOF or customized IOL like Toric, we have to place the IOL in the bag to have the best outcome. Now, in such situation, what to do? So let's start thinking about how to put an IOL in the bag when there is a posterior capsular rupture. The first important thing to analyze is the status of the antihyaloid and vitreous, whether there is only posterior capsular rupture with antihyaloid intact or if there is a vitreous prolapse. If the antihyaloid is intact, then we have to place the IOL in the bag directly if the posterior capsular support is adequate, and it's much easy to do. But in case of vitreous prolapse, when there is an antihyaloid rupture, we have to remove the vitreous using vitrectomy, and then we have to place the IOL in the bag with adequate support. This is very important because if we don't remove the vitreous completely, sometimes this is done by some surgeons. OVD is pushed so that the vitreous goes back or sideways and then IOL is placed. But many times this vitreous starts prolapsing. Also, it may get engaged with the incision and that leads to further decentration of the IOL and posterior segment problems. Now, what are the cases where I can place the PCL in the bag? So let's think about what is the real support for the IOL in the bag. IOL requires support at the haptic and the optic haptic junction. So if you see the central part of the posterior capsule is actually not critical for the IOL support in the bag. So in situation 1 where there is a horizontal posterior capsular rupture, we can place the IOL perpendicular to it. Same way for vertical, we can just rotate the IOLs 90 degree to that and can have adequate support for the IOL. In case of a small peripheral posterior capsular rupture, which is less than say 4 millimeters, we can easily place the IOL, which is away from this area and can achieve good support. Now, in case of large peripheral rent, many times on table we use OVD and try to place the IOL in the bag, but it may later shift to one side because of either gravity or capsular fibrosis. So we don't want that decentration. Now, in case of large peripheral PC rupture, there is another option of doing optic capture. For this, the 3-piece IOLs are best suited, but in certain types of IOL designs, this can also be done based on case-to-case basis. So that can also be one of the options to place the optic in the bag while the haptics lie in the sulcus. Now, the plate haptic designs and the 3-piece IOLs are difficult to put in the bag because they have some kind of spring action which stretches the posterior capsule. So it is not impossible, but I think it is difficult to place it in the bag. But these other designs are quite suitable for in the bag placement if there is adequate posterior capsular support. So let's look at some of the cases. So this is a case where there is a very small posterior capsular rent at the end of the surgery. So I'm trying to convert it into posterior CCC. Now just look at the mistakes that I'm doing. Now here you can see that antihyaloid is already bulging and I'm trying to do the PCC, which I could do very easily, but you can see the antihyaloid is bulging. So always keep the antihyaloid pressed back using good OVD. Whenever it becomes more convex, there is a chance of antihyaloid rupture. As you can see, it happened here. And once the vitreous prolapse is there, we have to take care that we remove the vitreous completely. So use the highest vitrectomy cut rate as possible. Here also we have to make sure that we don't enlarge the existing posterior capsular rent because we want to place the IOL in the bag. So make sure the opening of the cutter is away from the edge of the posterior capsular rent, and then you release the vitreous from all the incision. While releasing the vitreous from the incision, you have to go under the incision like this and then start cutting, and then you have to cut all the strands which are going into the incision. Make sure that the posterior capsular rent margins are not cut. So, and keep looking at these margins, you will be able to see where the strands are going like this. You can see the strands are going towards one incision. As you cut, the posterior capsular rent, actually the size kind of decreases slowly. So once you achieve complete vitreous clearance from the bag, you have to check if there are any strands going into the incision. Once you are sure that there are no vitreous strands which are going into the incision,
then we can place the IOL in the bag. I prefer to use 2% HPMC as the OVD because it is easy to wash after I implant the IOL. I prefer to enlarge the incision little bit so that there is no resistance to the cartridge, because many times after vitrectomy, there is little bit of hypotony. So I don't want more vitreous prolapse. I always place another instrument under the IOL while I'm inserting, and I try to open the IOL in the anterior chamber itself. And then using either Sinskey dialer or Hoogland hook, I very gently manipulate the haptics in the bag, making sure that the IOL goes in the bag very gently and it settles over the remaining posterior capsule, as you can see here. And then I will wash the methyl cellulose, which is 2% HPMC, using just passive wash using the BSS. So this is my preferred technique. Also, before I close, I want to check if there are any vitreous strands there, because that we have to be 100% sure to have good visual outcomes in these cases. So I think that has to be carefully looked into. Now let's look at the second case here. This is actually a post-polar cataract, and there was a rent which happened at the last step. And as you can see, I was just checking for any vitreous prolapse, which was not there. So in this case, I didn't try for a PCCC, which is not must in all cases. And we can simply place the IOL in the bag. As you can see, the posterior capsule has good support here. The rent has not extended to the periphery. And then again, as I mentioned earlier, I use just passive visco wash for the methyl cellulose, and which works very well. If you want to use active aspiration, make sure the bottle height is very low. Now look at this case. The posterior capsule opened up out of nowhere, and I wanted to show you how to check for the intact antihyaloid. As you can see, as I inject the OVD, it doesn't go into the vitreous. That indicates that the antihyaloid is intact. Thank you so much for watching the video.
Thank you so much. Thank you.
So that was a very, you have to think about it, because when you do these kind of surgeries. So you also mentioned about peripheral rents, and you're putting the, so have you ever encountered extension of the rent when you are doing these maneuvers?
Yeah, so that's why I mentioned about the use of viscoelastic and how to wash it. And also when you put the IOL in the bag, before that you have to open it in the anterior chamber and then slowly nudge it to the position where you want, and then push the haptics inside. So all these tips are very important. You have to maintain the anterior chamber. There should not be shallowing as well as deepening of the anterior chamber all throughout these manuals. So that will make it safer.
So any vitreous conditions like liquefaction and myopes, where you would say, or operated VR surgeries, that this should not be done?
Yeah, correct. So I think these are the exceptions where you have to, of course, not use the IOL in the bag unless there is a strong posterior capsulorhexis, which you can do.
Thank you, sir.
Yeah, thank you so much.
Thank you, sir. So next speaker we have, I'm honored privileged to call my sir, Professor Amit Gupta. He is a professor in Advanced Eye Center, Vijay Chandigarh. He has the specialty in femtosecond laser assisted corneal transplantation. He has very wide experience on this corneal refractive surgeries. And this afternoon, he's going to share with us on intraoperative biometry in cataract surgery. Sir, please, over to you.
Thank you, Dr. Lomi. It's good to see you, and I'm thankful to Professor Dayal and Dr. Namrata and for inviting me here for my talk. So this is about the intraoperative biometry in cataract surgery. So we know that, with swept source OCT, and we have the optical coherence tomography, and we have the ray tracing, all these principles. So the accuracy of biometry has undergone a sea change, especially in eyes which are for routine cataract surgery. A publication which was in Canadian Journal of Ophthalmology in 2021. So what they did was they studied the predictive accuracy of intraoperative biometry, and they compared with different formulae. And they showed us that we are now hitting a 0.25 diopters of postoperative refraction in up to 50% of the patients, and up to 80% in the refractory outcome was about 0.5 diopters, and almost 92% of the eyes were within 0.75 diopters. Now we are there yet, I think, as far as this is concerned, especially because the intraocular lenses themselves are available in increments of 0.5 diopters. The same was with the predictive error in these patients. So especially with the Barrett's and the Hill RBF formula, the predictive error was quite narrow. So that showed us that the outcomes are pretty good in these eyes. But as clinicians, biometric challenges are thrown our way. This includes post-refractive eyes which are very steep or very flat, post-penetrating keratoplasty, very long or very short axial lens, dense cataracts. So all these are scenarios which we often encounter, and it has been seen that the accuracy of biometry may come down to less than 50% of the eyes which achieve a 0.5 diopters. So this is where the intraoperative biometry can help us. So I want to talk about the ORA. What is the ORA? It's the OptiWave refractive analysis. And this uses a real-time biometer and real-time refractometer. And it also takes into account the anterior and posterior corneal curvature, the surgeon's induced astigmatism. All these factors are taken into account when it tells us the intraocular lens power intraoperatively. What we have to do first is to pressurize the eye. That is to bring it to its physiological state and also to throw back the posterior capsule to the proper position. In this particular case, for example, post-refractive surgery cataract, now we can see axial length which is close to 29 millimeters and a cornea which is very flat, almost 40. So this is quite a nightmare when it comes to calculation, which intraocular lens power should we implant, and various formulae can lead to different types of readings for the IOL power. So this is where the device like the intraoperative biometer can really help us. So we can see that there is, the Myers of the barometer are there. These are the Purkinje images, and we have to center on that. And this is the reticle on the right side. This is what the surgeon sees through the eyepiece. Our patient is asked to look at a red light, and we have to get the right focus in the green range. And what it does, it tells us the intraocular lens power and the estimated residual refractive error if we implant that particular lens. So in this case, with intraocular lens power varying from 8.5 to 10 diopters, we ended up putting in an 11.5 diopters, and patient was plano after the surgery. And there are several publications, and they have shown that the outcome of cataract surgery in patients, especially with the prior myopic refractive surgery, they're very, very good with the intraoperative biometry. Another surgical nightmare is a severe hypermetropia. The small eyes and the flat gaze, and they are prone to a variety of errors. And if I talk about our own PJ study of 65 eyes, this was carried out by Professor Jain, and they showed, and this perhaps one of the largest series of the intraoperative biometry in hyperopic eyes, and it showed a mean prediction error of just 0.1 with plus minus 0.5 diopters, and 95.4% of the eyes were within 1 diopter of the predicted refractive outcome. Another situation is the post-radial keratotomy. So we can see the scarred eyes, multiple cuts, and the posterior curvature undergoes a change. So this is how it differs from a LASIK surgery, that it's much more challenging. And if we look at an EKR map, so all the keratometric values are just like scattered all over. So again, it makes it so much more difficult for us to reach the conclusion which K reading to use in these patients. And our own study in PGI on 20 eyes, and we showed that when we used intraoperative biometry, the residual refractive error was just 0.63 versus 1.13 and 3.1 with Barrett, Truque, and Haggis L. And I think all of us are using basically these in these kind of eyes. And what was good about it was that the IOL power prediction accuracy was 66% of the eyes were within 0.5 diopters. And this was compared to 52% of the eyes which were actually more than 2 diopters with the Hague-Gisel formula. Another situation is post-OPK eyes. Now we can see that, in these, we had 14 eyes in the study, and we used the intraoperative biometry, and 80% of our eyes were within 0.5 diopters. This is versus 37.5% using other biometric formulas. The MRSC in these eyes was -6 diopters preoperative versus 0.5 diopters, 0.25 diopters postoperative. Toric IOLs, I'm not going to go into it in details, but this is, it gives real time. It tells us whether rotation is required or not. So it will say, okay, rotate counterclockwise 5 degrees, 10 degrees. So this is all a real time thing which is happening. And it has really helped us, especially in some of the IOLs which were mal rotated, and to set them right. And so, like it says, no rotation required. This means that the refractive error predicted is within 0.5 diopters. So to conclude, intraoperative aberrometry is an invaluable tool for improving the outcomes of cataract surgery in complicated eyes. It's important to remember that ORA still relies on keratometric values fed by the surgeon, and this may be a source of errors in these complex scenarios. So what I mean is that when we talk about feeding in a K, do we at times take the total corneal refractive power, or we use the EKR? That is your skill, and that is your knowledge that you have to bring into play when we are feeding in these patients. Some precautions that we have to use a viscoelastic with appropriate approved refractive index, so that because that is what calibrates the machine. No viscoelastic on the surface. We are very fond of putting HPMC or something on the surface. Don't do that. Avoid pressure by eye speculum. Patient should be comfortable. Explain to the patient no squeezing motions. They will all interfere with the proper reading. Patient should be able to fixate, which is usually a visual acuity better than 20/50. That is what is recommended by the company. And no retinal pathology, because that can interfere with the readings. K, as I said, is fed by the surgeon, and the ELP, as usual, eludes us. Thank you so much. Any questions?
Thank you, Dr. Amit. I think the intraoperative aberrometry is a very useful tool to refine our refractive outcomes, especially in difficult scenarios as the ones you elaborated. But we still have difficulties when you're looking at cataract surgery post-lamellar, like post-DALS, post-DZEX. The OptiWave refractive analysis itself, I think it's sometimes outside the purview of these, and it does give us a warning that it is not an approved device, especially for RK patients. I think operated RK, the ORA is not an approved.
No, we have the option which is pre-fed, that is the ORA which is less than 8 cuts or more than 8 cuts.
So
but
when you do more than 8, like the picture which you showed, then ORA is not a reliable one. So which is something we need to counsel our patients on when we do take them on.
We do that, as usual in these patients.
Fantastic talk. Thank you very much, Amit. I think we will move on, and we have with us Dr. Somshila Murthy now, and Somshila Murthy needs no introduction. Welcome, Dr. Soms, and she's a renowned cornea and uveitis person with fantastic work and academics in these two fields. She heads the cornea service of LEPI Hyderabad, and she is now going to talk to us on peripheral ulcerative keratitis recent updates. Over to you, Dr. Somshila.
Thank you so much, Vanity. I hope I'm audible. It's very unfortunate that I can't join you there physically. It looks wonderful over there. I have already sent my presentation, so I request the organizers to play it, please. Thank you.
I would like to start by thanking the organizers and also to share my deep honor in being part of the 55th RPC Annual Foundation Day celebrations. I'm Dr. Somshila Murthy, and I'm going to be talking about peripheral ulcerative keratitis recent updates. So what is PUK and what are PUK-like lesions? Any condition that causes peripheral ulceration of the cornea. The list may include many diseases such as marginal keratitis or PUK-like lesions, which can be caused by infectious or inflammatory or other conditions, can be classified under this category. So classically, when you say PUK, you in your mind think about the immune-mediated conditions. These are rare and they're caused obviously by inflammatory etiology. The etiology can be an ocular disease alone, or it can be in association with systemic immune-mediated disorders. And they do have a high association with connective tissue disorders, nearly half of them. The ocular manifestation sometimes may precede the disease. So what are the clinical features of all PUK? Usually it's unilateral, rarely bilateral. The classical picture is a crescentric perilimbal corneal ulcer, which has subepithelial infiltrate. It spreads circumferentially due to the limbal vasculature, and sometimes it may spread centrally. In addition, there is thinning along with the spread. The contiguous conjunctiva, episclera, or sclera can also be involved. Anterior chamber reaction can be present. If the inflammation is severe, you can also have hypopyon. As in this picture, you can see that the patient has pigment, which is due to anterior chamber reaction. This is yet another case of peripheral ulcerative keratitis, which presented bilaterally. It is usually rare. The panel of pictures at the top show the ulceration and thinning in the peripheral cornea in the right eye, as well as the below panel is for the left eye. And this is the patient after undergoing treatment, and finally the condition resolved with the help of tissue adhesive for the right eye and patch graft for the left. So what is the relevance of this condition in a general ophthalmology clinic? It's immune mediated. It is rare, but it's not infrequent. Murins ulcer, we are very likely to see these cases in our clinic, but the PUK-like lesions, we will definitely be seeing at least some or the other kind of mimicker of PUK. Those PUKs which will be associated with rheumatoid arthritis or granulomatosis polyangiitis, these are very rare, but we should at least be able to recognize and refer these conditions to the appropriate specialist. So to manage these conditions is to locate the etiology. The etiology can be local or systemic. Local can be infectious versus immune mediated, and so can systemic. These top two examples are of local conditions, the first one being an extensive Murins ulcer in the top picture, and the second one being a case of bacterial infection with a peripheral corneal ulceration. The local causes can be any bacteria, fungus, parasite, etc. The non-infectious causes could be due to trauma, repeated trauma, or due to the lids and lashes, especially if they're misdirected, could be neurogenic cause, rarely neoplastic, and of course the autoimmune category, local autoimmune category includes Murins ulcer. On the other hand, systemic causes can be immune mediated, can be dermatological. Certain systemic infections can lead to PUK. So let's look more closely at the local causes of PUK or PUK-like picture. This can be caused by various infections, and the non-infectious etiology can be caused by trauma, lids, lashes, conditions, neurologic, as well as local autoimmune. The systemic causes, when you look at them, these are the top 5 conditions which can be associated with PUK. And certain dermatological disorders, certain other systemic infections and inflammatory bowel disease can also be associated with PUK. So how do you come to the diagnosis? You have to have a thorough clinical history, figure out the systemic disease if present, and also what is the therapy that the patient is undergoing, based on which we can order our systemic investigations or maybe refer the patient to a rheumatologist or the physician. So if it is a local condition, as in the patient has nothing systemic, but what you see is in the eye only, you might want to also include microbiological investigation, which may involve corneal scraping to rule out infectious etiology. For example, the patient that you can see in the picture on your top is a case of HSV necrotizing keratitis, whereas the one below, where you can see a very white-looking keratic appearance, is a case of OSS. PUK-like conditions can also mimic PUK. We need to rule them out. These can be easily managed by the local ophthalmologist, which includes contact lens-related sterile infiltrates, a PUK-like picture, which includes peripheral marginal corneal degeneration, and also OSSN, as I showed in the previous slide. So contact lens-induced peripheral sterile infiltrates can sometimes look like the first stage of PUK, but history of contact lens usage will differentiate these two conditions. On the other hand, PMCD is a peripheral thinning disorder or an ectatic disorder. There is no ulceration, but you might sometimes see a sort of a scarring in the periphery, and you might be confused that the patient may have had a previous PUK, but the ectasia with the clear cornea in the periphery is the giveaway of the basic condition. And you can have a variant of OSSN, as is seen in this picture above. Luckily, these are very rare, but missed. So this is the earlier example of a perforated bacterial corneal ulcer and the earlier example of an advanced Murins ulcer. Look how different they are. But if the patient with the panel on the right side comes to you in the beginning, you might mistake this for infection, as had happened in this particular patient presented to us. Another important differential diagnosis that we should not miss is keratoconjunctivitis sicca. And these patients that give way, of course, is a very dry ocular surface. You can see the left eye showing the extremely dry ocular surface, which is on the right side of the panel. And the right eye of this particular patient actually shows thinning in the nasal part, which is due to lack of tear, lack of wetting, and not an inflammatory disorder. So this is the panels of the left eye after fluorescein stain, showing that there is pickup of fluorescein stain on the surface. Another condition with very dry, severe dry eye includes Sjogren syndrome with perforation, and this is one such example which should not be confused with PUK. A very mild condition in terms of the gravity is Terrien's marginal degeneration. Sometimes these are inflammatory or have low-grade inflammation, but are self-limiting, and these conditions can also be mistaken for PUK. So ultimately, what's the management? Is it an infection? We need to differentiate between the two, because the mainstay of therapy for immune-mediated conditions is steroids, and we don't want to use that for an infectious etiology. So we need to differentiate between various infections which mimic PUK, that include HSV, that include acanthamoeba. And we need to differentiate if it's a PUK due to immune origin. Is it local immune, such as murines, or is it a systemic immune PUK? For example, the picture on your right side shows a patient with scleritis in a patient with rheumatoid arthritis. So management ultimately depends on the etiology. For local conditions, we can, especially murines ulcer, we do conjunctival resection, glue application, and topical intensive steroids. Whereas for systemic conditions, we use immunomodulators in younger patients and bilateral disease. And prior to any surgery, intravenous methylprednisolone or cyclophosphamide is recommended. Thank you once again for giving me this opportunity.
Thank you, ma'am, for the wonderful lecture. We move on to our next speaker, Dr. V. Sujit Nana. Sir is one of our illustrious alumni. He, beyond RPC, he has the experience of training from multiple universities in USA. That includes University of Helsinki, University of Miami, and Bhaskar Palmer Eye Institute. Sir's primary focus is on femto laser cataract surgeries, lamellar surgeries. I request sir, I welcome sir to this RPC Foundation Day and request sir to start his presentation. In the meantime, I would like to request the panelists and the audience if they have any questions related to PUK to Dr. Somshila. Dr. Soms, Dr. Somshila. Okay, Sujit.
A very good afternoon. At the outset, let me thank my professors, Professor Titial, Professor Namrata Madam, Dr. Vanati, for giving me this opportunity to be here after so many years. Like I'm visiting RPC probably after almost 10, 12 years. So thank you for this great opportunity. As part of this program, I'll be talking on the corneal collagen cross-linking, the current status, as well as the future directions, an overview of the cross-linking procedure. So as you all know, this is the landmark paper that was published in 2003 by Wolensek et al., after which this particular procedure kick-started in corneal practice. So they included a lot of keratoconus patients of all a wide age range and a wide K value range involving moderate to advanced keratoconus. The protocol which they followed was later called as Dresden protocol, which is still the standard protocol, which involved epithelial removal of the central 7 to 8 millimeter diameter 0.1% riboflavin with 20% dextran as a photosensitizer, following which 30 minutes of UVA rays were used for irradiation. And what happened after that was a photochemical reaction with the help of the photosensitizer riboflavin. After the UVA irradiation, the riboflavin radicals and the oxygen radicals that are formed, two pathways, one aerobic and anaerobic pathway, that causes the radicals to form the new covalent bonds, so strengthening the collagen fibers. The stiffening effect of the collagen were demonstrated using the porcine cornea, and similar effect was also demonstrated in vivo in the human corneas after the procedure. So the observed biological effects were seen at around 250 to 280 microns of the anterior stroma with new intrafibrillary and interfibrillary cross-linkings between the corneal collagens. And the clinical effect which we saw was the demarcation line at around 250 microns. And there was improved uncorrected and discorrected visual acuity with almost 2 diopters change in the Kmax. There was 93% of success rate that was proposed for this particular procedure. And as was skeptical, there was no effect on the limbal stem cells. There was no effect on the tear films. The corneal sensitivity was not affected, but obviously there was thinning of the cornea, which started immediately after the procedure and was seen for a few months in the follow-up period also. So apart from the success rate, there were also complications that were reported, from the sterile infiltrates to infectious keratitis due to the contact lens involvement post-operative period. And also many of them were the endothelial problems, the endothelial toxicity because of the procedure. And the failure rate also, the first report about the failure rate also came from the same group, Theo Seeler, who reported almost 7.6% of the failure rate for the procedure, especially in cases with very high keratometry value. Anyway, with the with the success rate of the procedure, the indications got extended to other ectatic disorders like post refractive surgery, ectasias, PMDs, and other, and also in combination with other treatment protocols for the laser refractive surgery, and non-ectatic indications like the corneal infections and the painful bullous keratopathies. Anyway, the challenging situations was the thinner cornea, because all these conditions we are dealing with the thinner cornea, and also we are making the cornea more thin after the procedure. And with the fear of the endothelial burns, this was one area that was focused on in refining the procedure. So the modifying, the recent, the research papers that came after that actually worked on modifying 3 factors. One is the riboflavin concentration and increasing the penetration of the same, increasing the temporary thickness of the cornea during the procedure, and also influencing the UV fluence so that there is less endothelial toxicity. A lot of new protocols and procedures, protocols of the procedures came into existence after that. One of the few important ones were the epithelium on procedure, accelerated cross-linking, pulse cross-linking, and some chemical enhancers to increase the riboflavin penetration, interferosis cross-linking, and so on. Going into details of all this is beyond the scope of this talk. And some of the important one, as I told, one was epithelium on procedure, but it didn't show much results as was expected. Why we thought of epithelium on procedure was due to the increased pain and the discomfort after the procedure, risk of an exposed nude cornea surface for a longer time. But it was the role of oxygen was understood later on, because the epithelium, when the epithelium is there, even if you push the riboflavin into the stroma, the availability of the oxygen for the cross-linking was less. The epithelium eats away most of the oxygen that is being provided. So even in the pulsed cross-linking also, the results were not as good as the epithelium off procedure. Then the other cross-linking protocols that came were the accelerated protocols. Many accelerated protocols came into existence, but I think the more popular ones are the 10-minute one and the 5 minutes one. And with the it was based on Bunsen-Roscoe law, delivering a constant energy by reducing the time and increasing the power. The efficacy of the accelerated protocols were questioned. but many meta-analysis and randomized control trials came showing that it is at par with the standard protocol. But clinically, it is at par, but biomechanically, it is less than the standard protocol. Also, how to manage the thinner corneas with hypoosmolar riboflavin for temporary thickening using the contact lens use cross-linking, and other debridement patterns were all tried. And but these were all poor predictability were the main problems for these protocols. So the one that came into existence and is now in vogue is the sub 400 protocol by Hafesi et al. In this, they are controlling the fluence and fluence to a level based on the initial pachymetry. So they are keeping a safe level of almost 70 microns pre-Descemet membrane, and the fluence is adjusted so that they have a nomogram. So you look at the thickness at what we are working and see that it starts at almost 200 micron thickness. The fluence they are adjusting, and they are doing it at even 200 microns thickness of the cornea. So that is one individualized cross-linking. Then what is customized cross-linking? In customized cross-linking, what they are doing is it's a cone-centered approach. Like different parts of the keratoconus, conic cornea is getting different energy, and it's like a tailor-made approach in either in a concentric pattern or in the pattern which is shown here, sector-based pattern. The other two names you might have heard is CXL Plus, coined by the Chimenez in 2011, which includes the adjuvant therapies to the cross-linking, which offers stability and functional vision in the keratoconus. Extra is it is used along with the LASIK and the PRK and SMILE in the borderline cases of the refractive surgery. So this was one combined protocol.
Dr.
That
Sujit?
is, yeah.
Sujit,
Yes, 2 minutes. Combined protocol, one was the Athens protocol, which topo-guided PRK along with the customized with the cross-linking. A similar protocol with enhanced Athens protocol with customized as well as the topo-guided PRK. I'll skip it to the one more slide. So what next? Three things that is being worked up most. One is Pixel, PAC CXL, and the slit lamp CXL. The Pixel is photorefractive intrastromal cross-linking, which is only used for the refractive purpose. It's the cross-linking used for a refractive indication in low myopic conditions. PAC CXL for the infective keratitis, mainly for the bacterial keratitis. Fungal, it is still not very consistent. It's not giving very consistent results. And the slit lamp CXL, which is being introduced and CE approved nowadays. So the RiboCare kit along with it, it's like an all-purpose riboflavin for all type of cases. In this paper, the trends in research on cross-linking from 2001 to 2020 shows that there was almost 2,000 publications in last 20 years, like almost 100 publications a year on this particular topic. So in summary, it's the cross-linking remains a mainstay of arresting the progressive ectasia. Indications are expanding, newer protocols are being tried out, and long-term results are showing good results. I thank you very much for this opportunity. Thank you.
Thank you, Dr. Sujit, for the wonderful talk. I think we'll have the questions at the end of the session. We now go on to our next speaker, Dr. Vinita Gupta. She's here physically. And Dr. Vinita Gupta is a faculty at AIIMS Rishikesh. She's going to be speaking on pearls and perils of management of strabismus in children with developmental delay.
As Dr. Benita is setting up, we can take a few questions on collagen cross-linking with Dr. Sujit. I think, Sujit, you must have done a lot of collagen cross-linking for ectasias and for other indications. What do you think is the commonest post-operative problem with collagen cross-linking which you face?
Post-operative phase is one of the most common problems that is being faced. So most of the time, I think the machines which we use may not be like nowadays we are getting a lot of low-cost machines which is being used in many hospitals. I think it's not much validated. So even we follow the norms which they have told, we see some unexpected post-operative phase and probably some unexpected endothelial toxicity also after that. Infections, personally, I had 2 or 3 cases of infection initially when I used to give them post-operative contact lens. Nowadays, I've stopped using contact lens. I give them pad and bandage for 24 hours to 48 hours. They are more comfortable and the infection, because I feel the risk of infection is only from the contact lens. So I personally have stopped using contact lens.
Yeah. Yes, I do agree that if you're using contact lenses, then do see your patients back, and we refrain from using steroids as long as the contact lenses is on, and we start our steroids after seeing the patient perhaps 2 to 3 days later and take the contact lenses off and then start our steroids, with which we find the incidence of infectious keratitis is much lesser. And also the component of immune keratitis is something which we will need to recognize when you're doing collagen cross-linking. Thank you very much, Suchit.
Thank you.
Over to you, Vanita.
Thank you, Dr. Vanathi. At the outset, I would just like to thank all the the entire organizing team, Professor Tityal sir, Professor Namrata ma'am, for inviting me over for giving a talk at the RPC Foundation Day celebrations. The topic I'm talking about today is management of strabismus in children with development delay. And obviously, this has a lot of debatable issues which are related to it. Broadly, when we talk about developmental delay, we say it is basically when your progression through the normal predicted development phase is either halted or it is slows down or is reversed. So it may involve various skills of a person, which could be motor skills, cognitive skills, social skills, emotional skills, or a combination of all these. And there may be a variety of causes for it, which could be genetic syndromes, some environmental influences, medical conditions, or a combination of these. But most commonly, what we see when we see clinically children who are coming with developmental delays are usually broadly classified into those with autistic disorders, those with intellectual disabilities, those with attention deficit hyperactivity disorders, learning disabilities, and cerebral palsies. Now, the ocular problems, ophthalmic problems in these cases are multiple, but strabismus is quite a common condition seen in these patients. Almost 44% of the patients may have strabismus, and they have both motor problems as well as sensory issues in these cases. Besides strabismus, they have a fixation instability, they have impaired saccades and pursuit movements, and also if you look at the sensory component of binocular vision, they have a decreased fusional ability, and also there is a delay to because of the delay in the correction, this is further accentuated. And CVI, or the cortical visual impairment, is also quite common in these conditions. Now, prevalence of strabismus, if we go by each type of disorder, which we commonly see in the autism spectrum disorder, is around 13.4%. And the type of strabismus which is seen in these cases is usually infantile or childhood onset esotropias. Those with intellectual disability usually present with either infantile or childhood onset, both mainly horizontal strabismus, both exo and esotropias. As regards to ADHD, it's not there have been not many studies which have shown what is the incidence or prevalence of strabismus in ADHD. But what has been seen that most children with strabismus do have a high prevalence of ADHD. And the strabismus, which is usually again is a childhood onset strabismus in these cases, but here the preferences is for the exotropia. While those with the learning disabilities, there is no difference as compared to the age-matched normal children for that particular age. Maybe there's a slight increased prevalence of accommodated insufficiency in this case. The most commonly encountered developmental delay children which we see in our clinics is those with the cerebral palsies. Here, the prevalence of strabismus may go as high as 90%, and this correlates with the severity of the motor defect in them. And again, the infantile esotropia is the most common in them. Exotropia and esotropia are almost equal, 2:1 ratio. And pattern strabismus are less likely seen. If pattern is seen, then A pattern is more likely. And if you compare it with the normal, the ratio of the esotropia to the exotropia, if you compare it with the normal children, it is almost 2:1 as compared to 5:2 for a normal children normal population. In cerebral palsy, as I said, this is the commonest group of children who come to us. So I'll talk about the motor deficit, which are seen in cerebral palsy children. It is basically reduced and absent stereopsis.
which is usually associated with an intermittent or a manifest strabismus. There's a greater chance of improvement in these cases of binocular vision, especially in the milder forms of CP. And there may be children who are non-strabismic as well. And obviously they have good binocular vision potential. Then sensory deficits, again, the prevalence of the primary non-fixation is higher in the CP as compared to the general population by about almost 5% as compared to in the general population where it is 1%. And there have been anecdotal reports which have shown that there's spontaneous consecutive exotropia even without any intervention may develop in these children. And this is an indication that these children have a very, very poor potential for binocular vision. A special type of strabismus is also seen in patients with CP, which is basically a dyskinetic strabismus, which is actually pathognomic for CP. If we see this kind of strabismus, which is seen in roughly around 12 to 30% of the cases, primarily seen in the epithyte type of CP, and its prevalence increases the severity of the CP, the motor involvement of in the cerebral palsies. This is basically a comitant horizontal strabismus, which has an extreme variability of direction, duration, angle size. Every time we examine the child, every time we'll get different readings or different values and different types of strabismus presentations. And it is unrelated to the direction of the gaze or the fixation or the distance or the accommodative effort or the visual attention of the child. There's no periodic behavior in this. It is more prone to exodrift, and it is obviously is the worst type, is a poor prognostic feature for development of binocular vision. So the great debate in these cases is to operate or not to operate. So there are no axioms, no best practices, no golden rules. Just a sec. I think those photographs are not being projected. Just a sec. सर फोटोग्राफ्स क्यों नहीं आ रही? मेरे उसमें तो दिख रही है, प्रोजेक्शन पे नहीं आ रही. मेरे इस पे दिख रही है. हाँ, नहीं आ रही है. नहीं मेरे इस पे आ रही है. आप इसको मेरे वाले को लगाओ. Sorry for the.
Dr. Vinita, can we go on to the next talk, and then once your problem is set in, I think we can. Yes. So
photographs are estimate top में.
मीटर शो कर दो.
प्रोजेक्शन में नहीं आ रही, वैसे तो दिखा रहा है, स्लाइड्स में दिखा रहा है, प्रोजेक्शन में नहीं आ रही, प्रोजेक्शन में नहीं आ रही.
I think whatever you download the PPT in your desktop,
This one.
you can translate to there.
Display में जा. ये display.
I think we'll go on to the next speaker till this is sorted out. Yes, I now invite Dr. Vanashri Nair. She's going to be speaking on capsular excess, pearls in difficult situations.
Am I audible right now?
Yes, you're audible.
Okay, just a second. Presentation. Is my presentation visible?
yes, you are visible.
Okay. Good afternoon, everyone. First of all, I would like to thank Thank you for giving me this opportunity to present today in this 55th annual Foundation Day celebration. To begin the presentation, today I'm talking about capsulorhexis in difficult situation. As we all know that capsulorhexis is very important. A continuous curvilinear capsulorhexis is important to ensure that we have a safe phacoemulsification. A good rhexis, well centered, is important for IL placement in the bag or in the sulcus. In certain situations, we know that it is difficult to create a capsulorhexis easily. That is what I'm going to talk about today. We all know that the instruments which we commonly use are the cystotome, that is a 20 gauge bent needle, or in difficult situation, more useful will be a utrata or a microrhexis forceps and a microrhexis scissor. Now, which are the difficult situations that which we usually encounter? Most important ones are when there is a poor view, something like a poor dilating pupils, or if there is a opacity which is impeding the view. Second, a common condition is where there's an increased interlenticular pressure, something like an intumescent cataract or a Morganian cataract, where there's a lot of fluid and we do not have the support of the lens to create the rhexis. A fibrous anterior capsule again gives a difficult situation. Also, the weak zonules, somewhere like a traumatic cataract or a subluxated lens or pseudoexfoliation, where we do not have the counter force coming from the zonules to create the perfect circular rhexis. In pediatric cataracts, as we all know, the capsule is very elastic. So again, it becomes a difficult situation. So there are certain special techniques which are very useful to help us prevent radialization of the rhexis margin. And I'll talk about them as we see the video next. So first, I would like to talk about an intumescent cataract, which is a very common scenario. What happens is the cortical fibers are filled up with fluid, and that causes an increase in the interlenticular pressure. As we all know, the double rhexis technique actually helps us to prevent an argentinal flag sign or radialization of the rhexis. Here, it is important to decompress the fluid which is present in the intumescent fibers using a small gauge cannula, so that after creating a small rhexis, we, instead of cystotome, better to use a microrhexis forceps to again create a double rhexis, or even sometimes you may use a triple rhexis to safely create a capsulorhexis. Now, in this situation, it is important that we go slow and we use the grasp and regrasp technique so that the margin of the rhexis remains in control and doesn't radialize towards the periphery. Now, it is important that we go from all the directions so that we can move the rhexis edge appropriately. And it is important that we remain patient, refill the anterior chamber with the heavy OVD, and proceed ahead and complete the rhexis in a safe manner. Now, sometimes what happens, there is an intumescent cataract along with a small pupil. Here you have a double problem. So in this case, if you see, as I was trying to make the rhexis margin went under the pupillary edge. And that created a little bit of an issue. Here I refilled the anterior chamber and again tried from my left hand. Me being a left-handed surgeon, I prefer the left hand more. And at this point, I realized that the microrhexis forceps I was not able to grasp the edge well to go ahead. So here it is important that we stop and think again that how do we proceed ahead. So I went in with a Klugelin's hook and I lifted the edge of the pupil to see where the rhexis margin was ending. And under the direct visualization and bimanual technique, I could grasp the rhexis edge and then complete the rhexis. So it is important that we keep up our presence of mind. Now, sometimes what happens that the retroglow is not good because of the cortical fibers or sometimes the posterior subcapsular cataract, which may not give us a good retro illumination. And here I was almost about to complete the rhexis with my cystotome, and the capsule had crumpled up over there. But presence of mind gave me an indication that actually the rhexis was going outwards and it would have led to a radialization. So I used the little smonnier to grasp at the very edge and give a radial pull inwards, and that helped me to save this rhexis. Now, in case of pseudoexfoliation or when there are weak zonules and a small pupil, it is important that we first get a good visualization. Here I've used the malignant ring to actually give me a good view in this patient who had a hypometropia along with a pseudoexfoliation. And again, instead of the cystotome, it is better that we use the microrhexis forceps here because that will give us a better counter traction to help create the rexus well. Again, I would like to emphasize that use all the ports available and use all the directions so that the rexus is created safely and we prevent a radialization. Now, this is a special situation where you have a fibrosed anterior capsule, and sometimes the capsule is even attached to the cataract which is underneath. And in this situation, it is very important that you go slowly and you use the microrexus scissors liberally to cut and then proceed ahead slowly. In maybe you may need multiple directions to go and cut and pull with your microrexus forceps with a bimanual technique in such a way that we don't cause a sudden traction which may lead to radialization of the rexus here. And here I've injected some OVD underneath the capsule to prevent any tags that may cause a damage to the rexus over there. So again, using the scissors and the rexus forceps together, we can safely try and create a continuous rexus. That's how it gets completed over there. Lastly, it's just a case of a pediatric cataract. So in a pediatric cataract, as we all know, that it being a very elastic capsule, avoid using a cystitome and rather use a capsulorhexis forceps and try to keep the forces centripetally so that there is no radialization of the rexus. So that's about it. That ends my talk. Thank you so much for the opportunity.
Now I would like to request Dr. Talveer Sidhu to present her talk on role of lasers in glaucoma. She's a consultant in Government Medical College, Patiala, and is an illustrious RPC alumnus.
At the start, I would like to congratulate the RP Center team on organizing such a grand Foundation Day program. And I'm very grateful for this opportunity. So I'll be presenting on role of lasers in glaucoma. As we all know that laser is a coherent monochromatic light which is produced by when pumping energy is applied to a lasing medium. And the laser tissue interactions are of various different kinds depending upon the wavelengths of the lasers. Photoablation is something which breaks the chemical bonds, and it happens in lasers which have very low wavelengths, ultraviolet and excimer lasers. The visible length, the lasers, they usually have a photocoagulating effect on the tissues. And another effect that is very commonly used is photodisruption, where a ionic plasma is formed in the tissue, which breaks the tissue apart. And photovaporization is a property of the higher wavelength lasers like carbon dioxide laser. So lasers are used in glaucoma vastly and are of is of extreme importance, especially in angle closure glaucoma, where a relief of pupillary block can be done with the help of laser iridotomy, or modification of iris contour can be done with the help of laser iridoplasty, and ultimately inflow reduction can be done with the help of cyclophotocoagulation. Laser iridotomy, although looked at as a very simple procedure, but it should be meticulously planned according to what kind of patient comes to you. ND-YAG Q-switched laser 1064 nanometer is used, which is a photodisruptive laser. Indications are mainly angle closure glaucoma, and contraindications are common ocular media opacities where the iris is not visible. Abraham lens is used, which is placed over the eye with the help of a coupling medium, which acts as a speculum and also fixates the eye. The selection site for laser PI is very important in terms of whether the PI has been covered with the lid or not, whether it causes some glare because of the tear film. Therefore, it should be done either at 12 o'clock, or it can be done temporally also in people who have very thick irises. The PI should be done with pre-medicating the patient with pilocarpine and applying topical anesthesia. The important thing to understand is that PI should be done in the peripheral iris rather than this. So PI should not, if it is attempted, it is important that in a single setting, not more than 3 to 4 shots should be given on the iris, and the multiple sites should not be done in one setting, which causes increased inflammation. Also, a PI that is done in extreme part of the just under the limbus might not be very effective, especially when the pupil is dilated. And post laser topical steroids and anti-glaucoma drugs are given. It's also important to note that gonioscopy must be done post PI, because sometimes you might miss other possible mechanisms of angle closure where PI might not help, like plateau iris or phacomorphic glaucoma. The complications of PI are, the common complications are IOP spikes, uveitis, and hyphema. Laser iridoplasty is another procedure which is used in plateau iris or thick irises, where you need to modify the iris contour. Modification of iris contour is done with application of a photocoagulative laser on the iris 1 millimeter away from the root of the iris. In open angle glaucomas, outflow enhancement can be done with the help of laser trabeculoplasty. Laser trabeculoplasty is of two types: argon laser trabeculoplasty, where an argon or diode laser is used with a smaller spot size but a higher energy to coagulate the trabecular meshwork, while SLT is a selective laser trabeculoplasty, where a higher spot size is used with very low energy, which does not coagulate the trabecular meshwork. The common complications being transient IOP rise or mild iris burns or anterior synechiae formation. Post ALT, usually the steroids are used, but post SLT, because very less energy is used, commonly NSAIDs have to be given for a short period of time, and continuation of anti-glaucoma drugs have to be given. In early glaucomas nowadays, SLTs are being commonly used, which can actually, where people can actually avoid medication for some time. In refractory glaucomas, laser cyclophotocoagulation has been used as a transscleral or a non-contact or endoscopic procedure very successfully in non-seeing eyes. But recently, minimal laser has also been used in seeing eyes. So usually cyclophotocoagulation was done in refractory glaucomas and painful blind eyes in a transscleral manner, where multiple spots, like 6 to 7 applications per quadrant, were done over 270° or 360°, sparing the 3 or 9 o'clock positions using a G probe. The endoscopic diode cyclophotocoagulation has also been used in neovascular glaucomas, non-seeing eyes, as well as nowadays papers have been published where endoscopic diode cyclophotocoagulation is being done in seeing eyes, minimal cyclophotocoagulation of ciliary processes, so that the intraocular pressure decreases post-operatively. Nowadays, micropulse diode laser is also being used in seeing eyes, where there is minimal destruction and minimal inflammation of the ciliary body. In post-operative treatment also, there are multiple laser procedures. After trabeculectomy, lasers can be used for suturolysis. Intraoperatively, they can be used for sclerostomy. If there is an overfiltering bleb, it can be used for bleb reductions also. So in post-glaucoma management, suturolysis or Nd:YAG laser can be used for retracting the iris from a blocked ostium. So thank you very much. This is a very vast topic which could not be covered very extensively in a very short time, but this is the overview of the entire topic. Thank you so much.
Thank you, Dr. Talvi. That was an excellent overview of the topic. And I now invite Dr. Praful. Okay, I think there is a change of plan.
I'll take my lecture later on, but Dr. Tushar Grover, he has, I think, joined us. I would like to invite Dr. Tushar.
Hello, good afternoon. Thank you, Dr. Praful, and thank you so much for having me. It's an absolute honor for me to be a part of the RPC Foundation Day conference. So I'll be sharing my presentation. Is my screen visible?
Yes, Dr. Tushar.
Okay, perfect. Thank you. So I'll be talking about inflammation and hyperosmolarity in dry eye, more about inflammation and less about hyperosmolarity. 1 second, I'm not able to change my slides. Hang on, I'm not able to, yeah, okay. So we know that over the last decade or so, there has been a considerable increase in our understanding of dry eye, and that has led to a renewed scientific interest in the disease, and a lot more interest in terms of research as well. So what we know now is that dry eye is a vicious cycle. It's a multifactorial disorder, and any of these etiological agents that you see in the outer circle can lead an individual into this vicious cycle, and then the cycle self-perpetuates even if you've removed the original offending cause. And as you can see, inflammation and hyperosmolarity are important components of this vicious cycle. So to begin with, talking about inflammation, how does inflammation play a role? So any stress to the ocular surface, whether it is due to extrinsic factors or intrinsic factors, leads to this whole cycle of production of cytokines, maturation of antigen presenting cells, and finally the transformation of the T cells into CD4 plus T helper cells, which cause further damage to the ocular surface. And again, this cycle continues. And this leads to destruction of tissues. This leads to neurosecretory block, which we commonly see in dry eye. Now, how do we diagnose inflammation? The first thing that's important to do when you're evaluating any dry eye patient is to document the symptoms. So there are a whole range of validated questionnaires that are available. Any of these can be used to document symptoms because that's important. Then go ahead with examining the patient, starting from the face, moving on to the lids, then to the conjunctiva and the corneal surface. The tear breakup time, Schirmer test, and the ocular surface staining are all extremely important. Then you also have specialized tests available like the inflammatory, which detects the MMP9 levels, and that helps you identify the presence of inflammation and accordingly decide if you want to include steroids and other anti-inflammatory agents in your treatment regimen. Now, how do you treat inflammation in dry eye? There are a whole range of medications that are available that have been proven to be helpful in various papers. One of the most common medication that we use for treatment of inflammation in dry eye is cyclosporin A. This has been shown to improve dry eye signs and symptoms over the long term. And this has to be used long term as it has been shown to provide a progressive improvement in signs and symptoms of dry eye. Now, steroids are helpful as well. Obviously, we do want to give them in tapering doses for a short period of time because we do know the long-term implications and the long-term harmful effects that come with the use of steroids. Tetracycline derivatives, omega-3 fatty acids have also been found to have a role, particularly in meibomian gland dysfunction. And there are other promising therapies that are available as well, such as chloroquine drops. We looked at them. We had done a study where we treated 70 patients with chloroquine versus 70 controls who had only lubricants. And we did see a significant improvement in objective signs and symptoms in the chloroquine group. We do, of course, need more long-term data. There are other drugs like lifitegrast, which are also available. Again, we do need more long-term data, but this has also been found to be effective. Now, just going through some case examples. So because due to the time, I'll just quickly go through them. So this, as you can see, is a case of severe dry eye. The Schirmer's here is about 1. Schirmer's without anesthetic is 1. And so in these kinds of patients, extremely important to investigate and find out the underlying cause as well. So this particular patient was found to be having primary Sjogren syndrome. And such a case, you would want to treat with anti-inflammatory therapy as well. Of course, you do need to coordinate with your rheumatologist and start them on HCQs apart from giving topical steroids and topical cyclosporin. The second case, again, a case of severe dry eye. Schirmer's here is 2 without anesthetic. And this was a patient who was found to have rheumatoid arthritis. So this was secondary Sjogren's and the patient developing dry eye secondary to that. So here again, apart from giving a course of topical steroids, giving long-term type topical cyclosporin, you should coordinate with the rheumatologist and start an oral immunosuppressive as well. So it's extremely important to look for the cause in these kinds of cases. Scleral lenses are also extremely helpful with patients who have severe dry eye. This, on the other hand, is a patient who you can see that the Schirmer's here is not too bad. The ocular surface as such is not too bad, but you can see the lipid layer thickness is quite low. The tear breakup time is quite low. And this patient was extremely symptomatic. So here, it's more important to treat the meibomian gland dysfunction that exists. And there, things like warm compresses, lid massage, azithromycin are extremely important. An oral course of doxycycline or azithromycin are extremely useful. and also modalities like LipiFlow, which you don't have to offer them right away, but on subsequent visits, if the patient does persist to have symptoms, they can be offered to the patient as well. Moving on to hyperosmolarity. So what happens in severe dry eye is that due to the reduced quantity of fluid in the tear film, or due to the faster evaporation, the tear film ends up having a very high osmolarity, and that leads to cell damage and death and reduced function of the ocular surface epithelial cells. So this can be treated with hypotonic solutions like sodium hyaluronate, but it has been found that these effects are transient, and therefore, the role of compatible solutes has been stressed upon. So some lubricants do have these compatible solutes in them, which help maintain the osmotic balance. So you do have the protective shield that is formed by the CMC, by the lubricant, and then these osmoprotectants help maintain the epithelial cells because of restoring the osmotic balance that is disturbed in dry eye. So these drops have also been found to improve objective signs as well as symptoms when they are given long term, because they help improve the osmotic balance in dry eye. So just to summarize, dry eye is a vicious cycle. It's a heterogeneous disorder of the ocular surface where inflammation and hyperosmolarity are both extremely important components, and cyclosporin has been found to be extremely effective in long-term use and has also been found to be safe. Then you have additional modalities which are available, and there's constantly new research going on in dry eye and newer modalities and newer medications coming out, and we do see a lot of promise in the future as well. Pure osmolarity is another important mechanism in the evolution of dry eye, and that again needs to be treated apart from just the lubricant with osmoprotectants with compatible solutes that help maintain the ocular surface epithelial cells. So thank you, and thank you so much again for having me. It's my honor to be a part of this meet. Thank you.
Thank you, Dr. Tushar. That was a wonderful talk. Moving on to next speaker. Now we have Dr. Diwang Angmo. I invite her. She is the consultant associate professor at Dr. RP Center AIMS. She will be speaking on early diagnosis of progression in glaucoma. Dr. Diwang, please.
A very good evening to everyone. Thank you, Lomi, for the kind introduction. So coming on to why is monitoring of progression important? So the definition of glaucoma itself shows that it is a chronic progressive optic neuropathy. Therefore, early diagnosis of cases and altering the target IOP appropriately will prevent this irreversible blindness. So if you look at the Olmsted County study, which was basically a span of over the 45 years in which POAG patients were studied, the incidence of glaucoma did not change over this 45 years. The 20-year probability and population incidence of blindness due to POAG in at least one eye, in fact, reduced from 25.8% to 13.5%. However, 15% of the patients diagnosed recently still progress to blindness. And this is because mainly due to the late diagnosis and our incomplete understanding of glaucoma. So the early ideal test are the ones that distinguish test variability from the progression per se. They should be sensitive to subtle changes, and they should be minimal test-retest variability. However, we should take into account confounding factors like physiological variation over time and age-related neuronal loss, which has to happen. If you look into perimetry, we have either event-based analysis or trend-based analysis. The event-based analysis is a follow-up measurement that exceeds a pre-established threshold for change from baseline. It identifies a gradual or an acute event, and it is susceptible to the effect of outliers. Whereas on the other hand, we have the trend-based analysis, which is actually a slope of measured parameter over time. It is less sensitive to measurement variability. The rate of progression may be extrapolated from time to event predictions, the requirement for a large number of tests for reliability, and a prior assumption of a linear rate of structural loss, which might not lead to or which might not be applicable to all the eyes. So example of a trend-based analysis is the visual field index. Retinal fiber layer loss, that is the RNFL loss, is the earliest change that happens in glaucoma. And in a cross-sectional study, it was seen that there is a negative correlation of age with respect to the average RNFL thickness. So as the age increases, the average RNFL thickness decreases. And in the longitudinal study, it was shown that there is a reduction of 0.52 microns per year rate of age-related loss. And higher the baseline RNFL values, the higher the rate of decline. So if you look into automated perimetry, to diagnose glaucoma, we follow the Anderson's criteria, and to detect progression, we need to have at least 3 visual fields and have a visual field defect in the Durham's area. So we can either have a new defect, a deepening of a defect, or an enlargement of a defect. Out of these, deepening of the defect is the most common that we see in progressing patients, followed by enlargement of the defect, and then thereafter newer defects, which are less common to happen. So if you look at patients of POAG suspects and ocular hypertension, it is very important to see this fluctuating scotoma in the Durham's area, which needs a close review, because if these are there, these are the patients who are likely to progress. And if we intervene, or if we alter our management and take corrective steps, and again remeasure or alter our target IOP, we can prevent the patients to progress at an early stage. So if you look at this is the glaucoma progression analysis chart. So if at the top you see is the baseline exams of basically the baseline visual fields. At the middle, we see the visual field index plot, which is basically a trend-based analysis of the patient's overall visual field history. So this is the plot and this is the bar, and this bar is actually depicts the patient's visual field. So if you look at the white area, is basically the visual field that has lost. The dotted area shows that the visual is likely to be lost, and the hashed area is actually the patient's present visual field that the patient has. At the bottom, we have the current visual field summary, which is basically the complete report of the current visual field, including the visual field index, the mean deviation, the pattern deviation, the pattern standard deviation. And we have at the bottom, we have the glaucoma progression analysis alert message that indicates whether it is statistically significant deterioration on the consecutive tests. So this is how the GPA alert looks like, and this is the chart that shows. So the GPA alert criteria says that if the deterioration from the baseline at p less than 5% is there will be an open triangle. If the deterioration at the same location on 2 consecutive tests is there will be a half open triangle, and if the deterioration is there at the same location on 3 consecutive tests, it will be a solid triangle. So if there is a half open triangle, the GPA alerts you saying that it is a likely progression, and if it's a full solid triangle, the GPA alerts you saying that it is possible progression. So we should have at least 6 visual fields in the first 2 years to have enough fields to look for progression, to overcome learning curve, to create a baseline, and to assess the rate of progression. And in glaucoma, as has been taught to us, is said that we should have 1 test of structure and 1 test of function for diagnosis as well as progression. If we combine these 2 tests, the sensitivity increases to nearly 60%. However, only a single test will give you a sensitivity of 13%. So if you look at this HRT overview analysis chart, we can see that over the years, as the patient is progressing, we can see the red areas, which shows that there is a neuronal rim thinning, and corresponding GPA that shows a glaucoma progression. For early patients, OCT can also be used, which also shows a color-coded progression map. So in this, we have 4. We can see that there are 2 baseline examinations followed by the 3rd exam. In the 3rd exam, you can see that there's a yellow change in the superior RNFL area, and the yellow means that it is a possible progression. And in the 4th exam, we can see a slightly red defect that has come, which shows that there is a likely progression. So OCT is also a good tool in cases of early glaucomas. So next is the ganglion cell analysis. So ganglion cell is more sensitive to the OCT armamentarium, and again this is color coded, wherein red means that there is ganglion cell loss, and as we follow the patient and the patient is progressing, the red area increases, suggested that the patient is progressing. So if you look onto the risk factors for progression, the most important is the older age and IOP fluctuations. Apart from this, higher patients taking increased glaucoma medications, patients on a longer follow-up, and systemic risk factors like diabetes and hypertension are the risk factors for progression. So this was a study done from a center.
Is going to begin in hallway, I guess.
Yeah. So I would like to so this is basically a study done from our center, wherein we see that the yellow graph shows patients who have a fluctuating IOP versus the green graph, which shows the patients who have stable IOP. So patients who have stable IOP, that is fluctuation less than 2 mm, they are less likely to progress, whereas the patients who have progressed show a more than 4 millimeters of mercury of fluctuation. This shows the importance how higher IOP is an important cause for progression. So at the end, I would like to say that we can prevent this glaucoma related irreversible blindness by actually educating the public and doing opportunistic screening, for which early diagnosis can be done and a lower target IOP can be set at the beginning, and objective progression assessment should be used, and an early management should be done. Thank you.
Thank you, Devang. I think you have another talk, another session. Right, right. Okay. Thank you so much. We now have another young dynamic faculty from RPC, Dr. Praful Kumar Maharana, and he's going to be talking about something very interesting, Teenan's patch graph.
Good afternoon, everyone. Myself, Dr. Praful Maharana, and my primary interest is corneal surgery. So I'll be discussing about Teenan's patch graft. Teenan's tissue, we all know about this because at some stage of our career, we have done ECC or RD surgery or squint surgery. It's basically a fibrovascular tissue, and the anterior Teenan's, that is anterior to equator, it has some properties like it contains abundant collagen that helps in healing and some tectonic strength. So that allows us to use it as an alternative to multi-layered AMG or tissue adhesive and bandage contact lens or corneal patch graft in cases of corneal perforation, scleral melting, post-graft melting, or neurotrophic ulcer. My experience of Teenan's patch graft is primarily in cases of corneal perforation, small corneal perforation, neurotrophic ulcer, and corneal fistula. Most of the cases that I've done is in cases of corneal fistula. So corneal fistula is a little bit rare entity, as you can see in this picture. Although the cornea appears healed, and there is a black spot and you stain, you can see this wound is, this area is leaking. So this is what is a corneal fistula. And if you see this intraoperative picture, OCT picture, you can see there is a connection between anterior chamber and the external surface of the cornea with a thin layer of epithelium covering it. This is what is a classical corneal fistula looks like. This is the surgical video of Teenan's patch graft. Basically, the technique involves measure the, I think the video is not running. So you have to measure the defect size. You have to measure this defect size. The video is not running. I don't know why. It's not moving. So I can just explain this because of shortest of time, I'm not going to wait for this. So you measure the size of the defect. Isolating the Teenan's tissue is quite easy. Do a limited peritomy and separate the Teenan's tissue from conjunctival surface as well as episcleral surface, and take a size which is 1 mm more than the area of defect and suture it to the fistula or the perforation site. If time permits, I'll show this video through my laptop. So this is the end result. You can see this was the case of fistula, and now the Teenan's tissue is well sutured over it. So I'm not going to do the details of this paper. So this is the paper where we describe this technique for the first time in cases of corneal fistula. Subsequent to this, we reported the same technique in 7 cases of corneal fistula in British Journal of Ophthalmology. Subsequently, Dr. Namita Sharma published a series of 31 cases. So these are the few cases that I have done. And this image gives me immense pleasure because classically I teach my resident that don't attempt this in corneal perforation more than 3 mm, but one of my SRC did it in a case of 5/5 corneal ulceration and sent this picture to me, and with the message that this can be done in large perforation also. But I would still advise you should do it only in cases of small perforation. So far I have done this technique in around 36 eyes. Almost all cases the healing was complete by 6 to 8 weeks. In one eye there was leak. In the video is not running, but if you can appreciate, this was the area from where aqueous is leaking, so that had to be resutured on next day one post-op. Other than that,
However, there are certain limitations. As you can see in this picture, it induces a lot of vascularization. Why this happens, we are still working on it. We don't know exact cause why tendons tissue induces so much vascularization. The second issue is while doing surgery, it's often difficult to bury the sutures, and the other complications like leak, rise in IOP, and also it's an opaque tissue. So if you want to do a visual rehabilitation procedure, you have to do a subsequent keratoplasty. So the take home message, it is an effective alternative. I would not say this is the procedure to go for in the first instance. However, if you don't have a multi-layered AMG or iBank setup, or you don't have the access to cyanoacrylate glue, then you can use this technique. So if time is there, can I run my video? As I said in the beginning, if this tissue, isko connect karo. Tendon's tissue has some tectonic strength, but it is not as good as your cyanoacrylate glue. So if you have a large surface like 5 by 4 mm, then you should not be doing this, because there will definitely ectasia of the graft and it won't hold. The other alternatives, you can combine this with glue BCL. Put the tendon's graft in the center and apply glue BCL. But she did it, and luckily that graft survived. I don't know. I think you can consider it if they are non-seeing eyes and they are blind eyes, then you could probably consider them. But then you would, as he rightly pointed out, you might have to add on anti-glaucoma medications for them. But if they are seeing eyes, a perforation 5 mm is not an indication for putting a cyanoacrylate glue. So you should use a tissue patch for these. Are biological patches indicated? Okay, so this is the surgical video. It's just a 1 minute video. So as you can see, there was leak in this case. So first you measure the defect size. Remember, the size that is apparent on exterior is not exact size. It's almost 1 or 1.5 mm above that. So this is the peritomy that you often do in most of your cases. You separate the superficial layer of conjunctiva and then isolate this tendon tissue by using blunt dissection, and you can take a chunk of it. No need to suture the donor tissue. You can simply oppose the two surfaces of conjunctiva, and there won't be any need for glue or suture. This is how a tendon's tissue is isolated. You can place it over the sides of the defect, and you can trim the edges as per the requirement. So this is how you close the donor site. It's very easy. No need of any glue or suture for that. So you remove all the epithelial debris. Why is it running so slow? So this is the point. You have to create a pocket using a crescent, and then you can tuck the graft in and put suture. I think this is it. Thank you very much.
Okay, thank you, Dr. Praful. That was a very interesting video and very lovely, very nicely you have shown it. Coming to the next speaker, we have this is the final speaker. We have Dr. Ashwini. Currently he is a consultant at Ecos Hospital, Dharampur, and he is an ex RPC alumni, a very dynamic and a very great surgeon. He will be speaking on pediatric refraction.
Fine, good afternoon to all my respected teachers on the dais. It's a great opportunity, and thanks to Professor J. Titial sir and organizing team. In pediatric refraction, it is not only to prescribe glass to a child, but to reach to the point of refraction and doing retinoscopy, and according to the visual need, prescribe glasses and appropriate frame, and motivating them to use glass regularly and follow. All things are important. What are the challenges according in these pediatric refractions are the childs are uncooperative. There is a low reliability on vision assessment. If not treated well, then chances of amblyopia, and parent and child both have low motivation and loss of interest. We need to divide the child into different categories because the visual need is different for different childs. For a newborn child, he wants to see his mother's face. beyond that, he has no interest. So in a child with school going, he needs to stick the blackboard. So things like visual need, normal range and amblyopia, emmetropization and symptoms are very important. The symptom that we need to know is when they bring the child, what is the symptoms the mother complaining, what the child is seeing closer to the object, a child squeezes his eye, or poor school performance, headache or squint, or any history of low birth weight. All these contribute to the functional vision. Where to make the child sit? You cannot make a child sit on his ideally on a table and do a refraction. Best place is mother's lap, and let mother occlude the eye. The visual acuity assessment in non-verbal children are very difficult. So tests like Taylor's acuity and vanishing Cardiff test are necessary. Sensory evaluation is also necessary in such cases. Cycloplegic refraction is a must because child have strong accommodation. To get rid of accommodation, strong cycloplegics like atropine should be used. Different category of childs can be used different dilating drops, but for proper cycloplegic atropine should be used. Use some other stuff for dilation because nothing breaks down the trust of a child that we have built so far quicker than putting a dilation drop by ourselves. The errors of inadequate cycloplegia are like less hyperopia and more myopia. There are autorefractometers, but gold standard is retinoscopy because autorefractometer, if properly not cycloplegic action is there, it can induce proximal convergence. This is a consensus guideline. There are many consensus guidelines from AO and different consensus guidelines. This is a consensus guideline published in IJO by Rohit Saxena et al. So this is the minimum refractive correction that to be prescribed in infant and young children in Indian scenario. There is a high AC by A ratio also when there is a deviation for near and distance by more than 10 to 15 prism diopter. AC by A ratio should be taken into consideration. And the bifocal glasses should be executive bifocal, consider bisecting the pupillary axis, not like the above picture. The follow-up of accommodative exotropia are very important because to see whether they are amblyopia and refraction and the residual near deviation is there or not. The intermittent exotropia, any refractive error resulting in reduced vision to be corrected to improve vision, and stimulating accommodative convergence in exotropias. Now coming to few examples, a 6-year-old child with +1 diopter of refractive error, all these refractions are on cycloplegic. What should we do? It's a 6-year child, so we will not prescribe it with +1 diopter. But if this child is symptomatic, we'll prescribe with a lesser power like +0.5 diopter of. If a 6-month-old child with +3.5 diopter on retinoscopy with no family history or no strabismus, we should not prescribe because as according to guideline, plus up to 4 +4 diopter we can consider as normal. If it is a 4-year-old child, we can give +2 diopter, will undercorrect and leave rest 1.5 diopter for the child to accommodate. If it is same scenario with 2-year-old child with recent onset of esotropia, we'll give full prescription like +3.5 diopter. So with another example, 2-year-old child with +2 sphere and -1 cylinder on retinoscopy with no squint and nothing, will not prescribe this child. But if a child with 6-year-old, will prescribe the child because child is about to go to school. But the spherical will reduce a little bit. 2.5-year-old child with -2 myopia, though it is normal, but the child goes too close to the TV every time. So child in his own world needs glasses. So we prescribe a -1.5 diopter in such cases. A 4-year-old child with this of astigmatism, though it is less astigmatism, but it is an oblique astigmatism. So in oblique astigmatism tends to cause more chances of amblyopia. So we will prescribe. With childs like Down syndrome where there are poor accommodation, so we'll prescribe the child though they have less spherical power. We'll prescribe in such cases of syndromic childs. There are few case scenarios, 2 or 3 more case scenarios, like a 14-month-old child with bilateral lens aspiration done with atropine. This is a retinoscopy. So in such cases, this is a 14-month-old child. So after deducting for distance, then it will be, and there is patient is aphakic, so there is no need to correct for cycloplegic, and converting it into spherical equivalent, this comes to plus 17 diopter, and for near it is plus 2 diopter sphere should be added, and final pressure should be like plus 19. So it is a 14-month-old child. He does not look for far distance. That's why we'll give only spherical power. But this same child which comes with 3-year-old child, we need to give a with plus 2 near art with similar method, because the child is start to give executive bifocal glasses. This is a 4-year-old child with frequent rubbing of eye, refraction done on a tropicamide, and this is the retinoscopy. But we cannot rely and give refraction with such tropicamide. We need to give a strong cycloplegic like atropine, and after cycloplegic atropine, the retinoscopy comes out to be like this. So in such scenarios, we need to correct for distance and for the atropine, and the final prescription comes like this. The manual refraction is a talent we should not lose. Thank you all, and whatever little I know, all credit goes to my alma mater.
Thank you, Dr. Ashwini. And Dr. Vinita, would you like to come and complete your presentation? Yeah.
So I'll just continue from where I had stopped. So the great debate about operating in the children with developmental delay about the stressness management is there are no best practices, there are no golden rules for that. And we should not be just pushed into one corner by the pushers' expectations. Pushers could be the family members of the child, the teachers who are training them, the rehabilitation team, who are actually looking for all types of enhancement of all performances, whether they're social, mental, physical, as well as looking for a cosmetic alignment. So don't use evidence-biased medicine in these cases, because this is actually faith-based. Because the cure for us is not the same what the parents are expecting. Don't promise miracles and breakthroughs. Don't make them emotionally charged by giving them false hopes or dramatic miraculous breakthroughs. So issues which we have to think as doctors is, why did it happen? What is the syndromic problem behind it? Can we actually fix it? Is there fusion? Is there any potential for binocular fusion? Because if it is there, it will make our task easier. And whether we are doing just a cosmetic alignment surgery or whether doing a reconstructive surgery and are able to bring back some binocularity for the child. Then we have to deal with the anesthesia issues. There are multiple plethora of studies where the use of anesthetics in children, even for normal children, it has been said it is not very safe, especially if it is given for more than 2 hours, if it is given for more than 3 occasions, and especially if it is given less than 4 years of age. So we have to be more careful in these children, and special care since we are dealing with children who are already having some neurological problems. But this does not mean that we stop surgery and do not give them the offer of surgery if they have some potential for binocular development. And also we have the limitations of measurement in these cases because of the problems of comprehension, communications, limited participation of these children in the active sensory examination processes. And so the quality of data which we are able to collect is also limited. But as for any other case of strabismus, the factors to consider are the type of deviation, what is the type of disorder or the developmental disorder which you are dealing with, what is the binocular visual potential, what is the stability of the angle when we are going to operate, and what is the compliance issues and the parental attitudes towards the compliance and the follow-up therapies. So as for any pediatric population, refractive errors is the first thing which should be corrected. Inform the patients about the unpredictable results of the surgeries, but still stress upon the fact that we would be going ahead with the surgery if there is some potential for binocular vision. So they should be part in playing this game along with us. We are mainly doing undercorrection in most of the cases, except in Down syndromes where we're using standard tables as we use for a normal child with a normal development. And as regards to early intervention or to wait, basically once we are able to have a stable deviation, then it's best to proceed with early surgery, because obviously we are able to give them a better potential for binocularity. Till that time, if you're not able to achieve a stable deviation, we can probably use Botox. The cons, obviously, as I've already mentioned, are difficulties in measurements, the variability of the angle which is there, uncertain role of the refractive errors, and the unstable results and the compliance issues. But our role is to inform the parents about this, as well as the advantages of the surgery as regards to improvement of the binocular vision, the visual perception, and the psychospatial impact of the entire correction of the alignment. Underlying other visual disorders should also be identified and treated. And therefore, it requires the support of a lot of people as a team, which includes the educators, the psychologists, the pediatricians. We should also give data to the educators so as to rehabilitate these children by providing them the visual field data, the extent of the central vision which the child has, along with the need of what type of visual aids, low vision aids he would require, and also the suggestions for lighting and contrast for their education. As regards to Botox, there are not many studies which are evidence-based, they are mainly value-based about what time period should be repeating Botox in these cases, when to revisit, whether it is going to be cost-effective. There's not much data on it. But as I said, for cases where we're not able to do surgeries like athetoid types of CPs, diaperitic CPs, there we can use Botox, or CPs with small angle deviations. And patients, remember, in patients with hemiparesis, it is important to do an MRI in these cases because they may be having an associated homogeneous hemianopia, which is causing the exotropia and the face turn, and we are operating it, and the child will never accept that surgery, and he will again go back into exotropia. So no surgery to be done in these cases of where there is associated homogeneous hemianopias, or if there is no vision, there is an optic atrophy, there is a CVI, there is poor fixation, or there is a peripheral field which is better than the central vision. So don't operate and try to align the eyes in those cases. Dosing of surgery, as there are higher rates of overcorrection which are seen in these cases, especially in patients with various types of syndromes. So standard surgical schedules should not be adopted in these cases. And especially if the child is having ESO corrections, those cases, these high rates of overcorrections are seen. So it is usually aimed at undercorrection by 0.54 to 0.84 millimeter less for the muscle adjustment for that particular case. While if it is exotropia, we can go and do the straight correction and do the full correction. So normally it is said if it is esotropias, if the deviation is around 20 to 25 diopters, do not do anything, just give Botox. But if the deviation at the outset itself is more than 25 diopters, then probably do an undercorrection of 15 to 20%. But for exotropia, as I said, we need to do a larger surgery. So if there's a 40 PD of deviation, do a surgery for almost targeting for 50 diopters. This table just demonstrates for various syndromes how the response has been seen over the years in different studies. So in Downs, in the end, I would just say be syndrome specific. Look at the type of developmental delay which you are dealing with. In Down syndrome, use standard doses. In Williams and fetal alcohol syndrome, they have a tendency to go for exotropias, do undercorrections. In CP, also variable results have been seen. Some people tend to do undercorrection. Some people tend to do make the eyes straight. For homogeneous hemianopia, as I already mentioned, do not operate. So just to summarize in the end, there is a very, very high prevalence of strabismus in these children with developmental delay. With the exception of the dyskinetic strabismus, is specifically seen in patients with cerebral palsies. The type of strabismus is same as that for the normal children. So infantile onset esotropia is the commonest strabismus, and binocular degeneration is occurring as a sequelae to strabismus. So our target is, and we have a realistic goal in these cases, especially in cases of mild CPs, and where there is a stable deviation, we will be able to achieve some form of binocular vision potential in these cases. And this can be achieved if we do an early surgery. Hence, before deciding on your nomograms, how much correction to do, please examine them multiple times. Do MRI imaging once at least for every child, and talk to parents and teachers while dealing with these children, so as to take them into confidence that multiple surgeries may be required, since the results are less predictable, will depend on the type of specific developmental delay which the child has. Younger the child when he is presenting to us, more is the number of procedures he would require. So ultimately, what is required for you as a surgeon is to take careful consideration of the type of deviation the child has, the severity of the developmental delay which he has, and the attempts should be made, multiple attempts should be made to measure his binocular potential, so that we can, which will all help us in guiding what will be the timing of the surgery, what will be the dosage of the surgery, and what is the type of surgery, whether a bilateral resection procedure needs to be done or a uniocular resection procedure needs to be done. Thank you.
Thank you, ma'am, and sorry for that audio-visual glitch. With this, we came to the conclusion of this session. I request chairperson of the session, Professor Vanati, to conclude this session. Thank you, Dr. Praful, and thank you all. It's Hilon. Is Dr. Amit Gupta logged in? Sir is not that, but you can use Hilon. That's a good. Yeah. So I think
I don't know if the person is still logged in. You could use your Helon. It should be an optimal fill here, and the surface should be free of any viscoelastic. That's most important. You could even fill in with BSS at the end, and the company people do recommend that you learn to fill and make you adequate with BSS, because that will be closer to your aqueous if you're doing, and your imaging and your refractive outcome will be best if you do with BSS. So I always do opt to do it with BSS. Thank you all, and I really thank Freen, Vaibhav, and Dr. Sharath for being here, the audiovisual team, and thank you all for being with us in this very nice potpourri session. Thank you all.